way, but what am I clicking to advance?
How do I look, Devin?
Oh, it'll like be a pointer if I want it to.
Yeah, you move around.
Okay.
This thing?
Yeah.
And how do you go to your next slide?
So we'll open up the waiting room in about 1 minute.
Okay. So all I have to do is click and it's going to go to the next slide.
You can try it out.
Okay, do it. Okay.
Yeah.
Oh, that light is bright. I'm going to hide behind this wall.
Okay. Are they going to have presenter mode or no?
James, will we be able to do presenter mode if we want it? Okay. I don't think I need it. At least I hope. Fingers crossed.
Yeah.
Okay. All right. Okay. Just do it just in case. I don't think I have any notes, but just do it just in case. What ends up happening for me is I read from here and then I screw myself up, but I'll try my best. Okay.
And then also, if you want to point, I'm going to use the laser pointer. Use the red dot now or the sliders. So if you want to point on something, you just spin around where you want to point here.
Okay.
And then to advance, you have to.
Okay.
Make sense?
Yep.
Cool.
Okay.
Everybody, we're going to begin very shortly. You can keep all of the speaking to this or microphones. I'll pick it up.
Okay. Good morning, everyone. My name is Melita Villegas. I'm one of the cardiothoracic surgeons at the Children's Hospital of Pittsburgh, and I'm happy to welcome you to our 14th annual Neonatal and Pediatric ECLS Educational Conference. We're super excited to have you join us, even more excited to have the in-person option back to the virtual option that we've had for the last couple years. The whole agenda is jam-packed with amazing speakers from our institution and a couple invited speakers from other institutions, along with an opportunity for us to share with you our simulation experience on every single one of the days. So I hope that you guys all enjoy it. This is a large program to put on. It's 3 days long and it takes an entire village. Special thanks to Merritt Aspenleiter, who's our ECMO coordinator, who heads up a large portion of the meeting, as well as David Palmer, who's our Senior Director of ECMO and Perfusion, and every single one of our ECMO specialists, even our surgical teams, and every single one of our speakers. Big shout out and thank you. And obviously we wouldn't be able to do this without our friends from Massive Media, who are making this virtual option possible, as well as Devin Corboy for also assisting with that as well. So first, I'd like to start out with Merritt Aspenleiter, and she's going to tell us a bit about our ECMO program and overview.
Thanks. Thank you, Dr. Villegas. I'm just going to go ahead and start out with a quick overview of how our program is organized here at UPMC Children's Hospital of Pittsburgh. So I'm going to start out with a little bit of history for everybody to kind of see where we all started at Children's with our ECMO history. So we have a pretty long history of ECMO that spans over 40 years. Back in 1977, it all started when Dr. Robert Hardesty and Dr. Bartley Griffith went out to Irvine, California to visit Dr. Bob Bartlett's research lab. The original intention was to use ECMO for post-op cardiac patients. So once they went out there to visit with Dr. Bartlett, they came back, spent a little over a year in the lab here at the University of Pittsburgh, and they were ready to go clinical with ECMO. It was seen successful. However, we didn't have appropriate patient population had to be defined. We needed inclusion and exclusion criteria established. Once that was done, referrals really began to escalate for us. So we became the second institution in the United States to offer ECMO clinically. In 1983, there were only 3 centers that were regularly performing pediatric ECMO, and the University of Pittsburgh, or Children's Hospital of Pittsburgh, was one of them. The other 2 were the University of Michigan and the Medical College of Virginia. By 1986, there were 19 centers performing ECMO, and in 1989, the institution known as ELSO was born. So everybody who is familiar with ECMO is familiar with ELSO. ELSO is the kind of governing body, I guess, if you want to call it that, of ECMO. We all look to ELSO for guidelines, for inclusion criteria, they lead the way for ECMO providers, and they give us best practices and how we can support our ECMO patients the best that we possibly can. To date at Children's Hospital, we've performed over 1,500 ECMO runs with a greater than 78% ECLS survival rate. We are an ELSO Center of Excellence at the platinum level. Our program here at CHP is structured in a way that we have a kind of a blended team of people. So we're led by Dr. Melita Villegas, who you guys just saw a few minutes ago. She's our Director of Mechanical Circulatory Support. She oversees the overall operation of our ECMO department, assures training and performance, quality improvement initiatives, that makes sure we're submitting valid data to ELSO, and oversees the credentials of the other physicians that are supporting patients on ECMO. I'm the ECMO coordinator, along with the Senior Director of Perfusion and ECMO, David Palmer. We're responsible for training and supervision of the ECMO staff, maintenance of equipment, data collection, and a whole lot of other stuff. So I'm going to kind of move into the methodology that we have here at Children's. So we start off with our leadership. You just kind of saw the leadership structure of just the ECMO team, but it's not just the ECMO team that we rely on. We have sponsorship from our pediatric cardiothoracic surgeons, the critical care specialists who also care for our ECMO patients, and also the Heart and Vascular Institute from the University of Pittsburgh. Our ECMO team is kind of combined of several different specialties. Now, this refers to the people who kind of put the kids on and take care of the kids at the bedside from an ECMO standpoint. So we have ECMO specialists, which are combined of critical care RNs and respiratory therapists, perfusionists, which are all certified by the American Board of Cardiovascular Perfusion. We have ECMO RNs that are ICU RNs that are specially trained to support patients on ECMO. And we have artificial heart technicians, which are biomedical engineers that lend a hand to us when we have patients on VAD support. The equipment that we use here at Children's, we're an all Thoratec based program. We have 7 Thoratec ECMO carts, and we're Thoratec system-wide at UPMC. So if we have an increased need, or a lot of kids that need to go on ECMO, we can easily borrow from our adult counterparts to get the equipment that we need to support as many kids as we need to. We like to provide education to everybody that is supporting children on ECMO. So we follow an ELSO-based curriculum training of didactics and simulation. We offer cannulation simulation experiences throughout the year to our OR, our general surgeons, our fellows, and our ECMO team. And we can really do that anywhere that requests an ECMO simulation. The ER, the cath lab, IR, anybody that would reach out and want to do a simulation for their team of people, we're willing to go and do that for them. We host this annual ECLS symposium that you guys are all here for. We do nursing, resident, and fellow education. We're a recognized simulation center by the American Board of Cardiovascular Perfusion, and we're a satellite facility for WISER simulation. So one of the things we really like here is that we have this blended team. So we work to really build this blended team. So what exactly does that mean? So a blended team from an ECMO standpoint, for our ECMO team, we have perfusionists, nurses, and respiratory therapists. We have a blended team of ECMO cannulating surgeons. So we have CT surgeons that cannulate for ECMO, and we have general surgeons that will also lend a hand to cannulate for ECMO, and they have a shared call schedule. When we look to our staffing for our ECMO, we look to what we kind of call there are 3 different teams if you want to break it out like that. We have what we call our ECMO core team, our ECMO RNs, and our perfusion team. So our ECMO core team is responsible for 24/7 in-house ECMO coverage. So the picture here needs updated. I apologize to our new people, Kurt, Sean, and Mike. You're not in this picture yet, but we're glad to have you on board, and we'll get a new picture for next year, I promise. So this ECMO core team here is combined of 1 ECMO coordinator that's a CCP, 10 full-time ECMO specialists, and then we have 3 casual ECMO specialists. So these are the people that ELSO would refer to as primers. So they prime and initiate ECMO. One of them has to be in-house at all times. The team goals that we have for our core ECMO team is that everybody takes the ELSO Foundations course. So everybody on our core team has either taken or is currently enrolled in the ECMO Foundations course, or they will be shortly. We have, I think, 6 of our 10 people that are already certified, ELSO EAEC. And the big goal with that is to also get them the certifications for pediatrics. We have several people that already have the AMSEC CESP. I think it's 4 people. Sam, you can call me out if that's not right. I think it's 4 people that are already certified CESP. And our future goals are, once ELSO's pediatric platform is released for a foundations course and certification, we would also go ahead and have our people get credentialed for that. We're very fortunate here at UPMC Children's Hospital because we have the sponsorship of our leadership to be able to put our specialists through this course. And we kind of assume that as part of our budget so we can get everybody credentialed, because we feel it's really important for everybody to have this education when they're caring for our ECMO patients. Next, I'm going to move to talk about our perfusion team. So our perfusion team, we have 6 CCPs, all certified by the American Board of Cardiovascular Perfusion. They're mainly doing CPB in the OR for complex congenital heart cases. They do provide ECMO support for us, whether it's initiation in the OR or even on the floors if we don't have enough people to go and put a kit on. They help us with troubleshooting. They assist us with training of the core ECMO team and our ECMO RNs. They participate in simulations and any other educational offerings that we have on campus. They provide on-call support for the ECMO core team during off shifts and weekends. We also have a specialized group of ECMO RNs. So our ECMO RN team are specially trained ICU RNs that have successfully completed our in-house ELSO-based ECMO training program. They provide bedside coverage for our ECMO patients during times of an increased census. We're set up here at Children's that we could initiate ECMO hospital-wide. So you want ECMO in the cath lab, we'll come to you. You want it in IR, sure, we'll make our way down there too. The ER, yep, we'll come down there. Wherever you guys want us to come, we'll come and put somebody on ECMO. Once we get somebody on ECMO though, we like to house them in one of these 3 units, either the CICU, the NICU, or the PICU. We're set up with the personnel and equipment that we can provide ECMO in 2 separate units at one time. If we get to the point where, say, we had a CI, a NICU, and a PICU patient all on ECMO, we would have to cohort and move some things around to get the patients a little bit closer. We have a high volume center, so it was important for us to be able to do this cohorting so that we can not spread ourselves too thin and have the appropriate people taking care of the kids that are on ECMO. So some of the other things that we've done to kind of make sure our processes are as foolproof as they can be is we like to keep things what we call simple, streamlined, and safe. So some of the methodology to keeping things simple, streamlined, and safe starts with our circuits. So we have 2 circuit choices here at CHP. Again, we like to keep them simple, streamlined, and safe. We have a choice for kids under 13 kilos and 13 kilos and bigger. So they're largely the same. We use the PD Mag or Centromag pump head for the kids. The oxygenators are a little bit different, which we've had to make some adjustments, which I'm sure most people who are listening to this can relate to, with just some supply chain issues over the past year. So for our kids 13 kilos or less, we're using the AMG infant oxygenator, and then we have a 1/4 inch custom tubing pack from Medtronic. For our kids that are 13 kilos or bigger, we're using the Medtronic Nautilus oxygenator for those kids, and we have a 3/8 inch Medtronic custom tubing pack for those kids. Again, keeping in line with that simple, streamlined, and safe, we moved to our bedside ECMO management. So we like to kind of provide people with what we think of as kind of instructions for use for ECMO. So we've created a series of guidelines, checklists, cheat sheets that we can use at the bedside. They're easily accessible, either printed out and in the carts that we keep in the unit, or everything is very easy to find on our department SharePoint site. So that kind of gives a quick overview of how we like to do things here at Children's. So the big summary for our program here is we've been providing ECMO to patients at CHP for over 40 years. We aim to have processes in place that increase familiarity, they build confidence in our team members, and it creates a highly competent team for us. So that's why we like to create the tools and checklists that are easily accessible. We like to remember the 3 S's, simple, streamlined, and safe. And everything has a story. This is how we do it and why we do it this way. We don't like to have people come in and say, this is how we do it. And they say, well, why do you do it this way? Well, that's just because that's how we do it. And that's how we've always done it. We like to have a, this is why we do it. And this is why we do it. And this is what works for us. So whether you look at our circuit choices, the way we cohort our patients, the way we manage our patients, there's a story for everything. The future for our program, we want to continue to tell this story to everybody. We want to work to maintain our ELSO COE Platinum status, achieve both pediatric and adult ECMO certifications for all of our core ECMO team members. And this year, we're really going to strive to achieve ELSO endorsement for our simulation training program. So those are the big ticket items for us this year. And if anybody has any questions, you can type them in the chat. We'll give you guys a couple minutes. If not, we're going to go ahead and move on to our next speaker, which is Dr. Burhan Mahmood. Dr. Mahmood is the director of neonatal ECMO here at Children's Hospital of Pittsburgh. He is a huge asset to our ECMO team, particularly our neonates. He's one of the kindest people that I've ever met. He's always willing to talk to anybody about neonatal ECMO or really even just anything. He's delightful to talk to. We have him coming up to the podium now, and he's going to talk to you about neonatal respiratory ECMO management.
Thank you, Merit. So it looks like I have some extra time.
Yeah,
I'm very excited.
well, I do that on purpose because it usually takes you a little longer.
I know, I
Okay.
really appreciate that. Yeah, it's a lot to talk about. So I'm glad that I have some extra minutes to go over. So I'm the ECMO director in the NICU. We take care of babies with severe cardiorespiratory failure, non-cardiac or respiratory ECMO as we like to call it, who require that support. So they are managed in the NICU. Red mouse, okay. Can I use the arrows on the keyboard?
No, keyboard's not.
Oh, it's not, okay. And then just click. All right. Okay, I have no disclosures. Since its availability of ECMO for babies, this was like in the mid 70s, as you heard from Merit as well. ECMO has saved lives and helped babies with severe cardiorespiratory failure, thousands of them. And it does so by reversing systemic hypoxemia that is occurring as a consequence of the cardiac dysfunction, respiratory failure, and inability of the lungs to oxygenate blood. And this is a chest X-ray from an actual patient in the early days of our program who presented with meconium aspiration. You can see the severity of the lung disease. This baby was on extremely high toxic levels of cardiorespiratory support and not going anywhere with gas exchange. ECMO replaces function of heart and lung temporarily. That's a key word, temporarily. It's a reversible, it's a therapy for reversible disease. So if there is a condition that is not going to improve and the outcome is bleak from that standpoint, ECMO is not going to be the option in the long run. The purpose of ECMO is to ensure adequate delivery of oxygen to the whole body and stabilize the hemodynamics in these sick babies. So you can see it's the same patient. He's on ECMO now. We have these cannulas in place, and lungs are undergoing rest. So giving time for organs to heal, lungs to rest, and taking away the toxicity of the cardiorespiratory support allows the body to heal, the lungs to heal. The barotrauma is taken away, oxygen toxicity, which is causing worsening inflammation in the lung, is removed. So it's the same baby you can see 5 days later, and the whole inflammatory process in the lung is resolved with just lung rest for 5 days on ECMO support. So clearly has a lot of benefits in neonates with severe cardiorespiratory failure, and has been a forefront of therapy over the last almost 40 plus years. So if you look at the ALSO registry, that's the organization that has all the database from national and international centers. There's a decreasing use of ECMO for babies. As you can see in the last decade, less than 10% of the actual number of ECMO patients are neonates. And it's because of, we all know newer therapies that are available. Surfactant came in the 90s, nitric oxide, better ventilation equipment, and then effective management strategies. So the run-of-the-mill, cases like meconium aspiration, pulmonary hypertension, sepsis, pneumonia, hypoxemic respiratory failure, they nowadays respond very well to these conventional therapies. And our strategies are geared towards minimizing lung injury and minimizing toxicity of conventional management so these babies recover and they can avoid ECMO support. But you can see there's an increasing other diagnosis that the ALSO registry is in the process of teasing out. So centers are reporting these multi-organ, dysfunction patients who are sicker, who are requiring ECMO. They contribute, the disease process contributes to the greater morbidity and the mortality in this patient population. The ECMO runs are complicated and longer as well. I believe in the next year, ALSO is going to tease out what is involved with this other diagnosis, and that will give us a better insight. So what are the management principles of neonatal respiratory ECMO? So provide ECMO in a safe and effective way to minimize complications and improve outcomes. Babies are at high risk of complications related to ECMO support, bleeding complications, stroke, thrombosis, clots in the body. Goal of the management is to provide adequate perfusion and oxygen delivery to the tissues and organ system. That's what causes the organs to heal and get better. Also realize that each baby is different and understand the specific management nuances to optimize care. I personally and our team, look at every baby differently. For us, every baby is a new patient with the specific needs that need to be addressed. And then formulate strategies to expedite coming off ECMO. The longer you stay on ECMO, the greater the risk of complications. So measures are undertaken to try to get the baby off sooner than later. Certain cardiorespiratory criteria are available to determine what is the likelihood of a baby who's being referred for ECMO support to not respond to conventional therapy and may not survive. So traditionally, we have all these that you can see on the slide. We use oxygenation index, which takes into account the mean airway pressure, the PaO2, and the level of oxygen the baby is receiving to determine the likelihood of failing conventional therapies. And you can see an oxygen index of more than 40 is associated over a longer period of time, or even a few hours is associated with a high mortality risk. We start considering ECMO when we are reaching around 30. The conventional therapy is maximized, whether it be nitric oxide, surfactant, ventilator management, vasopressor support. And if the baby is not recovering, you don't want to mess around with it for too long, because you want to initiate ECMO when the infant is more stable. You don't want to initiate ECMO and start cannulation and the baby's heart rate is going down and now it is changing into an ECPR scenario. So a decision has to be made. Another aspect of decision making is certain exclusion criteria. As I said, ECMO is for a reversible process. So patients who have irreversible lung disease, severely hypoplastic lungs, lethal congenital chromosomal anomalies, evidence of irreversible neurologic damage, they're not good candidates to be put on ECMO. Patients who already have bleeds inside the brain, I'm talking about the neonates, the bleeding can get worse with anticoagulation on ECMO support. Size and gestation is a relative criteria. We have cannulated infants at 34 weeks and about 2 kilograms, but the smaller they are and the more preterm they are, the greater the risk of complications. And because of the size of the neck vessels, infants who are less than 2 kilograms, they may struggle with maintaining flows on ECMO, and that increases the risk of complications like hemolysis. But again, it's not an absolute criteria. There is some, research going on nowadays that can we bring it down even more. There are centers who have cannulated at 33 weeks or 1.8 kilograms with kind of mixed results. So when a call comes in, baby is coming in for ECMO, and we have a baby already in the NICU and we are considering, very important to notify our cannulating surgical team. We have a call schedule here at Children's Hospital. We immediately update them. We reach out to our perfusion team, to Merit, to our ECMO coordinator. It's very important to do that in anywhere where there's an ECMO program, to discuss urgency of cannulation and the timing of it. There have been situations where we get a call and the patient is in extremis and our ECMO team is available at the bedside. The baby lands in the NICU and is immediately cannulated. And there are situations where infant is stable, we want to try a few other things and then kind of like figure out, hey, it's not working, early is better, and we'll call the surgical team. But it's important for them to be aware that there is a patient who is potentially going to require ECMO support. Assessing the candidacy is important, and discussion with the family and documentation of that is very critical. To talk about the expected duration, why you would discontinue ECMO. Obviously, in the best case scenario, the baby has recovered, but what if not? And then talk about the risks and benefits, including mortality. And it's very important to document because bad things can happen in babies when they are sick. The ECMO disease status, hypoxemia, acidosis, puts babies at risk for the major complications. And essentially, we are worried about neuro complications like strokes and intracranial hemorrhage, which will have a very adverse outcome. ECMO is done to rule out congenital heart disease. It's not a requirement. You can put a baby on ECMO who is not doing very well, and then you can figure things out and talk to our cardiothoracic surgeons to take care of congenital heart disease. But there can be a situation where you're thinking it's a severe hypoxemia related to pulmonary hypertension, and it may turn out to be cyanotic heart disease, and you can take away all the toxicity of conventional therapy that the patient may be on. We've had a few cases like that in our history who came as an ECMO referral on maximized therapies and turned out to be anomalous veins or something else. Head ultrasound is important to rule out severe intracranial hemorrhage. If the baby already has intraparenchymal bleed, giving them heparin or putting them on ECMO will increase the risk. Maybe we need to consider not initiating ECMO in a patient like that. Ensuring working IV access, arterial access is very important. We at Children's Hospital, we do veno-arterial ECMO. We don't do veno-venous. Most of the centers nationally are using veno-arterial due to cannula issues and experience. Not everybody is able to do it. So arterial access is important to monitor hemodynamics on ECMO support, including blood pressure. Sending newborn screen, genetic metabolic studies before ECMO is initiated is important. It's part of our guidelines to do that. Sending blood for typing screen, O negative blood, or even saline primed ECMO circuit can be used for urgent cannulation. So if the baby needs to be on and blood is not available, you can go on ECMO with just a saline primed circuit. And then, yeah, the patient is going to be a little anemic, and you can always replace it with transfusion once the ECMO is initiated. Clotting studies and CBC is important to look at platelet count, clotting profile. A lot of these babies are coagulopathic, and that increases the risk of bleeding complications. So addressing that earlier on will ensure a good outcome. Resuscitation, sedation medications are important because bad things can happen during cannulation. Cannulation can be prolonged. The patient may continue to become more hypoxemic, and CPR may be required. And then heparin is what we use here for anticoagulation, which is very, very important for ECMO to run smoothly. So the baby is positioned, we cannulate the neck, the right side of the neck, well sedated, paralyzed. Very important to discuss appropriate cannula size with a cannulating surgeon. For arterial cannula, we use 8 or 10 French. For venous, 10 French, 12 French very infrequently, 10 French for venous cannula for a term baby would be more than adequate to generate adequate flows. Heparin is given at dose of 30 to 50 units. If there is a concern for some bleeding or coagulopathy, you can err on the lower side. 30 units, but typically we give 50 units per kilogram just before cannulation and at the request of our surgeon. And then once the cannulas are in, you want to ensure correct positioning by chest X-ray and by echocardiogram. You want the tip of the venous cannula to be in the right atrium, and you want to make sure the arterial cannula is in the appropriate spot. And if you are having flow issues, we use a centrifugal system, which is very preload and afterload dependent. If you are seeing high negative pressures, then we want to make sure the cannula is in the appropriate spot, and a repeat echo may be required. X-ray may give you some information, but echo will tell you a lot, and then adjustments may need to be done with our cannulating surgeon. These are 2 X-rays. One is for the VA and one is for VV, and you can see this is your tip of the venous cannula around the right atrium. This is your arterial cannula about T2, T3. This is for a veno-venous single double lumen cannula, and it's in the similar position. So X-ray will tell you all that, and then you want to make sure the endotracheal tube and lines are in the appropriate spot as well. So as I mentioned, we use the centrifugal ECMO system. It's a completely non-occlusive system. We used to use a roller pump back in the day. I personally like this system because you can tell a lot about the preload and the afterload, and you can adjust your management strategies accordingly. It moves the blood in and out of the baby by a passive fluid displacement, by vortex action. It's a spinning impeller that is rotating almost like 3000 RPMs and creates that force that generates the flow. RPMs, those rounds per minute, and the flow resistance determine the ECMO flow. And that is, as I mentioned, preload and afterload dependent. So the ECMO flows will go down if there's a decreased preload. So if the patient has a big diuresis, has an acute blood loss, or is intravascularly depleted, or the venous cannula is occluded or is kinked or something like that, or is malpositioned, the preload, the venous return will go down and the ECMO flow will automatically go down, and the pump will start alarming, and you know that there is something that needs to be addressed and needs to be evaluated. In these situations, your best friend is volume. Give fluid bolus, and that will buy you 15, 20 minutes, maybe longer, while you're trying to figure things out for the baby. And obviously, first thing would be to get an X-ray and an echocardiogram to look at the cannula, as well as look at some other areas of blood loss that may be contributing to hypovolemia. And then pump flow will go down if the afterload is increased. So the pump has to work harder. And then because it's afterload dependent, if there is more resistance to the forward flow, the flow will go down. So any kind of circuit obstruction, a clot at the end or of the arterial cannula, systemic hypertension, anything that increases the afterload against the pump will cause the flows to go down, and in severe cases, it may actually stop. And we've had a couple of cases where it did happen. Fortunately, the babies were ready to come off, but it can be abrupt and it can be quite nerve-wracking. So line pressures and RPMs are monitored continuously. Once on ECMO, we want to avoid high negative pressure. High negative pressure means more suction pressure, greater the risk of hemolysis and damage to the RBCs. When plasma-free hemoglobin comes out into the system, it is very toxic, cytotoxic. It damages the organ systems. It can make pulmonary hypertension worse. It promotes thrombosis, clots within the body of the patient, as well as cause renal injury. So you want to avoid that if possible. That's why we like at least 10 French venous cannula. If I have an 8 French venous cannula, there's a high likelihood I'll be dealing with negative pressures. And then what that means is, okay, I'm giving volume, there's nothing more I can do, cannula's in the right spot, and the patient is getting fluid overloaded, and we're not going anywhere with that. So getting a good size venous cannula, and that's why this 2 kilogram weight cutoff has been around for that reason. Avoiding high RPMs, our goal is around 3,000 RPMs. The higher the RPMs, and if you are preload wise in the negative, then the venous pressures will become more negative and the risk of hemolysis goes up. There is no need to increase flows or RPMs if there is evidence of adequate oxygen delivery and hemodynamics. So the baby's blood pressure is fine, he's making good urine output, creatinine is coming down, metabolic acidosis is resolved, and your mixed venous saturation, which is what we monitor, that's your oxygen saturation returning to the pump. If it's in the range, then there's no need to crank things up. So it's all about gentle ECMO support, just like gentle ventilation for CDH or other diseases. That's the approach we should have for ECMO management in babies as well. What are the full flows? Again, from the gentle ECMO support concept, 100 to 120 cc's per kilogram per minute. So if you have a baby who's about 3 kilograms, you're talking about 300 to 360 mLs per minute. Initially, blood products may be required, as I mentioned. Patient may be coagulopathic, and then maybe thrombocytopenic, anemic. So optimizing those parameters will be important. Hypertension is not very uncommon because of the pain from the surgery. Despite your sedation medications, patient may be on hydrocortisone, maybe on vasopressor support. So requires very close monitoring and treatment, because hypertension can lead to, especially after you have initiated heparin in a baby who's been very sick and acidotic and hypoxic, can increase the risk of intracranial strokes and intracranial bleeds. Sicker patients with severe cardiac dysfunction along with lung disease may be actually hypertensive, and you may need to provide some extra support with hydrocortisone and vasopressors initially for the day or two on ECMO support. Nitric oxide is discontinued. We put the baby on rest vent settings. What are the rest vent settings? For a baby, pressures of about 20 to 24 of PIP, PEEP of about 8 to 10. We want to keep the lungs recruited a little bit. I know I showed you that X-ray where it was completely whited out, and that happens occasionally. But you want to try to keep the lungs somewhat open. So when the time comes to come off ECMO, you don't have to do a lot to recruit the lungs. A rate of about 20 to 24, and you can provide about 21 to 30% oxygen. If the lungs are a little bit open, oxygen is a vasodilator, so it may actually help with gas exchange and lung recovery. Sometimes you have severe multiple pneumothoraces. We've had a few patients like that in our history who required to be just put on CPAP and even no pressure at all. They had the ET tube and with no connection to it. That's what it took for those air leaks to be resolved to be able to come off ECMO support. Gentle vibration, changing position, suctioning, all that is important to make sure no atelectasis is developing on ECMO. We use anti-10A levels to monitor anticoagulation in our NICU. We used to follow ACTs and PTTs, but they are very highly unreliable in neonates because of the developmental hemostasis. Anti-10A levels, they have a direct correlation to heparin dosing. So when the patient is put on ECMO, we start heparin infusion. We give the bolus, as I said, 30 to 50 units, and then we start the infusion at 24 units per kilo per hour, and then we titrate based on anti-10A levels. We have a titration table. If the levels are low, we increase 10-20%. If the levels are too high, we decrease. And the range is about 0.3 to 0.7 for our neonates. Now, if I have a baby where I'm worried about some bleeding, already has a grade 1, grade 2 intracranial, maybe I'll err on the lower side, 0.3 to 0.4. But if there's a baby who has some clots or thrombosis that is developing in the circuit and a higher level, may not be a bad idea. We follow anti-10A every 4, and then once you reach therapeutic goals, you can follow them every 6 hours. Heparin works through antithrombin 3, as you're probably aware. So antithrombin 3 is a natural anticoagulant. Heparin potentiates its activity many fold. So we do monitor that, and we want to keep it a goal of about 60 to 80%. Very common for neonates, because they're sick, they're coagulopathic, they are in multi-organ failure, to have low AT3 levels initially. So in the first 24 to 48 hours, you have to pay close attention and try to achieve your therapeutic range. A few other things about anticoagulation: diuretic and hemofiltration will remove heparin. So more heparin will be required. And you may see that you start a Lasix infusion on a baby and it's peeing out like 8 per kilo, and all of a sudden your anti-10A is drifting down. So monitoring more frequently is a good idea. Thromboelastogram studies and clotting profile are very useful because you want to identify coagulopathy early, thrombocytopenia early, and transfuse to reduce bleeding risk. Bleeding is the biggest complication we worry, especially neurologically in a neonate. Canula site bleeding can occur, so you can apply hemostatic agents before decreasing heparin. And then for severe bleeding of a surgical patients who need to have some kind of surgery, On ECMO, like congenital diaphragmatic hernia, we use antifibrinolytic agents like Amicar. We have guidelines for everything. We have guidelines which I'm going through with this talk for ECMO management, but also for anticoagulation as well, that addresses all that. Transfusion parameters, INR goal is less than 1.5. For the first 24 hours, our goal is to keep the platelet count more than 100, and then it's 80 to 100, fibrinogen more than 150, and hematocrit 30 to 35 range. So daily management goals, titrate heparin to optimize anticoagulation. We follow daily chest x-rays to assess cannula position, lung disease, endotracheal tube. Very important to be on the lookout for that. Adjusting sweep gas flow to maintain normal PCO2 levels, augment hemodynamics and oxygen delivery, optimize cardiac output and tissue oxygenation, and maintain mixed venous saturation of more than 70. So how do you interpret mixed venous saturation? So if you have a baby on ECMO and the mixed venous saturation drops down to less than 65, it either means that we are not providing enough ECMO support, there's poor oxygen delivery, or there's increased extraction, or there's a worsening disease or worsening shunt. So it can occur with low ECMO flows, anemia, low FiO2 on the ECMO system, sepsis, hyperthermia, agitation, or seizures, and you want to manage accordingly. High mixed venous saturation would mean that maybe we are overzealous with our ECMO support, so increase oxygen delivery, so reducing the flows and turning FiO2 on the pump down would be a good idea, or poor oxygen extraction because of too much sedation, muscle relaxation, or sepsis, and then resolving shunt, meaning the patient could be just getting better, and then it's time to turn the flows down and then see if the baby is ready to come off ECMO support. Hypertension, as I mentioned, is common, so make sure that it's not very infrequent, but it can happen that patient is on ECMO and somebody forgets to discontinue dopamine or epinephrine. So make sure that those vasopressors are off, hold the hydrocortisone. If the patient is fluid overloaded, early diuresis, hemofiltration, optimize sedation for agitation, and evaluate for seizures if the blood pressure is too high on ECMO. For hypertensive patient, consider volume or vasopressors, check cannula position. Hemodynamics can be assessed by urine output, perfusion, acid-base status, mixed venous saturation, and mean arterial blood pressure. If all those things are fine, then you are doing a good job on ECMO support and no need to make any changes. Evaluate pump settings, optimize ECMO flows, monitor pump pressures, as I mentioned, and avoid high flows and RPMs. Hemolysis is a big issue with centrifugal ECMO pump system, and you want to minimize it as much as possible. Poor venous return from the circuit can cause flows to become ineffective, pump may shut down. It can be from patient reasons like hypovolemia, as I mentioned, some tamponade effect from pneumothorax or effusions. It can be due to the circuit from poor catheter position, inadequate RPMs or small catheter. And give volume and increase support and evaluate the reason. Restriction of the fluid is important because babies will third space and get fluid overloaded very quickly on ECMO. Remove excess volume, start diuretic therapy, maintain acceptable hematologic parameters, monitor for infection. We don't leave babies on antibiotics unless there's a very good reason to continue. Assess for bleeding and clots in the circuit, in the baby, assess neurostatus, keep the baby comfortable. Baby's allowed to move around, they don't need to be muscle relaxed. Muscle relaxation will cause more third spacing. Prevent development of ECMO complications and keep assessing readiness to come off ECMO support. Neuro complications is the biggest thing we worry about because it's related to hypoxia, acidosis, hypertension, and anticoagulation, and puts babies at risk for something adverse. Daily head ultrasounds are done for the first 7 days on ECMO to rule out intracranial hemorrhage. If we can do it even more frequently if there's a concern for small bleeds. Head CT, it may be required at the bedside if there's a concern for especially infratentorial bleeds or cerebellar bleeds that ultrasound may not pick up. If seizures are suspected, get an EEG, initiate anticonvulsant therapy because that will affect your mixed venous saturations and hemodynamics. Optimize sedation is important. And then ECMO is stopped if there's evidence of any significant neurologic injury, and MRI brain is obtained for every baby after ECMO to get to the bottom of things as far as neuro issues are concerned. And then neurodevelopmental assessment is done before and after discharge. When it's time to wean the ECMO, we follow X-rays to assess lung inflation is adequate, ensure endotracheal tube is in a good spot, maintain adequate lung expansion, ensure adequate oxygenation and hemodynamics as the support is weaned, adjust sedation to ensure spontaneous breathing, ensure hemoglobin levels are optimized. You want to keep the crit around 35 to 40. That's how you are improving your oxygen content to be able to come off successfully off ECMO, transfuse if needed, and ensure the patient is not fluid overloaded. We go up on the vent settings, typically PIP of about 20 to 26 in that range, PEEP about 6 to 8, FiO2 up to 50%. and then see if the baby is able to maintain gas exchange as the flows are weaned to idle flows around 100 mLs per minute. For VV ECMO, we just wean off the sweep gas flow and to see if the patient is ready to come off. And these idle flows, we do a clamping trial about 100 mLs per minute, and if the baby is transiently removed from the circuit to assess capacity to maintain cardiorespiratory function when completely off extracorporeal support. Success is present when there is evidence of adequate gas exchange and oxygenation, and infant is able to maintain hemodynamic stability with the while on non-toxic cardiorespiratory support. And we can assess it clinically, and echocardiogram is very important to assess function and resolution of the pulmonary hypertension. If all that is not happening, and patient is hypertensive and is hypoxic, showing O2 lability, changes in oxygenation, then full ECMO support is initiated and infant is not ready to come off. Once the patient is off, stop the heparin. Hypertension is not uncommon after VA ECMO, so we provide support as needed. Follow post-op labs. We get a screening echo and head ultrasound after ECMO to make sure patient is continuing to get better before discharge, brain MRI, hearing screen, and follow up with neurodevelopmental and pulmonary. If the disease becomes irreversible or there's failure to wean ECMO after a long run, if there's evidence of significant neurologic injury, significant bleeding complication, irreversible multi-organ failure, ECMO is not the long-term answer for that situation, and support may need to be withdrawn. In terms of survival, it's best for neonatal respiratory patients coming off ECMO. It's about 80 to 83%. At discharge, it does go down for all categories, including the respiratory patients, so about 70%, likely because sicker patients are being treated with ECMO. Neurodevelopmental outcomes, mild to major neurodevelopmental impairment is seen in about 10 to 25% of neonatal ECMO survivors. Severe is seen in about 20%. If there is no evidence of bleed or MRI is normal, as well as normal short neurologic examination, then these patients will have a normal neurodevelopmental outcome. So to summarize, ECMO has saved lives of newborns with the most severe forms of neonatal cardiorespiratory failure, but ECMO use is decreased. Sicker patients are being put on ECMO. However, there remains a high percentage of morbidities and risks with this therapy. Efforts to manage and eliminate complications are important to ensure a favorable clinical outcome. And advancements in ECMO systems and refinements is ongoing. I was just at the ELSO meeting this last week, and there's amazing work that is going on. All right, any questions? Sorry, I had to go very fast, time constraint.
We have a couple questions that have come up in the chat.
Okay.
Let me see here. So one of the questions I did answer, so I'll just go ahead and review that, but then there are a couple that I'll have you weigh in on. So cannulation in our NICU patient population is done by either general surgeons or CT surgeons. They share a call schedule. So it really is whoever is on call for ECMO cannulation at the time that a baby needs supported on ECMO in the NICU. The other question was, do you use double lumen cannulas? We don't here at UPMC Children's Hospital of Pittsburgh. Burhan, I don't know if you want to comment on that further.
Yeah, it's something we would like to do. But again, as I mentioned, centers who have done VV ECMO with the double lumen, they're totally comfortable with whatever cannula comes out in the market. There were some cannula issues, so there were a few years where even the centers who were doing VV ECMO had to go back to VA ECMO and learn that, and they were not too thrilled about it. So the new cannula that is out, the MC3, centers are starting to use. There is some data that's going to come out shortly in the next year or two about its experience. There are some issues with it. There may be a need for like frequent echoes. The position can change. The cannula has to be in the right spot for the flows to be directed into the right ventricle. So I think that's where the folks are struggling. Not everybody. So it's a work in progress, and there is a category of patients where VV ECMO will be useful, because as you improve oxygenation to the heart, a failing heart, for example, into the lungs, then in the next day or two, the clinical situation will improve. And that's the argument we have from the centers who use purely VV ECMO, that they do see that they use it for even patients with congenital diaphragmatic hernia. Our center has traditionally always done VA, so it will be a transition for us. But maybe we'll start with some straightforward pulmonary hypertension type babies with no major cardiac dysfunction to be put on VV ECMO.
One of the other questions was regarding, do we use LivaNova centrifugal pumps? So we don't use that technology here at Children's Hospital of Pittsburgh. We're an all Thoratec fleet, so our neonates get a PediMag pump head with an AMG oxygenator and a 1/4-inch custom tubing pack. Even going further into that, Burhan, I'm going to pitch back to you, is they're asking if we see frequent issues with hemolysis with the centrifugal pumps and the infant oxygenator.
Yeah, so hemolysis is a known complication of centrifugal ECMO pump systems. When we looked at our own data, our hemolysis rates are lower than other centers nationally. When we looked at the database that was submitted to ELSO, but it's an issue, and that's why the gentle ECMO approach is the best approach. Keeping an eye on the RPMs, minimizing that. You don't want to be too low, but you want to be around 2,900 to 3,000 range, and then making sure that your cannulas are appropriate size. Because if you have smaller cannula, venous cannula, say 8 French, you are going to see hemolysis, and no matter what you do. And occasionally we've had 1 or 2 patients where we were stuck with a smaller cannula, and we had that problem. And then making sure that your cannula is in the right spot and your venous pressures are not too negative will ensure that the hemolysis will be low. So there is some degree of hemolysis. By definition, also say significant hemolysis is more than 50 level, but a level of hemolysis that is toxic to the baby, we do not see that very frequently. And then even if it does happen for some reason, we address it, and sometimes we have to do plasma exchange to remove that plasma-free hemoglobin. But paying close attention to that will bring the plasma-free hemoglobin level down. But yeah, toxicity can develop, and it's a real issue with centrifugal pump systems.
One of the other questions that has come in is regarding circuits again. Any thoughts on moving to the cardio help for our neonatal population? And we currently don't have any plans to try the cardio help. And lending further to that, there was another question about shunts in our circuit. So we don't run a shunt in our circuit, which is one of the nice things about having the smaller pump head with the small oxygenator and the 1/4-inch tubing, is we haven't had a need to use a shunt in our circuit. I know a lot of people do, but we've been fortunate here to not have to do that.
Yeah, 2 points. In our history, occasionally, infrequently, there were a few instances where we had to put a shunt in. The risk of hemolysis went up. So there was evidence of hemolysis, and we had to take those shunts out for that specific patient. The other thing, going back to the VV ECMO, the smallest cannula size is 13 French. So the size of the cannula with respect to the cannulation of the internal jugular is a concern. Most of our venous cannulas are 10 French. Occasionally we've had 12 French, 13 French is bigger than that. So I think technical reasons, the cannula design, cannulas going in and out of the market, those are the reasons that we've not been able to initiate VV ECMO. Just going back to that question earlier on. But yeah, hemolysis is an issue, and you want to be as minimalist as possible while maintaining adequate oxygen delivery and perfusion to the baby. Typical ECMO runs for our center about 5 to 6 days, 5 to 7 days. So you want to try to get the babies off during this time frame to minimize any risk of complications.
Okay, one other question that has come in is, any experience of nitric oxide to the circuit to present clotting?
No, I know new circuits are being developed with that are nitric oxide coated. We have not done it because it's not something that is advocated that we should be doing. Yeah, so we've given nitric oxide to maybe occasionally some babies to come off ECMO support who still had refractory pulmonary hypertension, but not in the circuit.
Okay, just 2 more questions. One is, do you monitor venous drainage pressure? And we do. We don't have a better bladder, but we do use a pressure transducer to monitor our venous negative pressure on the venous line. And then the last question, Burhan, is it a standard of care to use AT3 supplementation versus plasma?
Plasma would mean more volume, and AT3 requirement may not be very frequent for most of our babies. Plasma would be recommended if there's evidence of coagulopathy. So we all know FFP will have all the clotting factors, including 83. We don't know how much 83 is in a particular transfusion of FFP. So if you really want to adjust our 83 level to that range of 60 to 80, giving 50 units of 83 would be better to get in that range versus just giving volume of 10 per kilo or another volume of 10 per kilo and then having some discrepancy in the levels. Because of the presence of clotting factors in the plasma, that can affect your anticoagulation as well. You're trying to improve your anticoagulation by going up on your 83 by FFP, but at the same time, you're also giving clotting factors. So more targeted therapy would be better, like giving an 83 thrombate, or for example, if your fibrinogen is low, give cryo instead of giving the whole FFP. So we usually reserve FFP for situation where there is evidence of coagulopathy. And most of our babies, they usually need it for the first 24, 48 hours. And then once we reach a steady state, things are pretty much stable. The sicker, complicated patients are the ones with liver failure, for example. They're not making their own clotting factors. We had one patient who did not have a good outcome as expected, was disseminated HSV, who used to be on an FFP drip to maintain anticoagulation because the liver was totally shot. And it just got worse on ECMO, and then it was complete liver failure. So yeah, answer to that question.
Okay, thank you. That was the last question.
Okay.
So
Great questions. Thank you so much.
Hi, my name is Sam Brynan. I am an ECMO specialist with the core team here at Children's Hospital. I'm going to help with some of the introductions for the rest of the day. So up next, we have the role of ECMO in bronchopulmonary dysplasia by one of our neonatal attendings, Dr. John Ibrahim.
Okay. Hi, everyone. The goal of my presentation today, now that Dr. Mahmoud had touched on the importance of lung rest settings in ECMO management of acute pulmonary process, my goal is to have a thought-provoking presentation about, do bronchopulmonary dysplasia fall in the same category of acute pulmonary diseases, and would also recommendations for lung rest settings be appropriate for infants with bronchopulmonary dysplasia and chronic lung disease? We're going to go over results of a survey that we have conducted across the nation, including neonatal and pediatric intensivists, to see their perspectives too. So as you all know, bronchopulmonary dysplasia impacts about 10 to 15,000 infants per year in the US, and half of these infants are less than 1 kilogram. 25% of infants born less than 32 weeks gestation have moderate to severe PPD and develop pulmonary hypertension. More extremely premature infants less than 20 to 25 weeks are surviving with bronchopulmonary dysplasia and or without pulmonary hypertension. Now, there are several factors, including respiratory viral infections, particularly RSV, that can trigger acute decompensation in these infants with bronchopulmonary dysplasia or chronic lung disease of prematurity. In some centers, those infants remain in the NICU until discharge, while others can be transferred to the PICU or other units. So PPD and ECMO, what is the role of ECMO in infants with PPD? The ELSO neonatal respiratory guidelines used to recommend ECMO for acute reversible pulmonary disease and infants or neonates with ventilation for less than 10 to 14 days. PPD is not specifically addressed in the current guidelines. PPD management also varies among centers or among units where these babies are located, whether it's the NICU, PICU, or other units within the same institution. There also exists ambiguity between individual providers regarding their comfort with candidacy as well as strategy for ECMO management of these infants. So there are challenges. There are numerous challenges that exist regarding ECMO candidacy and management of PPD patients or infants with chronic lung disease. There is lack of clarity about ECMO inclusion and exclusion criteria. There's also the heterogeneity of the PPD phenotypes, making ventilator management a major challenge in this neonatal and infant population. The ventilator strategy can vary based on the underlying lung disease, with patients usually requiring higher support, contradicting the lung rest settings currently recommended by ELSO. There is also lack of consensus. A lack of information exists regarding neonatal and pediatric intensivist perspectives on the use of ECMO for infants with PPD. That also is, this lack of consensus is further exaggerated with the evolving definition of PPD. There's also paucity of data on infants with PPD and PPD with pulmonary hypertension diagnosis requiring ECMO. In fact, the last outcome study of infants with PPD was published more than 20 years ago. A more recent study of pediatric patients up to 18 years of age had no age stratification for baseline ventilator support, underlying cause, or complications during ECMO. There is also the emergence of new viral infections like COVID, posing further risk to the PPD population, as well as evolution of pediatric ECMO care with improved outcomes for many conditions. So let's go over the study that was recently published about outcomes of PPD patients placed on ECMO. This was an ELSO registry data query conducted across 1982 to 2018, including all pediatric patients from 2 months to 18 years of age. It included about 281 patients. The first case of bronchopulmonary dysplasia with pulmonary hypertension placed on ECMO was reported in 2004. A contemporary cohort analysis from 2004 to 2017 included about 143 patients. 128 of them had PPD and 15 had PPD with pulmonary hypertension. The study reported that the overall survival to discharge among infants and pediatric patients with bronchopulmonary dysplasia was 66%, versus PPD with pulmonary hypertension was almost 87%. So they had great outcomes. This is a graph from the study that kind of shows that starting 2004, there is increasing trend to place infants with PPD and pulmonary hypertension on ECMO, as well as increased ECMO use in this infant cohort with improved survival, as we can see from this graph. So what did we do? We did a survey and this survey was targeted to neonatal intensivists in level 4 NICUs, particularly in the Children's Hospital Neonatal Consortium, as well as pediatric intensivists in the PD ECMO group. Our goal was to assess the perspective on ECMO candidacy and management during ECLS in infants with PPD, using different case scenarios that was included in the survey. Now, for the sake of time, we're not going to go over the case scenarios. I'm going to kind of present some snapshots of the responses of the neonatologists and pediatric intensivists to the questions that were part of these case scenarios. So this is a map to show the centers that have responded to our survey. We got survey from 55 neonatologists, 20 pediatric intensivists, 2 surgeons, and 1 ECMO clinical nurse coordinator. We found significant variation in the PPD definition used across sites and ICU location. As can everyone see, even some of them, 14% of NICU and 13% of the PICU, and 20% even were unsure of the definition of PPD used in their units. And just to orient everyone, sorry, the blue bars are NICU and the orange bars are PICU. When we asked about the volume of PPD ECMO cases over the last 5 years, the majority have mentioned that they have placed about 1 to 5 cases in the last 5 years, which also brings the question of comfort with placing these babies who have an acute decompensation versus improved conventional management of these babies when they have an acute decompensation. And PPD patients can range from patients on home oxygen with pulmonary hypertension to patients with tracheostomy who require invasive support, who are on higher pressures, on higher PEEP. When we asked about if there's any kind of exclusion that will be used for PPD patients, the majority, about 27% and 30 of NICU and 30% of the PICU said that they do not exclude infants with PPD. When we asked them about the baseline support, if there was any kind of baseline support that above which they would exclude infants from cannulation and placement on ECMO, about 71% of the NICU and 47% of the PICU said that whether they have invasive or non-invasive, low, moderate, or high pressures would not exclude infants with PPD from being placed on ECMO. We then went to ask them about baseline factors that would affect ECMO candidacy. And we had, when we asked about baseline CO2, as you can see from the graph, both NICU and PICU kind of was spread all over the spectrum in regards to if baseline CO2 would affect their decision to place an infant with PPD on ECMO. Same thing applies to FiO2. However, we saw more agreement about pulmonary hypertension severity and number of pulmonary hypertension therapies, where the majority of the NICU and PICU responders said that they would agree or strongly agree that these, the baseline pulmonary hypertension severity and number of pulmonary hypertension therapies would factor in their decision to place infants with PPD on ECMO. When asked about if baseline lung injury or the pulmonary course in the NICU would affect their decision to place these infants on ECMO, as you can see, the baseline lung injury, the responses were spread all over the spectrum. There was no consensus about it, but with lung improvement, the majority of them said that if these babies had some degree of improved course during their NICU stay, that they would consider them for ECMO candidacy. Now, the last few slides were more about ECMO candidacy. The next few slides will address ECMO management of infants with PPD. And these slides have the NICU and PICU responses combined together. When we asked them about what ventilator settings do they use when they place infants with PPD on ECMO, about 40% said that they would still use lung rest settings, even if those babies have been on invasively ventilated on high peak pressures and high PEEP. When we asked them about what initial PEEP they would use for these infants with chronic lung disease, the majority of them said that they would use peak inspiratory pressure less than 25, going along with the lung rest settings, and PEEP of 10 to 12. When we asked about eye time being used during ECMO, as you can see, the responses were also spread along the spectrum from 0.35 to 1 second, even to baseline pre-ECMO. When asked about tidal volumes, though, the majority of the responders said that they would aim for tidal volumes less than 8 mL per kilo. Given that the majority of these patients can end up on ECMO with an acute respiratory decompensation secondary to a viral infection, worsening pulmonary hypertension, we asked the responders if they would continue or add pulmonary vasodilator therapy during ECMO. And as you can see, 83% of them said yes. And when we asked about what kind of pulmonary hypertension therapy they would use, you can see that the answers range from nitric oxide, sildenafil, ibuprostenol, Marinone, Bosentan, all of the therapies that we know about. When we asked them about what FiO2 threshold they would use for ECMO decannulation, we found that the responses were also spread across the spectrum, with the majority of them saying that they have no criteria. Now, we asked the responders what PCO2 would they target for PPD patients on ECMO, understanding that some of these PPD patients would be living in higher PCO2s before ECMO at baseline, whether it's in the 60s or lower 70s, as long as they have normal pH. And about 32% said that they would aim for PCO2 of similar to the baseline CO2 prior to the acute decompensation and prior to ECMO. That's, as you can see, also the results were very spread. When asked about recruitment measures to use on ECMO, 41% responded that they would use open suctioning. Some of them even said that they would use surfactant in these chronic lung disease babies, about 12%. And 49% said they would use bronchoscopy, with about 36% said that they would use hypertonic saline. So we asked the responders, if those babies do not have improved lung compliance, despite interventions, would you consider systemic steroids? And the majority of them said yes. When we asked them about if the presence of tracheostomy would affect their decision to pursue bronchoscopy for lung recruitment, the majority of them said no. However, the surprising response was when we asked them if the patient had no trach prior to ECMO, would you consider tracheostomy while on ECMO support? The answer was divided. When we asked those responders about whether in NICU and the PICU about ECMO decannulation criteria, 55% said improvement in pulmonary hypertension, 45% said wean to baseline respiratory support, 31% said improved tidal volumes on lower support, and 40% said improved ventilation per the blood gases, and 51% said improved lung compliance. We then went and asked what would be the threshold peak inspiratory pressure for ECMO decannulation, and it's very impressive. About 37% said 20 to 30 centimeter water, and 30% said baseline pre-ECMO. So we can see that the answers were divided. When we asked about the threshold PEEP for ECMO decannulation, 33% said baseline pre-ECMO, and 24% said 7 to 9, understanding that those patients pre-ECMO might be on higher peak inspiratory pressures. If they have some sort of airway malacia, they might be on a PEEP of 13 or 14. So with severe PPD, with minimal to no improvement on ECMO, would you use ECMO as a bridge to lung transplant? We can see that 57% said no, but 11% said yes, and 32% said depending on the disease process. When we asked about how long you would keep these infants on ECMO if they're not responding, we did not get a consensus. The answers range from 2 weeks to any time after discussion with the parents to until ECMO complications. So what's the conclusion? I hope by now I have kind of convinced you that we do not have consensus guidelines for management of infants with chronic lung disease when placed on ECMO. There is lack of data on PPD and PPD with pulmonary hypertension regarding ECMO utilization, indication, management, and outcomes. Neonatal and pediatric care, critical care intensivists actually struggle and differ in their approach, sometimes within the same institution. So what's next? We plan to query the ELSO database and analyze data from 1982 to current for all infants 36 weeks corrected gestational age to 1 year of age with diagnosis of bronchopulmonary dysplasia who were managed on ECMO. We plan to utilize the information from our survey and the ELSO data query to develop expert consensus recommendations for both candidacy and ECMO management for infants with PPD. Future studies should focus on the development of predictive models incorporating pre-ECMO pulmonary and other comorbidities to determine candidacy for ECMO to better counsel parents. Thank you. Questions? Okay.
We're just going to go to a quick 10-minute break. Thank you.
So we're, as soon as the screen share goes away, we should be able to start this. Yeah. When the break slide disappears for him, then you can share the screen.
Okay. So up next, we have CICU ECMO management by Dr. Juan Sanchez.
Dr. Sanchez, you should be able to start your screen share now.
Thank you very much. I will share the screen. Please let me know if you can see the screen now.
Yes, we can see your screen and we see the slides full screen as well. Thank you.
That's fantastic. Well, thank you very much. It is an honor and a pleasure to be here, and I want to thank all the committee for inviting me, even though this is not in-house, this is a virtual presentation. I will be happy to, at the end of the slides, to answer any question that might arise from this talk. This is a general topic, a broad topic. This is ECMO management in the ICU, and not in a general ICU, but in a cardiac ICU. So when we talk about cardiac ICU, there's always the same goals of treatment: ensure organ perfusion, allow myocardial recovery, and preserve neurological function, right? And this is probably the most important thing on ECMO, off ECMO, neonates, pediatrics, adults. If we take a look at the data from the ELSA over the last years, the number of cardiac cases have tremendously increased. So the cases assisted on ECPR, and even though those cases have increased a lot, we've been able to ensure survival to some extent. The question that will remain now to answer is whether the outcome, the long-term outcome of these patients will remain as good as we want. But we should try our best. And in order to succeed a cardiac ECMO run, we should make it as short as possible. And in order to make it short, the first thing that we have to do is apply common sense, but make sure that we don't have residual effects. Again, this is cardiac ECMO. This is ECMO because of myocardial dysfunction, post-operative or not, or in general dysfunction. But if we are talking about post-operative cardiac ECMO, the first rule is to rule out residual cardiac defects. Therefore, echo and cardiac catheterizations should be #1 on our list. When we talk about cardiac ECMO, obviously, we have to associate the run with a VA ECMO. And the question mark would be whether this is a peripheral approach or a central approach. And this question is pertinent, and I'll try to answer those things in a physiological manner. In order to understand what ECMO does, we need to understand the hemodynamics effects of the VA ECMO. And this is a beautiful screen, a beautiful slide that shows you the effects of a given patient that is placed for the first time on VA ECMO. If you take the slide on the right, and you have the pressure volume loop of a given heart that all of a sudden is placed on ECMO, and we subsequently increase the amount of flow on this ECMO run by a fold of 4 or 4.5, you will see here on the left side of the slide the effects that those increasing flows will have on LV volume, left atrial pressure and aortic pressure, and right atrial pressure. So if we increase the flow of ECMO, we will be able to increase the blood pressure in the aorta. And at the same time, what will happen is that we will slowly increase the LV volume. We sure decrease the RA pressure, we unload the right atrial pressure, but we slowly increase LV volume. So this is probably the most important concept to understand the hemodynamic effects of a peripheral VA ECMO run. The most deleterious effect is the LV dilation. Decreased contractility plus VA ECMO equals LV distension. There are several reasons. Most importantly is because a little bit of blood always from a peripheral VA ECMO run bypasses the circuit, ends up to the right ventricle, from the right ventricle to the lungs LA, and that blood on the left ventricle will have to face an increased afterload from the aortic cannula. On top of that, there is always a shunt from bronchial arteries and so on that will fill blood from the right to the left, contributing to the LV distension. So the most important thing is to understand those effects, right? So what happened if in this particular patient, we now put the ECMO. So normal contractility, we put the patient on ECMO from a normal contractility, normal heart, all of a sudden we cannulate the patient on peripheral ECMO, VA ECMO, and you can see that even though we maintain cardiac output, the pressure loop changes, the heart gets distended. So in order to improve this distension, decompress a little bit the heart, we can do several things. One of the things that we can do is to put inotropy. By inotropy, we could probably increase the cardiac output, but as you can see, the pressure volume curve doesn't change a lot. And what it does is the heart gets stiffer. Now we can do maybe change and put vasodilators. We decrease the afterload, and by decreasing the afterload, we decompress a little bit better the left ventricle. The ventricle doesn't get more dilated. It unloads a little bit better, but still, it's not the same heart as it was before the ECMO cannulation. Now, if we have a VA ECMO run and we decide to decompress the ventricle, all of a sudden what happened is that stiff ventricle, that afterload decreases and the ventricle recovers his functionality. So as a rule of thumb, I think that the most important thing when you face an ECMO run, a peripheral ECMO run, is to understand when to decompress the left ventricle. And this is why in the postoperative period of a congenital heart disease or any other cardiac surgery, the most important thing is to be able to decompress the left ventricle. And this is why we typically do central ECMO cannulation on postoperative cardiac ECMO. In terms of management, it applies always the same concepts that we apply in general ICU. In order to keep the heart as healthy as possible, you have to control the rhythm, you have to control the pace. You should be able to win inotropic support as quickly as possible in order to preserve myocardial function and to support myocardial recovery. And then other things that might impede the recovery of the heart, such as ruling out pericardial effusion, pleural effusion, and other important causes of constriction to the heart. One of the key points on ECMO is to understand that we are dealing with a cardiac ECMO run and not a respiratory ECMO. And in order to translate that to physiological concepts, it's important to understand that cardiopulmonary interactions are key, are paramount to support the heart and to rest the heart. If we want to keep the ECMO run as short as possible, we should keep the lungs open. We should decrease the afterload of the right ventricle and understand that it's as deleterious a collapsed lung that similarly to what happened to an overdistended lung. So in cardiac ECMO, we should try always to work on FRC, not too distended, not to collapse. In order to achieve that, there is many ways to do it. It depends on the institutional approach that you have in order to keep your lungs open, but typically not too high of a rate, inspiratory times long enough to keep the lungs expanded with a tidal volume that is not too big, not too low, 7 to 8 mL per kg, and a PEEP that it's not too high, that increases the afterload to both ventricles. Another aspect, probably one of the most important ones, is how to deal with the bleeding. We need anticoagulation for an ECMO run, but too much anticoagulation will put the patient in danger, will put the circuit in danger, and will push us to change circuits to deal with a massive transfusion. So gentle management of anticoagulation is very important. I'm not here to tell you which one of the methods will apply to your institution, but as a general concept, I think that it's important that your institution pick one system and try to follow that one. There's many places that deals with ACT, thromboelastography, PTTs, anti-10. So if you keep adding ways to monitor, and you will add more confusion to the system. There is no evidence so far that proves that one system is better than the other, that they improve overall outcome of our ECMO runs. So I will say, try to be as systematic as possible, try to stick with one method, and try to get your folks working with the same method. Try to set targets of hemoglobin of 10, but always looking at the SVO2, if a patient has a hemoglobin of 10 and the SpO2 gets down below 60, then probably this patient needs better oxygen delivery, so he will need hemoglobin. Platelets, try to keep platelets as close as 100. You don't want to bleed, but you don't want to clot the membrane. And the same thing applies with fibrinogen, right? What happened though when the patient starts to bleed? It's a surgical bleeding or a medical bleeding. This is a concept that always applies to the ICU. What does happen? What does it mean? That the surgeons are not physicians? Is surgical or medical? No. Bleeding is bleeding, and sometimes bleeding is because you don't find the hole, and the surgeon has to look at it. But what we have to do as intensivists is just to make sure that we correct all the causes that can put this patient in danger or more prone to bleed. We have to give blood products. We need to make sure that all the tests that we run show that all the coagulation factors are well correct, and you should be able to transfuse the patient to correct numbers, but to make sure that you don't overshoot, because if you correct numbers that are already corrected, you might end up breaking a circuit that worked before. So if a patient has a normal thromboelastography and you give factor 7, or you give too much platelets, then you will end up with a clot in your oxygenator, and that will prompt an emerging circuit change. Coagulation is important, but probably one of the things that is also of paramount importance of these patients is making sure that your fluid balance is always optimized. There is no short ECMO run in the setting of volume overload. So the first thing that you have to target is for euvolemic, or rather negative fluid balance during your ECMO run. This is sometimes counterintuitive and difficult to achieve, but this is something that you have to always be careful about. Patients need to slowly achieve negative fluid balance in order to get to a euvolemic state that will put them into a safe place to be able to decannulate themselves. How are we going to do it? We can do native urine output. We can push diuretics. Remember that the diuretics bind into the system, the volume of distribution is higher, and you might need more diuretics in these patients. If you are not able to achieve the negative fluid balance with the diuretics, then use other renal replacement therapies. The first one that it's always interesting in the postoperative period is the peritoneal, the passive peritoneal drainage. And then, if you are not able to achieve those desired negative fluid balances, please use your filtration strategies. Whether you use the CRRT machine or you put a filter in the oxygenator, that will depend on the manpower and the ability of your institution to accommodate those wishes. Infection. It's not now the time to talk about how important is the infection in a postoperative period of cardiac surgery, nor an ECMO run. But what we know from years is the longer you stay on ECMO, and this is the right lower part of your slide, that shows that the longer you stay on ECMO, the higher the odds of getting infected. And the infection rates hasn't changed dramatically over the past years, but what we know for sure is the longer you stay on ECMO, the higher your odds of getting infected. So send cultures in for sure ECMO runs. Make sure that you use the appropriate prophylactic antibiotic. Use a stewardess and talk to your ID experts and use antibiotics in a very meticulous and judicious way to avoid infection. Ensure nutrition. This is probably not as key as a long ECMO run. Probably more important in a respiratory ECMO, longer ECMO run, well, nutrition will be key. We're talking about short ECMO runs, so obviously you want to feed the patient, but the most important thing is that you want to avoid complications. Please always rule out neck. If the patient does not have good cardiac output, make sure that you keep them NPO. If the patient is overloaded, fluid overloaded, the CVP is higher, the cardiac output is low, then the mesenteric perfusion will be low, and the chances for getting an enterocolitis are higher. So make sure that you protect this gut. So it's okay to keep a patient for a couple of days on trophic feeds if you aim for a short ECMO run. Probably one of the most important points is the neurological preservation, the neurological function preservation of our patients. There is no heart, there's no patient, but if there is heart with no brain, then we have a big problem, right? So this is why we know that ECMO runs traditionally and in smaller patients and preemies were associated with worse outcomes, and that's why we were hesitant initially to put the small patients on ECMO, because we were afraid of creating a lot of problems. And this is an old data from the ELSO registry, but we know now that even in those patients that are small, we are able to achieve good overall survival with intact neurological outcomes. And this is why, and this is because we have changed the way we monitor these patients. Remember, this is a typical picture of a patient 10 to 15 years ago. Some of the units might experience that issue right now. So we have a lot of things on top of this patient, but nothing monitoring the brain. If we know that the brain is probably the most precious thing that we have, why we are not paying attention to the brain of these patients? And this is what has changed. Now the trends are different. Even those patients that are extubated have a lot of systems that monitor their brain. And this is what we should do in our units. We should invest, we should put neuromonitorings in our patients to help us derive a postoperative care targeting and preserving neurological function. We know that the use of bilateral near-infrared spectroscopy helped us determine which patients are at risk of long-term neurological disabilities. And this is why the standard of care now is at least put bilateral near monitors on those patients while on ECMO, but not just neurological near infrared spectroscopy monitoring. The power of the monitoring the electrical brain activity. We are now putting those patients on continuous EEG. And this is another important topic to discuss, probably outside of the scope of this talk, because if you have the manpower to put continuous regular EEG and you have somebody that can monitor those patients 24/7, it's perfect. But sometimes there's other institutions that don't have the capability of having somebody looking at those patients 24/7 from a neurological standpoint. And then you have to do other ways. You have to use other machines, such as the one that you see in the screen. This is the Amplify EEG that simplifies the interpretation of a complex EEG monitoring and give us a lot of information at the bedside. So at the end, bottom line is we know that ECMO is associated with worse neurological outcome. Patients on ECMO have higher number of electrical abnormalities that are related to worse outcomes. So the more we monitor, the more we identify those patterns, the better we're going to control and the better we're going to support those patients, and the better we're going to sustain the long-term neurological function of these patients. So as a summary from the neurological standpoint, I think that we need to monitor, we need to appropriately monitor with whatever devices we have available, ideally bilateral nears, ideally continuous EEG, and then apply sedation in a gentle manner. understanding that the sedation in the circuit gets either binded to the circuit, the membrane, such as morphine and fentanyl, and you might need higher levels of sedation to achieve the same control of the neurological function. Typically on patients on central ECMO, we need to paralyze them, and the longer the ECMO run is, the more holiday paralysis that you might need to do in order to make sure that there's underlying function and that you are able to assess the functionality of these patients. So overall, I think that taking care of a cardiac patients on ECMO is challenging, but it's also very interesting. There is lots of physiopathological concepts that might apply, and some important concepts that we should keep in mind in order to achieve good outcomes and perfect outcomes of our patients. Please, please, please try to always aim for a short run. Try to minimize and to identify rapidly all the residual effects of these patients, trying to allow myocardial recovery, protecting the lungs, making sure that bleeding is under control. If there's a surgical bleed, make sure that the surgeons are aware and they don't tease you and they tell you that this is a medical bleed. Surgeons are doctors and also physicians, so there is no surgical or medical bleed. There is a patient that is bleeding. Please, please, please monitor the brain. Keep it very simple. Keep it very simple. Keep it very simple, and work always as a team. The better we work together, the better the outcome of our patients would be. Short is better in a CICU standpoint. Thank you, thank you, thank you very much.
Juan, we have one question that has come in, or actually maybe two. So we have, do you still want to share your slides or no? No. Okay.
Well, it's better to see the slides on my face, probably. Yeah.
So the one question is, what's your take on ECMO with inotropes and ECMO with vasodilators?
Yeah, I think that's probably that's a very important question. This is what I was trying to explain briefly on those first slides that I showed regarding the pressure loops. So when we place a patient on ECMO, immediately we increase afterload. In order to make sure that we help decompress this left ventricle, this is allowing the aortic valve to open, we need to decrease afterload. If we decrease afterload and there is no function, we will not be able to decompress the left ventricle. That's why sometimes you need a combination of inotropic support to squish this left ventricle a little bit better, and afterload reducers to help decompressing the left ventricle. So ideally, the less inotropic support, the better. But you have to always keep an eye on your left ventricle and make sure that the left ventricle is decompressed.
Okay, we have a couple other questions for you also. The next question is what's the political practice with analgesic over fentanyl in your hospital?
Yeah, so again, this is an institutional question rather than a general question, right? I can tell you what we typically do. So we use a combination of analgesia and sedation and anxiolysis. So we combine fentanyl, dexmedetomidine, plus minus paralysis. Typically, we on an ECMO run, on a given ECMO run, I would say that the average starting dose of fentanyl is around, for a neonate, is around 1.5 up to 2 micrograms per kilo per hour, combined with relatively medium dose of dexmedetomidine, which is approximately around 0.5 to 0.7 micrograms per kilo per hour, plus minus cisatracurium if you need to do so at the at the dose that gives you the amount of paralysis that you desire.
Okay, just a couple other questions. So outside the immediate postoperative period, do you normally give regular prophylactic antibiotics while on ECMO?
The short question to that is no, we do not. But I still don't know if that's the right thing to do, right? So what we typically do, we keep the patients on antibiotics while the chest is open, and since we do we typically do short ECMO runs, we keep those patients on antibiotic typically. If you imagine a cardiac ECMO, peripheral VA ECMO on a patient that has the sternum closed and that will have more than a week of antibiotics, you might argue that you will send routine cultures and you don't need prophylactic antibiotic. But I have still yet to see a paper addressing this particular question.
Okay, thank you. There's a question about your physiology slides, but just to address that, the videos will be available on YouTube also through the Congenital Heart Academy website. So I'll send out those YouTube links nearer to the end of the conference, so you can always go back in and watch any of the presentations. One other question is, what about massive transfusion protocol in case of bleeding during ECMO?
Yeah, I mean, you have to do whatever it takes to keep the patient alive, right? And if this is a surgical bleeding and there is no surgical available and you don't have the surgical skills to control the bleeding, then you have to do a massive transfusion protocol, which is making sure that you provide all the blood products necessary to keep the patient alive. Let's keep a oxygen delivery, that is, give hemoglobin to make sure that the hemoglobin is able to carry the oxygen, and make sure that you keep transfusing FFP and platelets until somebody just finds the hole.
Okay, thank you. A couple other questions. What's your protocol for diagnosing residual lesions on ECMO, bedside echo, cath, or CT angio?
Yeah, the first one being experience, understanding the anatomy, the physiology of the cardiac disease that has been taken in the OR, knowing your surgeons, and then understanding the resources that you have in your institution. The number one is your exam. If there is a residual VSD, then you should be able to look at to get there with the exam. Then the second important thing is echo, and if with the echo you are not able to diagnose the problem, then you should go immediately to the cath lab. So transposition, you should have always the coronaries in mind. So if you cannot see anything, then obviously you have to go to the cath. Norwood, if you don't see the shunt on echo, you have to go to the cath, etc., etc. So exam, echo, cath.
Okay, great. And the last question we're going to get to right now is, do you close the sternum with central ECMO? Is it possible? The other questions that are coming in, I'll address those online just in the interest of time so we can keep moving on. But Joanne, if you could address that question for us, that would be great.
Yeah. So this is an interesting question, right? So if you do central ECMO and you want to close the sternum, is because you think that probably that ECMO run will be long enough that you don't want to create problems on the healing part of the sternum. So the answer to that is yes. You can put cannulas, and I'm not a surgeon, so obviously one of the surgeons in the audience will answer that better. But you can cannulate and put the cannulas through through the subcostal and then close the chest. And short, which is if you cannulate central, you decompress, you will be ready to take off sooner rather than later. So, but in the interim that you need to put cannulas and close the chest, yes, that can be done.
Okay, great. Thank you so much, Juan. Just a real quick thank you to Juan. He's presenting live from Barcelona, Spain, so we truly appreciate him logging in and giving us his time, whether he's here with us in our CICU or in Spain. He's always in our hearts.
Thank you, Mary. That
You're
was
welcome.
very kind. And I wish I was here. I was there with you. I will be there on service 2 days from now, but unfortunately, I was not able to make it sooner. So thank you for having me.
We'll be looking forward to seeing you next week. Our next speaker that we're going to go with is Dr. Nama Kim Campbell. Dr. Kim Campbell is an intensivist in our pediatric ICU here at Children's Hospital of Pittsburgh. She's on service, so she's actually presenting remote from her office. So we're going to switch over to her. Thank you, Nama.
Thank you. Can you hear me? So my video won't start in here. I'm not sure why. Can you hear me okay? No.
You're able to tell her we can hear her. We can hear you.
Okay, great. Thank you.
We can't see your slides, though.
No. Okay. All right, hoping you can see my slides. My name's
Okay, we
Nama
can
Kim.
see your slides now, Nama.
Okay, great. Thank you. My name's Nama Kim Campbell. I'm a PCU intensivist here at the UPMC Children's Hospital of Pittsburgh. And I am here today to talk to you about extracorporeal life support for respiratory failure in the PICU. So I want to thank the organizers for inviting me to give this talk. So basically, when do we use ECMO or ECLS? Basically, when you have cardiac and or respiratory support, that when you need the support, when gas exchange is not life-sustaining, it's not a cure, and essentially it's just giving the body a chance to heal. So I'm going to be focusing on respiratory failure and respiratory indications for ECMO, since we just heard this wonderful talk from Joanne about cardiac. So just keep that in mind, that everything that I'm presenting today will be kind of focused on the respiratory ECMO world. So who should be offered ECMO for respiratory failure? So basically any patient that has inadequate gas exchange, who's at risk of ventilator-induced lung injury, who's failing conventional therapies, or has a high predicted mortality. So the Pediatric Acute Lung Injury Consensus Conference in 2015 suggests that ECMO should be considered for children with severe pediatric ARDS when the respiratory failure is believed to be reversible, or the child is likely to be suitable for consideration for lung transplant. And so basically, whenever you have lung protective strategies that are not providing adequate gas exchanges, when you would consider ECMO. So the other thing to think about in terms of ECMO is that it must be a bridge to something. So if it has to have a potentially reversible disease process or lead to transplant, it can't lead to nowhere. And so this is a bit of a non-specific criteria, and this is a little bit dependent on your institution and your practice as a ECMO provider. Okay, so what are the criteria in general for when we consider putting a child on ECMO for respiratory failure? So there's a couple of different things that people look at. One is oxygenation index. So the OI, to me, this is a really easy formula to remember. It's basically just what you give divided by what you get. So you're giving FiO2 and airway pressure divided by what you get, which is a PaO2. Generally, an OI greater than 40 is associated with high mortality, and this increases over time. Again, a PF ratio is something that you're probably all aware of in terms of our definition for acute respiratory distress syndrome, acute lung injury. Basically, a PF ratio less than 200 is considered ARDS. So a PF ratio from ELSO's criteria less than 60 to 80 is indication for ECMO. And then there is the Murray score, which the adults have used. So there's a link here for the CSER trial. And so basically, the Murray trial had this entry criteria for if you had above a 3, you would be considered eligible. The other things that we look at in terms of oxygenation failure, one is a AA gradient, or alveolar arterial oxygen difference, and this is an equation that you can use to calculate. Basically, an AA gradient that's greater than 470 is considered highly predictive of death. The other thing that we sometimes look at is the pulmonary shunting. So if you guys remember from any of your physiology lectures in the past, basically a shunt is when you have something perfused that's not actually like airways that aren't open or alveoli that are not open. So it's basically like a consolidated alveolus, for example. And so to calculate this, basically you can look at the shunt fraction. So here is just a pictorial picture of what we are considering when we think about shunts. So basically, it's a ratio of oxygen content. So the top being the CCO2 minus CO2. So if you consider the CVO2, which is the oxygen content of the mixed venous blood, I don't know if you can see my cursor here, which is measurable, and the CCO2, and this is a two-compartment model. So you have to assume here that CCO2 is equal to the alveolar content, which is the same as arterial content. So if you had perfectly oxygenated blood through your lungs, that would be CCO2 minus CCO2. The CaO2 is actually the oxygen content of the systemic arterial blood after you take into account the amount of blood that's gone through this shunt. So it's really kind of just a simple ratio that you're calculating. Another pictorial way of looking at this is the two-compartment model with a fully oxygenated blood, and compartment 2 is unchanged venous blood is going through your shunt, and that's how you calculate your shunt fraction. So again, here's the equation. So in this particular case, when you have this patient that sats are 90%, the hemoglobin is 10 milligrams per deciliter, where you have oxygen content in the fully oxygenated blood of 130 and oxygen content in the shunted blood of 97.5. And so your total shunt fraction here is 40%, which is high. So one of the equations I'm going to put up here, just one, probably the most important equation to know, is the equation for oxygen content. And so what you can see from this equation that the most important number is your hemoglobin. So it's directly proportional, and your percent sat, obviously. So this is why people try to push up their hemoglobins when you're on ECMO. Because the higher your hemoglobin, the higher oxygen content of the blood is going to be. So here you can see in this figure that I'm showing you that even with the same percent sat and PO2, if you have a higher hemoglobin, you will have a higher oxygen content. And this is something important to remember. Okay, so when you talk about ECMO, and when we're talking about delivering ECMO and making sure you're delivering adequate gas exchange for patients' organs to function, we talk about oxygen delivery and oxygen consumption. So oxygen delivery is the oxygen content of arterial blood and blood flow. So it's your oxygen content times your cardiac output. Whereas your oxygen consumption is the amount of oxygen that your body needs to function. And this will increase with things like exercise, catecholamine, sepsis, etc. Normally for an adult at rest, it's about 120 cc's per minute per meter squared, or 3 cc's per kilograms per minute. It's higher for a child, even higher for an infant, even higher for a neonate. So generally, we try to maintain a DO2-VO2 ratio of 5:1 in general. In the PICU, when we think about shock, when we think about oxygen delivery. So this is why when you check your SpO2, you're looking for a decrease of like 20 to 30% from your SAT, right? So 20% of the available oxygen is used for metabolism, with 80% left in your venous blood. a decrease in DO2, so when you have low cardiac output, if you're anemic, if you're hypoxemic, or an increase in VO2, so this is when you're exercising or you're septic, you have a high catecholamine release, will decrease this ratio. When this ratio is less than 2 to 1, which you can see in this figure here, that is when the oxygen supply is inadequate to maintain aerobic metabolism, and you that will result in acidosis, organ failure, and shock. Okay, so when we're talking about DO2, VO2, basically we think about using ECMO when either cardiac or lung failure is severe enough and is unable to maintain an adequate DO2-VO2 ratio, or in terms of respiratory support, when the interventions needed to maintain this ratio are damaging. So we're talking about high airway pressures, high FiO2, or high doses of vasoactive drugs. Ventilation failure is also an indication for ECMO. This doesn't happen as often as oxygenation failure, because generally it's usually easier to ventilate than oxygenate. But compliance and ventilatory failure in terms of pH are the two things that we generally consider. So compliance is the change in volume over change in pressure. And so when you have a very low compliance lung, that could be an indication to use ECMO if you're not able to ventilate. Ventilatory failure is basically defined as hypercarbia with a pH less than 7, or if you're using peak inspiratory pressure is greater than 40. And so this is also the ELSO guidelines for the definition of ventilatory failure. So when we talk about contraindications for ECMO, I think this is very institution specific. It also had some guidelines that they have put forth, but these are even the guidelines that are considered absolute have some gray to it, and so this is something that is more institution specific and what you do as providers. But most contraindications are relative. So basically you're balancing the risk of ECMO versus the potential benefits of using this very resource-heavy therapy. So the things that people think about in terms of contraindications are when there's unacceptable physical and mental impairment despite survival, pre-existing conditions which affect the quality of life. So these are the lethal chromosomal abnormalities, or your CNS status, or malignancy. Bone marrow transplants are something that we consider. Age and size of patient or futility. So if the patients are too sick, have been on conventional therapy too long, and you don't think they have a chance of recovery, or they have a fatal diagnosis. So the two forms of ECMO that we use in our pediatric ICU are VA ECMO and DV ECMO. And as you've heard from the cardiac side, VA can provide efficient respiratory gas exchange, but also provides circulatory support. Basically, blood is taken from venous circulation, returned to arterial circulation. It does increase afterload on the left heart. And LV failure can lead to pulmonary venous hypertension, pulmonary hemorrhage. EV ECMO is efficient in providing respiratory gas exchange, but doesn't provide any hemodynamic support. So you need to have a functioning heart. So blood is withdrawn from the venous circulation and returned to the venous circulation. So the blood return exactly matches the drainage. It does require, like I said, the adequate function of the native heart. And the benefit of it is that it avoids the use of a major artery and potential systemic embolism. A few slides on patient management. So generally the goal of patient management is adequate tissue oxygenation and cardiorespiratory support. The laboratory markers of oxygen delivery and clinical markers of oxygen delivery and adequate perfusion and support. So the laboratory markers that you'll see that most follow are lactates, pHs, central venous saturations, arterial oxygenation saturation. Clinical signs are vital signs, your urine output, the patient's perfusion, and their neurological exam. General tidbits about VA versus EV ECMO for patient management. In general, generally pediatric respiratory ECMO tends to potentially go on for a very long time. And so for this reason, you generally want to try to maintain some arterial pulse pressure because the hearts are usually not affected by the overall clinical picture, and it's usually a respiratory issue. So you try to maintain arterial pulse pressure of at least 5 to 10 millimeters of mercury to allow some blood to enter the native circulation. And you can generally aim for higher oxygen saturations and higher SpO2s. In VV ECMO, the flow through the cardiopulmonary circulation is normal. So you aim for oxygen saturations greater than 80%, SpO2 greater than 70%, because you're going to have some mixing. And so you're not going to be able to achieve really high numbers. And in some situations, depending on your DO2-VO2 ratio, you can actually tolerate sats even less than 80%. Okay, so blood flow on ECMO. For cardiac support, blood flow is going to be, in pediatrics, about 80 cc's per kilo per minute, and you have a goal SpO2 of greater than 70. The flow is maintained at about 80% of venous return to avoid stagnant flow and clogging the pulmonary vessels and chambers of the heart. You see, try and aim for a pulse contour of about 5 to 10 millimeters of mercury. For respiratory failure, your oxygen delivery and CO2 removal has to at least be equal to your normal metabolism. So in pediatrics, oxygen delivery of 4 to 5 cc's per kilo per minute, or in neonates, about 120 cc's per kilo per minute, and adults down to 60 to 80 cc's per kilo per minute. It's a blood flow that will give you that. For CO2 production by metabolism, you actually only need about 10 to 25% of your cardiac output. And this is why we have things like eCore devices and things like that, because you actually do not need a lot of flow to get CO2 removal if that is your only problem. So again, the oxygen, you'll see this equation that I'll put up in various slides randomly, so you just remember this particular equation. Okay, so a non-functional heart can be a problem on ECMO, and why is this? When you're going to be on ECMO for a very long time, so some of these respiratory kids will be on for weeks, months, and that is a long time to not have a functioning heart. So that being said, venous blood drains into the circuit with no arterial pulse contour, and so what that will lead to when you don't have a functioning heart is that your left heart gradually fills with blood from both the bronchial and diffusing venous circulation. And so this will lead to increased pressure in LV, LA, and your pulmonary circulation. At a certain number, you'll then end up with pulmonary edema and overdistended LV. And this is why you'll sometimes see the need for atrial septostomy in a patient with MSD or a drainage cannula to be placed in the LA or pulmonary artery. The blood in the cardiac chambers and pulmonary circulation will clot if there's no flow. So if you generally have a heart that's not beating well, you can use higher levels of anticoagulation, or in our center, talk to the cardiac surgeons or cardiac ICU and think about that and whether or not that would be indicated. Sweep gas, for us, most of the time we started at 100% and started at a flow rate equal to the blood flow rate. And sweep gas generally will control the CO2 clearance. Increasing your sweep will increase the CO2 clearance. In the pediatric world, we generally don't have issues with this. I know in the NICU sometimes it's a little bit too efficient with the CO2 clearance, and so they have some ways of dealing with that. Cardiac support in respiratory ECMO. So this is something that's we're talking about, because a lot of times patients that are in severe respiratory failure will often appear to also have a cardiac component, but a lot of the cardiopulmonary interactions that kind of lead to that are mostly driven by the respiratory system. So hypoxemia prior to ECMO can affect the myocardium. And so this will often lead to a requirement for inotropic drugs prior to ECMO. So you have the adverse cardiac effects of high airway pressures. And then if you put them on ECMO and you decrease the mean airway pressure, you actually will often have improved venous filling of the heart, improved oxygen delivery. And so this inotropic requirement that you have prior to ECMO goes away. Severe cardiac dysfunction does happen on ECMO. There is something called cardiac stun that we see occasionally with low pulse pressure and low cardiac output immediately after going on. Hypertension is common in patients with respiratory failure. So in VA ECMO, the reduced cardiac pressures from the diversion of the venous blood will lead to a baroreceptor response and reflex tachycardia. The non-pulsatile flow also increases your renin angiotensin from the kidneys, which is a normal kind of response. And so the treatment for this is vasodilators, beta blockers, ACE inhibitors, so all those things to try to decrease afterload. In VV ECMO, when you have hypertension, it's usually caused by the same reasons that you have hypertension in a patient who's intubated on it, also use some systemic vascular resistance secondary to agitation or pain, or if you have volume overload. When you have hypotension on ECMO, if you're on VA ECMO, you can just increase your ECMO flow, give some fluids or some inotropic support. On VV ECMO, it is very dependent on your needed cardiac function, so you have to support your blood pressure based on your cardiac performance and hemodynamics. If your myocardial performance is still inadequate for adequate oxygen delivery on VV ECMO, that would be an indication to convert to VA. So the one thing to remember, which is a little, might seem a little hard to remember, is that in VV ECMO, you actually do have better support to your actual heart, the coronary arteries in VA. And the reason why is because in VA ECMO, coronaries are actually perfused with lower saturated blood ejected from the LV, whereas in VV ECMO, you have oxygenated blood that's infused into the RA or IVC. So you actually have better oxygenated blood going to your coronaries than you would in VA ECMO. Hemodynamics on VV ECMO. So basically, when you have hypotension or need hemodynamic support, you do focus on your needed cardiovascular function, like we mentioned previously. So improvement in your venous return, improvement in your RV afterload. If you can try to resolve your myocardial hypoxemia or your myocardial acidosis. Okay, so ventilator management in pediatric ARDS and respiratory ECMO. Thing to remember most is that ECMO doesn't cure the underlying pulmonary disease. It's just providing gas exchange until your pulmonary recovery occurs. And so you can take this opportunity to try to minimize your barotrauma oxygen toxicity and promote lung healing and give the lungs time to heal without causing additional trauma. So as we know, the high ventilator pressures and oxygen concentrations can damage the lungs. So the benefit of being on ECMO is that you can then reduce your settings to non-traumatic levels. So we're talking low rates, long inspiratory times, lower peak pressures, lower FiO2, lower peak. So, the practice here is a little bit different per provider. In general, I personally like to maintain some lung expansion, so I will maintain some PEEP. Some people like to go lower with their PEEP, but mostly people generally do not like to let lungs completely collapse. But in VV ECMO, if you have a really high PEEP, it will inhibit your venous return and have a negative effect on your hemodynamics. So that's why people generally set it between 10 to 15. An alternative to this is to extubate the patient and allow spontaneous breathing with the patient awake, which some centers also prioritize. And then in the event of a major pulmonary air leak or interstitial emphysema, the ventilator pressure at times can be decreased pretty significantly or even turned off until the leak seals. The problem, so just keep in mind that if you do this and you end up with significant analectasis, then lung recruitment is going to be a little bit more challenging once they are ready for that step in their recovery. There's an acute inflammatory stage after cannulation, which you will often see. And so in terms of lung recruitment maneuvers, we usually wait until the inflammatory stage starts to recover or you see improvement. And then pulmonary toilet is always important. So once you're on ECMO, that gives you a lot of opportunities to do bronchoscopies, to do some aggressive suctioning or saline installation, surfactant, all the things that they were not tolerating prior to ECMO. When you have hypoxia on ECMO, there are a couple of things that you can try to do to improve your oxygen delivery. So the major things that you can do is red blood cell transfusion. So as you saw, the hemoglobin, higher hemoglobins will give you better oxygen delivery. Or you can reduce your O2 consumption and metabolic demand of the body, so decrease your VO2. So, use some sedation or maybe cool them a little bit and make sure they're not febrile at the very least. For VA ECMO, you can try to increase your flow if you have room. You can try to give volume, optimize your cannula placement. If you have a limitation of venous outflow or venous drainage, and that's why you can't increase your flow, you can think about adding additional venous drainage cannulas. In ECMO, increasing your flow can help to some but at some point it just increases your risk of recirculation. And so it won't be beneficial once that happens. Generally, you can accept lower oxygen saturations, generally in the 80s or low 80s. So basically, your infused mixed blood mixes with your systemic venous return. So typical flows is about a 3-to-1 ratio. So you monitor adequate perfusion and see if your lower sats are enough to provide the support for your organs that is needed. So things like lactate or NIRS, cerebral oximetry, look at your urine output, etc. So if all else fails and you're optimized as much as you can on your ECMO circuits, depending on your lung status, you could try to ask the native lungs to do a little more. So you can increase your oxygen or increase your settings on the ventilator, try to recruit a few more alveoli and see if we can get a little bit more participation from the native lungs. But in general, because you're on ECMO, you're going to try to maintain toxic ventilatory support settings. If your inadequate oxygenation continues and leads to hemodynamic failure, that is an indication to convert to VA ECMO from VV ECMO. So a few points about cannulation, which I thought would be interesting to go through because we do see this quite a bit in the pediatric ICU world. So venous drainage needs to be adequate for maximum ECMO blood.
Dr. Kim Campbell, we've lost your audio. We don't hear you anymore.
How about now? All right. How much did you miss?
I think it was just 1 or 2 slides, Dr. Campbell.
All right. So I guess I'll start here because I'm not really sure.
Your audio cut out prior to.
Where I lost you.
If when you get to the slide that you're going to, click the little screen icon in the bottom. Yeah, there you go. Okay,
okay, so
your audio cut out prior to this slide. Merritt is saying start at 23.
Can you also hear me? Because I actually can't hear you.
Dr. Campbell, are you able to hear us?
All right. Can you all still hear me?
Can you hear us, Dr. Campbell?
I cannot hear you, but do I need to hear you?
That's the problem. She can't hear what we're saying to her.
Okay, I have another computer open, so maybe that'll be better. Yeah, I cannot hear you. All right. I am going to mute my mic and use a different one. Okay. Okay, can you hear me? Yeah, can you hear me?
Can you hear us, Dr. Kim Campbell? We can hear you.
Okay, great. So can I share my screen again?
Yes, you can share your screen. Your audio cut out on slide 23.
Okay. Great. Okay. So sorry about that. I'm not really sure what happened there. Okay, so so this is a slide that we lost audio.
That's correct, yes.
So a few points that I wanted to make about cannulation. So essentially, venous drainage needs to be adequate for maximum ECMO blood flow, as we all know. And so you can achieve this in a couple of different ways. So make sure your cannulas are the right size and position, and make sure that you have adequate volume replacement. Or sometimes you might need to actually add an additional venous cannula. So as is pretty standard in most places, we assess this either by chest X-ray, ultrasound, or echo. The one point to make about a cervical cannulation, if you do happen to have a carotid arterial cannula, is that you do want to make sure that it's not directed at the aortic valve, because you do want to avoid damaging the valve or interfering with LV emptying. So one of the things that is one of the conditions or situations that's worth knowing, because in pediatric respiratory ECMO, this does happen quite a bit if you have a femoral venous and femoral arterial cannulation. And so this occurs because you have a normally functioning heart with native circulation that is ejecting, but it's ejecting blood that's going through non-functioning lungs. And so what you see then is essentially a watershed phenomenon where you have blood being ejected from the LV that is actually deoxygenated, and oxygenated blood from the ECMO circuit via your femoral arterial access, which is kind of mixing somewhere in the mid-aorta. And so what that happens is you have deoxygenated blood providing the upper half of your body and very oxygenated blood in the lower half of your body. And so basically what you see is when you don't have your aortic valve opening, if it's completely closed and you have no mixing, all the blood that comes in through the femoral cannula will go all the way up to the arch. But depending on where your heart is in terms of recovery, or maybe just it has normal function to begin with, you have various degrees of LV ejection. And as your ECMO flows decrease, the location of the mixing cloud, so this is where that watershed is, will change in the position of that aorta based on your LV ejection and your ECMO flow. So this differential cyanosis can be really problematic, especially if you're worried about the brain, because you do have to worry quite a bit about oxygenation and oxygen delivery to the cerebral vasculature. So in severe respiratory failure, this native cardiac ejection will preferentially support the heart and brain, and that will be deoxygenated blood. So the way to monitor for things that you should be concerned about when you have this differential hypoxia is things like myocardial ischemia, neurologic changes. So NEERS here might be very useful. If you continue to have issues and you have mixing that is really problematic, you can insert a cannula in your IJ or right atrium. An ECMO return can be incorporated, so almost a VAV kind of system where you're putting oxygenated blood back into the venous system. So you end up with that mixing that you normally get with VV ECMO. So this will direct oxygenated blood into the right heart and improve upper body saturation. The other thing that we should talk about in terms of VV ECMO is recirculation. So basically, since the blood is being drained from the venous circulation, returned to the venous circulation, when you have VV ECMO, you can actually have drainage of oxygenated blood from the circuit that goes back into the venous drainage cannula. So it just overall decreases your efficiency. And so you can have falsely high SpO2s on the ECMO circuit because of this recirculation. So as you can see here, blood that's being returned, some of it is actually being sucked right back out of the venous cannula. You can calculate this with your at the bedside, but generally, you know, a very kind of crude way of kind of looking at this is if you see red blood coming out of your drainage cannula, or blood doesn't seem as dark as it should be, then you might want to consider that you have some recirculation. Or if you have your SpO2 being really high, but your sats are not very high, then you probably have some recirculation. So if there's clinically significant recirculation, the things that you can do, you can try to increase your distance between the cannulas. You can add an additional drainage cannula, try to allow comparable blood flow at lower pump speeds, so less negative venous pressure. You can manipulate the reinfusion cannula, or the use of a bicable dual lumen cannula is often very helpful. All right, so a couple of slides just for other other organ systems. So infection in general, there's no indication for prophylactic antibiotics. If you're treating an infection, obviously you would use those antibiotics. Fever and inflammatory markers are not reliable because ECMO circuit easily controls your body temperature. So you have to have a high suspicion of infection or new infection or ongoing infection. Trends in procalcitonin or CRPs can be useful, or cultures, and broad spectrum antibiotics if you're unsure of what you're treating yet, if your cultures are not there. In terms of renal, acute kidney injury is very common in ECMO. It's actually upwards of 93% by 48 hours of ECMO support. Most patients on ECMO have received some fluid resuscitation early in the course, and so they often do develop some fluid overload very easily. So it's very important to pay attention to your fluid balance, maintain a strict fluid balance, avoid hypovolemia or impaired perfusion. Most kids with respiratory failure on ECMO need some form of diuresis, either pharmacologic or through CRT, like renal replacement therapy, or a hemofilter. Most often you have to use one or more than one of those things. Nutrition, so absence of enteral feeding actually leads to hypoplasia of the intestinal villi and risk for bacterial translocation. So if your patient can tolerate it, it would be in their best interest to actually feed them enterally. So the goal would be full enteral feedings, which is shown to be safe and effective during ECMO, at least trophic amounts to maintain gut integrity, and placement of enteral feeding tubes, either post-pylorically actually would probably be most beneficial. Can be done safely even with anticoagulation. In terms of pharmacology, circulating drug levels can be reduced from hemodilution or adherence to the ECMO circuit. So if you have drugs that can be monitored therapeutically, like therapeutic drug levels, that should be done when available, because being on the ECMO circuit, and especially if you end up adding in a renal replacement therapy circuit or even a hemofilter, can change your drug levels. And then sedation. So your goal is to maintain patient comfort and maintain safety of the ECMO circuit. And so this is a little patient dependent because some patients can remain comfortable and not agitated and much less sedation than others, and some might tolerate even not being sedated and more awake than others. And this is obviously a little bit age dependent and patient dependent. But the goal is to move the patient towards less dependence on sedation, if possible. From neuro, so our standard here on ECMO is to have patients continuously monitored by EEG. Sometimes NERS, especially if you have that harlequin or differential hypoxia that we just discussed. At the very minimum, if you're on sedation, or especially if you're on a neuromuscular blocker, they should do sedation and paralysis holidays and get an actual clinical exam to see if you have any neurologic deficits. And so what you're really worried about is any kind of cerebral bleed or stroke. And so you will have a clinical exam finding if that were to happen. Survivors of ECMO should receive a CT or MRI prior to discharge or some point in their near future to identify any abnormalities. And it's also very helpful for any early intervention programs or to improve neurodevelopmental outcomes. And then finally, skin integrity and positioning. So the goal is to prevent decubitize since they are laying in the same position for quite some time. So repositioning, spontaneous movement, and prone positioning. Complications that we worry about are obviously bleeding and clotting. So bleeding in surgical cannulation sites or GI hemorrhage or pulmonary hemorrhage. Hemolysis is very common on extracorporeal support. Neurovascular integrity, limb ischemia, especially when you have femoral arterial cannulations. Mechanical complications, and these are all related to the circuit thrombosis or pump failure, air entrainment. And then the thing that we worry about the most probably is our neurologic complications. So the seizures, the infarcts, and the hemorrhages, which can be dramatic and life-ending. So weaning and decannulation, the things that you're looking for are signs of clinical improvement. So you want to see signs that the lungs are actually improving before you decide to wean and then eventually decannulate. So in terms of lung disease and respiratory failure, what are the signs of clinical improvement? So resolving edema on your chest x-rays, increased lung compliance on your ventilator, which you can see by increased tidal volumes. If you're in a pressure regulated mode, or decreased pressures if you're in a volume regulated mode. All of a sudden having breath sounds that are much easier, much louder and easier to be auscultated. If you have an end tidal CO2 in line and it's showing increasing values, it might actually show that you're actually starting to have some more gas exchange and improvement in your chest x-ray. Also improvement in your SpO2s, which so it just shows that you have increased oxygen uptake by the lungs and better oxygen delivery. Increased SaO2 or PO2, obviously. So once your pulmonary function is improved, the way you wean and decannulate is a little bit different on VA versus VV ECMO. So in VA ECMO, much as the cardiac world would do, you decrease your flows, monitor your SpO2s. And when you get to a low enough flow, then you consider a clamp trial or trial off ECMO. And so during this time, you adjust both your ventilator settings and your inotrope suppressor support, clamp the circuit, and then if perfusion and gas exchange is adequate, you decannulate. In VV ECMO, you can treat the ECMO circuit almost a little bit like a giant ventilator. This is how I think about it. So you can adjust, you adjust your ventilator, your actual ventilator to acceptable settings. And then you can plus minus reduce oxygen concentration to the oxygenator. But you then decrease your sweep. You just wean the sweep. And eventually you have to cap the oxygenator to know for sure that you're not getting any gas exchange through the circuit. And if they have adequate gas exchange at that point, then you can decannulate as well. Unique patient populations for respiratory ECMO. So occasionally you'll get the patient with really severe status asthmaticus. Like this is the patient in the pediatric world where you typically think of going on ECMO for just selective CO2 removal. And this is very useful when you have someone like that who is requiring incredibly high ventilatory pressures. And so you can achieve lung rest settings, normalize your hypercarbia, with very little support, and then wait for the lungs to improve it and then decannulate them. Okay, so conversion from VV to VA and vice versa, and when would you do it? So VV support to VA support, you would consider that when your support is inadequate. So when you have increased pulmonary vascular resistance, if you have pulmonary hypertension or right heart failure. And so in those situations, it would be beneficial to be on a VA circuit. From VA to VV, if you have a patient whose cardiac function is improved or normal, and there is a thought that this patient is going to need ECMO for a very long time. So these are our severe ARDS patients that maybe are moving towards lung transplant. Those patients, if you can, you would try to convert them to VV because the risk of complications overall is just lower. And the complications that we worry about the most are the brain or cerebral stroke, or especially stroke or emboli complications. So just a few slides on VV ECMO, because this is a respiratory ECMO talk. In general, that the same 2015 Pediatric Acute Lung Injury Consensus Conference stated that in the absence of cardiac or circulatory dysfunction, expert opinion favors a choice of VV ECMO. And so back to this one slide, just want to show you again, DO2, VO2, and this is actually kind of important when we think about ECMO in respiratory, and especially VV ECMO. So generally we plan for VO2. Oxygenation is a bigger problem for membrane lung than CO2 removal. So blood flow is planned for oxygen consumption at rest or moderate exercise. And so that's what you should be planning for when you kind of set your flows. In general, to think about for VV ECMO is a mixing of two blood flows with different oxygen content. So you'll have mixing in the right atrium and the RV, and the mixing will be from venous return through the circuit as well as venous return through the native heart and lungs. And so the PO2 and the percent SAT is determined by the ratio of circuit flow to the total venous return. So you're typically aiming for 60 to 80% of your venous return to go through the circuit. And so just a little bit of math to show you why, what happens in VV ECMO and why we kind of tolerate lower SATs at times. So this is all these equations I'm going to show you is assuming that there's no lung function whatsoever and no recirculation, which is not realistic, but this is just for math purposes. So the systemic arterial oxygen content will be the average of the oxygen amount of oxygen in the two blood flows that we talked about. And so this is the equation that you can write just based on that statement alone. You can then solve for cardiac output or native venous flow as such by just rearranging the equation. And so what this is going to show you is that you can do this with both, I think I might have two of the same slide. For simplicity, you can do this using O2 saturation instead of oxygen content at the bedside as well. So here, if you use O2 content to look at this equation, so you can see, since you know everything except native flow, you can calculate your cardiac output, you can calculate your native flow. Using the O2 status surrogate, you'll get the same number. So why is this important when you're thinking about VV ECMO? So the fundamental concept of VV ECMO is that hypoxia, which is the inadequate oxygen is available to support aerobic cellular functions, must always be avoided. But hypoxemia, which is inadequate oxygen saturation in blood, which may or may not result in tissue hypoxia, actually may still allow adequate oxygen delivery, but like should still be avoided, but it's not, could maybe be tolerated. So why is it okay to have lower SAT? So here's a picture of a child on ECMO. And so you have systemic numbers here, oxygen content, you have your native venous flow oxygen content, and you have your outlet oxygen content. So let's say your circuit flow is 4 liters per minute, hemoglobin is 10.5, your SpO2 is 64, but your SATs are 88. PO2 is 50, and your systemic oxygen content is 12.3 milliliters per deciliter, your native venous content is 9, and your circuit is 14. And your VO2, let's say, is about 200. So your oxygen supplied here is flow times the out minus in oxygen content difference. So your oxygen supplied here is 200 milliliters of O2 per minute. Your cardiac output, which we calculated in previous slide, is 6 liters per minute. So your oxygen delivery is 738 milliliters of O2 per minute. Your DO2, VO2 is 3.69, which is very adequate to provide oxygen delivery and support to your body. So that's good. To increase your systemic oxygen delivery, how can you do that in just ECMO in general, but also mostly in BV ECMO? So because this part is about BV ECMO, you can increase your hemoglobin concentration to increase your DO2, increase your circuit flow, either increase your RPMs or add another cannula, decrease your VO2, so paralyze and cool the patient, or use more sedation, or add another membrane lung to increase the gas exchange surface, which will be limited by your overall blood flow. So last thing, last two slides. So this I thought was important to put in here, because sometimes when you decannulate someone on BV ECMO, you'll have this transient hypoxemia. You know, their stats might actually drop pretty significantly while you're decannulating them. And so this can happen during weaning and during decannulation. And so here, like, why does that happen? So because during ECMO, the hypoxic vasoconstriction, was your normal kind of response in your lungs, is abolished during ECMO, and just from your increased SpO2. So decreasing SpO2 during weaning will allow the return of physiologic hypoxic vasoconstriction, but sometimes this takes a long time. So you'll very much have this transient worsened functional shunt. So you do need to allow time to restore this physiologic hypoxic vasoconstriction, optimize your VQ matching. And so this is why sometimes on BV ECMO it's helpful, because you can wean your sleep very slowly and kind of let the lungs catch up, essentially. And so this is something to kind of remember when you're weaning your BV ECMO and weaning to decannulate. And the last thing to really talk about is futility. So this is actually, I think, one of the most important things that we need to do as intensivists is the discussion of stopping for futility, but with the family before starting ECMO. So limiting ECMO in the absence of complications can be a very difficult conversation to have. So the expectations of this need to be set prior to actually cannulating the patient onto ECMO. So when there are no other therapies to offer, or the underlying process is deemed to be truly irreversible after some time, or there's really no help for any kind of survival or meaningful survival, that can be something that should make you consider just taking a patient off ECMO. And then the last thing to remember about this, though, is that with pediatric or any kind of respiratory ARDS or respiratory injury, sometimes lung remodeling takes a very long time, and it can take weeks and 2 months for someone's lungs to recover. So you do have to have some patience when you are dealing with just pure respiratory failure. So I apologize for all the problems with the microphone and things, and appreciate your time. Thank you.
So we have one more presentation before we take a break for lunch. Our next speaker is perfect for this topic of adult ECMO for pediatric patients. He is not only one of our pediatric intensivists, but he also works over at UPMC Presbyterian as an intensivist. It's one of our adult facilities. He's a great resource for our adolescent patients and all of our pediatric patients as well. This is Dr. Timothy Kaslitz.
All right, thanks everybody. We'll try to get folks to lunch pretty quickly here. As Sam mentioned, I split my time. 25% I wear the hat of a pediatric intensivist, and then 75% of my time I actually wear my hat as a cardiac intensivist on the adult side. So I have the privilege of being able to take care of patients from all ages and also see patients on ECMO of all ages. And that kind of led to the inspiration for this talk. So one of my favorite mantras that people often cite, children are not just small adults. However, I think it's a little bit overused, because sometimes when they're on ECMO, they kind of are. I'm going to talk about a few things that we do very ubiquitously in adult ECMO that definitely has uses in place in pediatric ECMO, but is either invariably applied, in other words, it tends to be institutional and cultural, or it's applied with some changes, which is perfectly fine, but this is, I think, an opportunity to think about how we can cross-pollinate to standardize practice a little bit more. We'll talk about the use of point-of-care ultrasound and how that can aid in the pre-ECMO period, the intra-ECMO period, and then while weaning. We'll talk about the prioritization of VV ECMO and respiratory failure. We'll also do a little bit of discussion about dual site VV ECMO cannulation, carotid versus femoral arterial cannulation, and then finally, if we have time, we'll talk about LV venting techniques. So point of care ultrasound is something that I use ubiquitously when I'm taking care of a patient on ECMO. First and foremost, it can be really helpful in ensuring that your support strategy is the right strategy, right? So you can actually adequately assess hemodynamics in real time at the bedside before you make your decision on ECMO modality. You can also look at causes of why a patient might be having respiratory failure. You definitely want to exclude a cardiac reason as the reason for respiratory failure before you decide to make a decision on ECMO modality. Probably the most useful thing I use it for is evaluating anatomy. So you can actually see and measure the vessel size in real time. You can ensure patency. You can look for anatomic aberrancy. And you can also look for other pathologies that might change some of your decision making. It's really helpful to select a cannula size when you actually know the vessel that you're putting it into. Just a schematic showing the different VV cannulation approaches. I want to focus actually on the dual lumen single site approach for how point of care ultrasound can be especially useful. It's actually essential to use some kind of image modality when cannulating via this way. To show you a quick schematic, so this is a kind of a textbook example of how to use this technology. So in the upper left there, you can see a guide wire inside the internal jugular vein. Then moving on to the top right, this is a bicable view. So just to orient you, this is the SVC here. This is the IVC here, and the right atrium is here. So this is showing the guide wire appropriately positioned past the right atrium into the IVC and actually past the hepatic vein, which is absolutely essential. In the bottom left, they're advancing the cannula over the guide wire past the hepatic vein. And then on the bottom right, you can actually see they're doing color flow Doppler to ensure that the return jet from the cannula is properly directed at the tricuspid valve. This is a nice time to kind of segue into percutaneous cannulation. So the majority of pediatric ECMO cannulations are still done via open technique, although slowly percutaneous cannulations have become more and more common. Some of like anything in ECMO, you have to weigh the pros and cons. So the pros for a percutaneous cannulation, obviously less invasive. We know via multiple studies now that there's fewer complications. It's very rapidly available and could be deployed very rapidly. It's also accessible by non-surgical clinicians in certain circumstances. Some of the cons, it requires additional skills. So you actually need to be comfortable with accessing a vessel with use of ultrasound, which not everybody is comfortable doing. There also is this question, can it increase limb complications in ischemia? This is particularly true with femoral arterial cannulation, which we'll talk about in a second. This is ELSA data, just showing you that over time, percutaneous cannulation, again, while still the minority, is increasing. This is both VV and VA. Interestingly, VA cannulations, the percutaneous access has gone down, probably because you see a decrease in percutaneous access with neonates. That was something that was done in the late 90s and the early 2000s because of complications started to become less common, as you can see. But in VV cannulations, percutaneous access is almost 50%. This is just highlighting some of the differences between the two. So you're less likely to have cannula problems, less likely to have bleeding. Interestingly, limb complications, more common, percutaneous cannulation, as we discussed, and less likely to require cannula site repair. What about the post-ECMO period? So here, point of care ultrasound can be really helpful to ensure that your cannula remain well positioned over the course of the ECMO run. You can also troubleshoot issues that arise. So looking at drainage insufficiency, you can assess for and treat hypovolemia. You can look for thrombi, either intracardiac or even sometimes in the cannula themselves by utilizing color flow Doppler. You can also exclude other pathologies like tamponade intra-abdominal hypertension and pneumothorax. I want to give a particular example of how we used it to troubleshoot a recirculation issue we were having. So you can also look at a differential diagnosis for hypoxemia. In this case, we had a 29-year-old woman. She actually had COVID. She was persistently hypoxic on femoral IJVV ECMO. She had an x-ray that showed that the cannulas looked like they were sufficiently apart. However, the perfusionist at the time was concerned there was recirculation by observing flashing in the drainage cannula. Given that the cannulas were adequately positioned, we decided to do a point-of-care ultrasound to see exactly which one was causing the problem. So again, to orient you, this is a bicable view. This is the IVC and the SVC. And this is the tip of the return cannula, which looked like it was a little deep. And sure enough, when we interrogated it via color flow Doppler, you can actually see the return jet going right down the IVC. So normally, if you were to pick a cannula, it's usually the drainage cannula that gets withdrawn about 8 to 9 times out of 10. However, in this case, we had reason to suspect that it was the return cannula that was the issue. So after we withdrew it, you can now see the return jet, while not exactly directed to the tricuspid valve, much more of the jet is in the right atrium. Moving on to prioritization of VV ECMO and pediatric ARDS. So as Dr. Kim mentioned, it's now the preferred strategy as long as you don't have any cardiac or circulatory concerns. Interestingly, it's still the case that VA is still selected in a lot of patients, especially in the setting of inopressor dependence. I think what becomes a little bit of a leap of faith for people making this decision is some of the hemodynamic benefits you get once you ensure adequate gas exchange. So hypoxia, hypercarbia, acidemia are all usually taken care of with VV ECMO. And not to mention, you're able to lower the ventilator settings quite a bit. A lot of times mean airway pressures are in excess of 30 centimeters of water, and you're able to come down quite a bit on that, which facilitates improved venous return. All of these things lower PVR, and then lastly, you can actually reduce the dose of medications that sometimes have a negative inotropic effect. This is showing you the proportion of patients that are undergoing VV cannulation and respiratory failure. The pediatric population in particular has now crossed the 50% threshold. So most patients in PICUs that have respiratory failure are now being cannulated on the VV ECMO, which I think is a huge step in the right direction. This article was sort of the seminal article that brought concern to this issue of using VA ECMO and respiratory failure, specifically with cervical cannulation. This group actually showed that carotid ligation was associated, not surprising, with more neurologic complications. Interesting, the folks that got femoral artery cannulation were much, much older, but after adjusting for age, the association was still present, as you can see. And lastly, this is a fairly recent article that came out looking at complications of VA versus VV ECMO in pediatric respiratory failure. So in-hospital mortality was significantly less in the VV group, as was the duration of time on ECMO, needing mechanical ventilation, as well as neurologic complications. They had more ECMO-related issues in the VV group, including oxygenator failure and clots. But those were the only statistically significant differences. Lastly, this group looked at VV versus VA in patients that before ECMO were actually dependent on inotropes. And they showed that survival to discharge had an association, there was an association with an improved survival to discharge in the VV group versus the VA group, with no other complications noted. I mentioned I would talk a little bit about dual lumen versus multi-site VV cannulation. So single site, a dual lumen cannulation still predominates in most pediatric centers. The decision seems, at least on survey data from ELSO, is basically dependent on institutional culture and the experience of the surgeons. Multi-site cannulation is generally discouraged and thought to be not possible in infants less than 15 kilograms due to the fact that they're not ambulatory and they have a really small femoral vein. We'll talk about that in a second. And there's this concern, although you can't really find much citation of it in the literature, for recirculation with multi-site cannulation in smaller children. I'll skip over this just in the interest of time. So this is also data that actually compared multi-site versus single-site VV cannulation. You can see there's no separation in the Kaplan-Meier curve. This is over multiple years and multiple centers with many, many patients. So the first thing I want to mention is that modern cannulas actually do a nice job reducing recirculation, and that's owing to the fact that modern drainage cannulas are multi-stage. They have fenestrations all down the length of the cannula. You can see in the graph to the right, so this is a study that looked at complex fluid dynamics of multi-stage cannulas. They're comparing single-stage and multi-stage. Most of the flow actually comes from the proximal fenestrations, not from the distal fenestration. The distal hole is a little bit larger, so you have a little bit of an uptick. But then as you move down the length of the cannula, flow actually goes up. And that owes to the fact, if you look at Pusili's law, the length of the cannula, it determines resistance. So the closer the source of blood is to the negative pressure, the more blood flow you're going to get through those holes. So that goes a long way, because if most of the blood flow is actually coming proximally rather than the distal tip, then the cannula position matters much less, and recirculation fraction is going to be considerably less. This is a real-time schematic actually they used to kind of illustrate this point. You can see most of the flow is coming from these proximal side holes, and the distal side holes actually don't have much flow at all. I also make the argument that I think flow trumps recirculation. So if you look at the current generation of Biomedicus drainage cannulas, and you assume a negative pressure of 80 and 100, and then you compare that to the current generation bicable double lumen cannulas, you're going to get much more flow with a large single cannula than you will with a similarly sized double lumen cannula. And just to show you how the math works out, so if you take a 10-year-old, 35-kilo child, even if you assume a really low 2% recirculation rate, which is what's cited by the folks that manufacture the Crescent, it's going to give you a total support of about 3.4 liters, and then compare that to the strategy I have below. Again, these are relatively conservative estimates. And even if you assume a higher recirculation fraction of 12%, your effective ECMO flow is still going to be almost a liter higher, so you're going to get 20% more flow. So when do I think it would be appropriate to consider multi-site VV cannulation? I think if you have a big kid, and I think if you have a really sick set of lungs that are really stiff with a high shunt fraction, you're going to want a strategy that's going to give you the most amount of support up front. You can always revise it if you start moving towards rehabbing the patient on ECMO or something like that, where you think a single cannula would benefit you there. I'm not advocating for this, but this was, I think this was 2 years ago that this study came out. This was a group in England. So they had multiple complications with double lumen cannulas in the form of cardiac perforation. So they actually moved to IJ femoral in babies. So these kids were all less than 10 kilograms. Apparently, if you listen to the lecture that this group gave, they all had huge legs because they occluded the common femoral vein. But ultimately, upon decannulation, they collateralized, and there was no loss of limb or other limb complications. Obviously, small case series, not advocating for this, but just kind of showing you what's out there. What about carotid versus femoral arterial cannulation? A lot of folks have already talked about this, so I'm not going to spend a whole lot of time. Obviously, carotid cannulation and ligation are associated with more neurologic outcomes. The flip side is femoral arterial cannulation. If you look at the limb ischemia rates, they're pretty high. Anywhere, depending on what articles you read, it's anywhere from 20 to 50%. Will have some issues with limb ischemia, even in the presence of a distal perfusion cannula. Interestingly, if you look at neonatal ECMO survivors they all have carotid cannulations. They have comparable neurologic disability as non-ECMO survivors of critical illness. But there must be some age where the cerebral vasculature can no longer adapt to carotid ligation. Just nobody knows what that is. This group actually did something interesting. They surveyed pediatric surgeons, and they kind of posed a question in this kind of in-between case. You have a 7-year-old. What percentage of them are going to be cannulating centrally? What percentage of them are going to be cannulating the neck versus the femoral arteries? And most of the participants elected to still cannulate the neck. Interestingly, half of those was just because they only used that strategy, period. So a whole ton of variability. For the ones that did cannulate femorally, only about half of them had distal perfusion cannulas, and only about half of them placed them at the time of cannulation. The other half waited for issues to arise. So the comparison is when we cannulate onto peripheral VA ECMO, we only do femoral cannulation if it's going to be percutaneous. And they all upfront get distal perfusion cannulas. Actually, that's the first cannula we place because it can often be the trickiest one to place. And then lastly, we'll talk about LV venting strategies. So I'm not going to spend a lot of time reviewing the physiology. Joanne already did a really nice job at that. Interestingly, the only options that are kind of available in pediatrics are pharmacologic, so the use of inotropes, or a balloon atrial septostomy. You can use a direct drain, a direct vent into the left atrium, but that's typically reserved for central ECMO. In adults, we typically, historically, have gone directly to an intra-aortic balloon pump, but now more and more people are using Impellas. Again, I'm going to skip over that just because Joanne already illustrated what happens to your pressure volume loop on ECMO. So if you think about some of the advantages and disadvantages of all these different venting strategies, one of the things that we really like about Impella, and this is just going to show you a quick schematic. So this is kind of conventional fem-fem VA cannulation with the Impella inserted through the left femoral artery and kind of sits in the LV here and crosses the aortic valve. So one of the things we really like about it in the adult world is it provides direct full LV unloading. One of the issues with balloon atrial septostomy is that you can still get stasis of flow in the LV. You can ultimately get impaired aortic valve opening and clot. You don't have that same issue with Impella. It also provides additional support, so you actually can utilize that flow to stage your weaning. You can get off extracorporeal support sooner and get them to Impella-only strategy as long as they have healthy enough lungs. So it may allow shorter ECMO runs. Obviously, it's another procedure, so there's going to be technical issues with that. There's more bleeding and hemolysis, and now you have to worry about another vessel with potential access site ischemia. So is it feasible in kids? So the smallest device that Abiomed makes is an Impella 2.5. They actually did their own study where they did cardiac MRs on children to provide guidance because these devices are being utilized more and more in children. So what they kind of came up with was you need an LV apical length of about 7.5 centimeters, which if you looked at growth charts corresponding to roughly a 25-kilogram child. And they are doing this. They're not doing ECPella per se, but they are doing Impellas in children as young as 4 years old, actually, in this study. So that age range from 4 to 21 was as small as 20 kilograms. Yeah, so that's all I got. Thank you.
Tim. Thank you, Tim. Always a great talk. We love having you here at the conference. We're running behind schedule, so we're going to go ahead and break for lunch now, and we're going to come back at right around 2 o'clock. I'm going to move my case report to tomorrow afternoon, and we'll continue on with our program starting again at 2.
Hi, everyone. Welcome back. So we're gonna actually hold on one second. Okay. Good. All right. Welcome back, everyone. So we're gonna continue the afternoon. Just as an update, I know Merritt said this earlier, but just in the interest of time, we're gonna rearrange the schedule a little bit. And her case report is gonna be moved to tomorrow. And then we're gonna move ahead with my talk, which is ECMO considerations in congenital heart disease. So like I said before, my name is Melita Villegas. I'm one of the congenital cardiac surgeons here, and I'm also the director of mechanical support and ECMO here. So I have no disclosures. So today we'll talk about a few things, and this is just an outline of all the topics I'll cover, but the role of ECMO in congenital heart disease, followed by considerations in management, risk factors, and then finish up with outcomes. So how are we using ECMO in this patient population? So what is this patient population? So congenital heart disease is common. It's present in about 40,000 infants per year, about 1% of live births worldwide. And there's a very high heterogeneity in this group, which means there are simple defects that may be small VSDs that will end up closing on their own, all the way to very complex diseases that require very demanding high-risk interventions for repair. Of the complex congenital heart disease, hypoplastic left heart syndrome occurs in about 1 in every 4,000 of the patients with congenital heart disease. There's also tetralogy of Fallot, TGA, and tricuspid atresia as well. So how do we view ECMO in congenital heart disease? There's 4 general approaches, sorry, that was me and the mouse. 4 general approaches to ECMO cannulation. So when a patient's expected to have a reversible underlying pathology and recovery of cardiac function, ECMO can be used as a bridge or temporary support to recovery. For patients with non-recoverable cardiac disease who are candidates for long-term support, ECMO can be used as a bridge to VAD support. And then it can also be used as a bridge to cardiac transplantation. And finally, in patients with significant comorbidities with variable expectations of recovery, it can actually be used as a bridge to decision-making while we gather more information, which will evaluate the progression of the disease process. Lastly, it can also be used for pulmonary support in patients where the primary challenge may not necessarily be the congenital heart issue, but a respiratory issue. So when and how do we use it, and why do we use it? So ECMO can be instituted in the pre-op, intra-op, and post-operative period. It can offer pre-op stabilization and support those patients that may fail to wean immediately from cardiopulmonary bypass. It can be used to minimize end organ damage and low cardiac output syndrome. It can also be used to treat refractory hypoxia and in those that suffer cardiac arrest. It's also very useful in those patients that may have residual lesions, which leaves them in a physiologic state that is unstable and allows them to be stable for further evaluation and then potential reintervention if necessary. Overall, ECMO is used in 1.4 to 5% of neonatal and pediatric cardiac cases. From 2014 to 2018, the ELSA registry reported 65% of cardiac neonatal cases were in single ventricle patients, and 38% of pediatric cardiac runs were actually in single ventricles as well. So what are contraindications? There tend to be some relative contraindications, and I tried to choose ones that would pretty much be standard contraindications. So if a patient's in prolonged cardiogenic shock with irreversible multi-organ failure, therefore not reversible, then most likely ECMO is not an option. If a patient is less than 34 weeks of gestational age or of low birth weight less than 2 kilos, severe chromosomal abnormalities, or if there's irreversible brain injury or intracranial hemorrhage, as well as if there is uncontrolled bleeding, unless ECMO can bring us to stabilization to fix the bleeding. So preoperative ECMO support usually occurs in neonates with unpalliated congenital heart disease. These can be patients with obstructed total anomalous pulmonary venous return, severe Epstein's anomaly with a circular shunt, or tetralogy of Fallot with absent pulmonary valve. This was a report from the STS Congenital Heart Surgery database, and it included 80 hospitals and 96,500 cardiac operations. Overall, only 0.5% of patients required ECMO preoperatively, and 0.1% required ECMO both pre and postoperatively. Focusing on the postoperative ECMO, postoperative cardiac dysfunction can manifest as either failure to wean from cardiopulmonary bypass, needing a high amount of inotropes in order to wean from bypass, or development of low cardiac output syndrome in the intensive care unit. Low cardiac output syndrome happens in this patient population in about 10 to 25% of patients. The highest rates of ECMO in this postoperative setting were in the Norwood procedure at 17%. In the arterial switch operation with VSD closure and arch augmentation, so our Tausig Bing patients at 14%. Those patients that underwent truncus arteriosus at 9.4% and Roscono patients at 9.3%. With improvements in ECMO technologies and our institutional experience and standardization of use, the applications of ECMO have expanded. Cardiac ECMO, the cases themselves have been on the rise, with thousands of pediatric cases reported in the ELSO registry annually. Overall survival in patients with congenital heart disease has increased in time, partially due to the use of ECMO in this specific subgroup. This is a look at the ELSO registry up until 2020, and at that time, 21,829 cases of cardiac failure had been reported in neonates and children since the beginning of ELSO. That's about 30% of all runs, with a steady increase in the runs over the years, as you can see. Survival itself is roughly 50%. Paring it down to the more recent area, looking at 2018 to 2022 in the ELSO registry, there were a total of almost 3,500 pediatric cardiac runs, of which 24.5% were in patients with congenital heart disease. As you can see, the overall survival there is marked as 55%. Of those patients with congenital heart disease requiring ECMO, 20% had a diagnosis of hypoplastic left heart syndrome, and the remaining majority had cyanotic heart disease. Those patients with the lowest survival to discharge were those with pulmonary venous obstruction, and while those with the highest survival were those with right-sided obstructive diseases. Looking at neonates, 46% of the neonatal cardiac runs in this time period have also been in patients with congenital heart disease. Several studies have reported that the use of neonatal cardiac ECMO is roughly 2 to 5% in all cardiac cases. Of those, 28% of the patients in this portion of the registry, 28% of the patients had hypoplastic left heart syndrome, with an overall survival of 47%. And just as in the pediatric group, the patients with the worst survival were those with pulmonary venous congestive disease. So what strategies do we use in this patient population? As you can imagine, there's a lot of things to consider, and number one depends on what the patient brings to the table in addition to their anatomy. So cannulation site and ECMO strategy are determined by a patient's underlying cardiac anatomy, prior surgical interventions, their size, as well as expected duration of ECMO. It can be performed either peripheral or central. Central cannulation is generally easily accessible in the postoperative period, and can also be helpful, especially if you require appropriate flows, especially in patients that may have had multiple surgeries and have limited access. It's also something to consider in patients that have shunt-dependent congenital heart disease. So this is more looking at single ventricle patients that are in stage 1 or interstage. In these patients, you need to consider what the best strategy is and how to run the ECMO circuit according to what type of shunt anatomical shunt they have, whether it be a Sano or RV2PO conduit versus a modified BTT shunt. And we'll go into that a little bit more. Switching gears back to biventricular physiology, let's talk a little bit about LV decompression. So what is the mechanism of left ventricular distension? Dr. Sanchez talked about this earlier. So, the ECMO circuit itself bypasses the heart and pulmonary circulation. However, there's always some blood that enters the RV and pulmonary circulation and then ends up in the LA and the LV. This ultimately leads to LV distension. These are just some kind of physiologic graphs for us to look at this. If you look here in A, that shows us what the LV volume and pressure increases as patients in cardiogenic shock are in ECMO. In B, you see the aortic and left atrial pressure increasing, and C, with your venous drainage, you see the right atrial pressure decreasing. The pressure volume loops actually demonstrate that with increasing ECMO flows, the aortic pressure and afterload increase, and stroke volume, as evidenced by the width of the loop, decrease, ending up giving you LV distension and LA hypertension. So it is important, especially in our postoperative group, we don't necessarily need to decompress all patients, or not all patients need left atrial decompression in this particular group. And it's important to realize when it can be important, but also recognize when to pull the trigger on it. So if this is a patient that has decreased function or has an issue with SVR, but you still have ejection of the heart, you most likely will not have LV or L left atrial distension. Clinical signs will be your X-ray and your echo as well. Your X-ray will be whited out. This is a large multi-center cohort of patients with 2 ventricle congenital heart disease, looking at the association between LA decompression and in-hospital adverse outcomes. And what they call in-hospital adverse outcomes is mortality, transplant on ECMO, or conversion to a VAD. Of the 2,900 patients supported with VA ECMO, 1,500 had biventricular physiology, and 279 of them underwent LA decompression. So the adverse outcomes occurred in 47% of the patients with LA decompression, and adverse outcomes happened in 51% of those without. And while that doesn't seem like a huge difference, it turned out to be statistically significant, and proved to be an independent protective factor against those in-hospital adverse outcomes of death, transplant, or VAD. Other factors that came out from this study included longer ECMO duration, higher ECMO pump flow, cardiac surgery on ECMO, and ECMO complications independently increase the risk of adverse outcomes, whereas the use of systemic vasodilators on ECMO independently reduced the risk of the adverse accounts. There are a lot of ways, and it deserves a talk in and of itself, but there are lots of methods to achieve left atrial decompression, and the optimal method has not been determined. Various methods are available both surgically and percutaneously. You can place an LV vent, you can do a balloon atrial septostomy, you can place a stent across the atrial septum, you can place a completely different device as well. Determination of when and which method to use will always depend on the patient's clinical status, their patient-specific factors, and what your surgical and catheter resources are. Switching briefly to touch on single ventricle considerations. So stage 1 of the Norwood, the patients are left in a shunt-dependent circulation, and this is the most critical phase. We normally cannulate these patients centrally if necessary, but they can also be cannulated peripherally as well. What is important to know that if a patient has a BTT shunt, then that means that there will be runoff of systemic perfusion via the BTT shunt. And in order to compensate from that, we increase our flows anywhere to 150 to 100 150 to 200 milliliters per kilo per minute. The other option, if you just want to run at normal flows, is to place a small clip, but obviously that could lead to potential injury of the shunt as well as possible thrombosis. In those patients that undergo an RV to PA conduit or a sono, you want to ensure that there's continued flow during that conduit while on ECMO. So you basically want to keep the ventricle pumping so that there's no stasis within that conduit, so that there's no thrombosis. So important things to remember, and it's always important to remember what your anatomy is. Like I talked about before, you can also cannulate these patients peripherally. Just keep in mind, what type of shunt you have and how you need to adjust your flows accordingly. The Glenn cannulation and ECMO tends to be very challenging. So the cannulation of the Glenn patient, because there is separation of the systemic venous drainage, the SVC drainage to the pulmonary arteries and the IVC to the heart. So this separation leads to difficulty maintaining adequate venous drainage and systemic perfusion. Cannulation needs to be tailored according to the cause of the patient's decompensation. So if the reason is primarily respiratory, secondary to infection, cannulation of only one of the cavas may be adequate. But if there are elevated Glenn pressures, the superior vena cava will likely need to be drained in order to decompress the Glenn and cerebral venous system. And lastly, if it's due to poor function, likely both the SVC that is going to the PAs as well as the IVC that's still connected to the heart will need to be cannulated so that you can completely take over full function of the heart. Even more challenging, or maybe the same amount of challenging, are patients with Fontan circulation. Dr. Feingold will talk a little bit about this more, but first off, prior to ECMO CPR is largely ineffective because the venous return is passively returning to the lung. So cannulation can be difficult also because patients have had several operations before, they have occluded vessels, and the presence of reconstructed cavas and lots of baffles. In order for adequate decompression to support the systemic output, usually both the IJ and femoral vein are needed. And even with adequate drainage, you end up with decreased preload to the single ventricle because there is less flow through the lungs. The failing single ventricle will often have inhibited ventricular ejection due to the high afterload of the arterial flow, and therefore ECMO flow must be responsible for delivering all of the cardiac output. So let's talk about risk factors and outcomes. So several studies have outlined the predictors of mortality in this patient population. This list provides a result of a meta-analysis of several studies investigating all these risk factors. They include the usual offenders, including low birth weight, chromosomal abnormalities, and single ventricle physiology, but also the pre-ECMO state of the patient. Obviously, the sicker the patient is prior to ECMO, the higher the risk for mortality after. This is a meta-analysis that reviewed the reported outcomes of post-op congenital heart disease and cases on ECMO from 1990 to 2020. 43 studies were included involving 3,585 patients. Postoperative ventricular failure with low cardiac output was the most common indication for ECMO initiation. Approximately 60.3% of patients were successfully weaned, and bleeding was the most common complication and occurred in 47% of the patients. Mechanical complications occurred in 19% of patients and neurologic complications in 16%. 14.9% of patients had residual lesions that required reoperations. And just as a special note about that group in particular, Dr. Sanchez touched on this in his talk as well, but there really are no multi-center studies documenting this as yet, but those patients with complex congenital heart disease that undergo repair often benefit from stabilization on ECMO if they're unable to wean from bypass for further evaluation of if there are residual defects or things that need to be fixed from the repair. But ultimately, with that stabilization, we miss that whole phase of potentially patients going into liver failure or renal failure, and ultimately translates into improved outcome in this very high-risk group. In the same study, the pooled estimated incidence of in-hospital mortality was about 56.8%. Single ventricle physiology and renal failure were two independent risk factors for in-hospital mortality. And as expected, the longer the ECMO run, the higher the risk of mortality. So this study looked at factors associated with requiring ECMO within 48 hours of surgery in patients that were less than 6 weeks old, so neonates. Of the 565 patients, 20 required ECMO at a mean postoperative time of about 12 hours. The risk factors, important risk factors, were high vasoactive inotropic score, a lactate greater than 6, and single ventricle anatomy. Of those that required ECMO, 40% had residual lesions, a residual anatomic defect that required an intervention, just emphasizing what I just talked about, that ECMO can be used as a tool for rescue and salvage. This is a study that was generated from the PC4 registry looking at risk factors and outcomes of ECMO in the CICU. It included 14,000 hospitalizations, of which 64% were surgical. ECMO was used in 509 of the patients. The most common indication was systemic circulatory failure in 48%, followed by ECPR in 32%. Neonates had a higher rate of ECMO utilization, and preoperative risk factors included preoperative CPR, shock at the time of surgery, hepatic or renal dysfunction, seizures, stroke, or intracranial hemorrhage within 48 hours of surgery. Also, the likelihood of ECMO increases as the stat category increases. You can see here that the odds ratio for ECMO use in a stat 5 procedure is 8 times as high as those undergoing a stat category 1 procedure. So the hope is that cardiac ECMO is positively affecting survival in this patient population. This is a retrospective review from the ELSO registry attempting to answer this question. It looked at children less than 18 years old supported with ECMO due to failure to wean from cardiopulmonary bypass. The overall mortality of this group of patients was 55%. However, it's similar to the mortality reported for cardiac ECMO support of all indications. That being said, there are several single study centers that have shown that early ECMO in complex postoperative patients have resulted in improved outcomes. So to kind of look at this and to explain why single centers may have better results than just looking at the ELSO registry, I want to show you our own data. So this is looking at our own data from 2012 to 2022. We had a total of 191 cardiac ECMO runs, 80 in single ventricles and 111 in 2 ventricle patients. The initiation of ECMO was largely intra-op or shortly postoperatively. And as expected, the higher the stat category and the presence of single ventricle physiology were associated with increased use of ECMO. What's interesting to note is that our survival to discharge is higher than what's reported in ELSO. Our overall survival to discharge is 77%, with 78% survival in single ventricle and 76% in biventricular. Even looking at our most complex patient populations, the use of ECMO has notably increased our survival to discharge. So here we're just singling out our Norwood population, and that's separated by era. So we go all the way back from 2004 and to almost current in 2020. In the early era, we didn't routinely use ECMO in the post-op period, and by that mean we didn't necessarily immediately transition in the operating room from cardiopulmonary bypass to ECMO. At that time period, we were either peri-arrest or already arresting at the time of ECMO initiation. As time has gone on, we've learned that early initiation allows us to prevent organ dysfunction and the sequelae of cardiac arrest. So in the current era, we use ECMO in our Norwoods in about 53% of our Norwoods post-op. A majority of those are all converted from cardiopulmonary bypass to ECMO. We make that decision largely in the OR, or if shortly after in the ICU, or if we are starting to enter low cardiac foot syndrome, and we're seeing our inotrope need increase, our ventilator need increase, we pull the trigger for earlier initiation. And you can see as we changed our approach from era to era, we have overall been able to increase our survival. So our overall 30-day mortality decreased and our overall survival increased from 85% to 97%. Just looking at the Norwood population on ECMO, the 30-day mortality in this group was 6% with a survival to discharge of 94% with 0% interstage mortality. So there can definitely be a huge impact if ECMO is used early and appropriately in even the most complex patients. So what were our keys to success? It's luckily kind of brings together a lot of the concepts that I talked about already. But we found how to improve our outcomes is by using elective deployment, having appropriate patient selection, early investigation, and also limiting residual lesions and repairing them early as possible. Also attempting to minimize complications and minimizing our run length. And always considering the anatomy when we initiate ECMO. Future goals. So obviously we want to prove this idea that ECMO increases survival in patients with congenital heart disease. Our hope is that we can help bring together a multi-center study. A lot of what will make this possible is if we are able to streamline our approach to both initiation and management in this patient population so that we can translate that to better outcomes in our patients. That's it. Any questions? Okay. So our next speaker will be Dr. Feingold. He is our medical director of heart failure and transplant. And he is going to talk to us about a big topic of ECMO in the failing Fontan. I'll turn it over to him.
Thank you for asking me to speak. It's a privilege. I want to give kudos to Dr. Villegas for a wonderful talk and managing through that national alert sound with everybody's phone going off and not missing a beat. So I'm going to speak today about ECMO and the failing Fontan circulation. In terms of disclosures, I do have some research funding and a speaker for CareDX and some consultancies, but none of this is relevant to the talk today. So in terms of overview, we'll review the Fontan circulation, talk a bit about complications of the Fontan physiology, and then try to give some reasons for and against ECMO support for a patient with Fontan physiology. So as we've seen in a number of prior talks, these are some examples of lesions that are single ventricle congenital heart disease lesions and would lead somebody down the pathway to a Fontan. And so there's a few different varieties here, but the common issue is that there's a single ventricle capable of supporting one circulation, and I guess you have to decide, are you going to commit that to the systemic circulation or the pulmonary circulation? And because of the demands of the systemic circulation and the higher resistance, it makes more sense to do that. In terms of stage palliation, this is a cartoon diagram just showing the classic, if you will, 3 stages of single ventricle congenital heart disease palliation using hypoplastic left heart syndrome as the sort of underlying congenital lesion. And so we have the stage 1 Norwood with a BTT shunt, the Glenn stage where the SVC is anastomosed to the pulmonary arteries, and the IVC still brings venous return from the lower body that mixes with the pulmonary venous return and is directed out the aorta. And then the Fontan, which is the completion, if you will, stage where both the IVC and SVC are bringing blood directly to the pulmonary arteries without a pump, without a right ventricle, without a subpulmonary ventricle, adding to the flow into that circulation. This is most commonly done now with an extracardiac conduit, though there are other variations of this anatomy that incorporated the native right atrium in various forms, and I think arrhythmia were more predominant complications in those features. Often there's a fenestration here as well, a pop-off, if you will, to allow some flow to get from the venous phase to the arterial phase without passing through the lung circulation in times of acute increase of resistance, often around the surgical, immediate surgical phase and recovery. So talking a bit about the Fontan circulation. So I think one of the key features of this is that these individuals are at risk for pump failure. And a few reasons for this may be that commonly the systemic ventricle is a morphologic right ventricle, which is a ventricle that, simply put, I guess, is not designed to pump to, against systemic afterload for a lifetime. It's morphologically different, and in many cases will fail with systolic dysfunction over time, as well as diastolic dysfunction and inability to relax. These individuals often have multiple cardiopulmonary bypass runs to get to be a Fontan. And so, the impact of that on their myocardium may also play some role in pump failure that develops over time. Obviously, a key feature that I've already alluded to is that there's one pump for two circulatory beds, meaning the systemic and pulmonary bed. I think it's worth just taking a moment or two here to kind of look at this diagrammatically a little bit more so everybody understands what we're talking about. Essentially we have the pulmonary circuit here, the pulmonary circulation with capillary network here, as well as the body, all the organs and peripheral muscle and et cetera. And so with a Fontan, you're taking this usual setup and converting it to something that looks like this, where you have ventricular outflow into the aorta, and that has to pass here to through the systemic circuit, through the resistance vessels here, and through the capillary bed. And on that same force of return, perhaps aided by some skeletal muscle contractions in the body, which sort of force the blood back towards the heart, instead of getting a second sort of push into the lungs, it just has to continue on and go through into the lung capillary, lung resistance and capillary bed, and then eventually back to the left heart. And so, this creates significant issues. So while the Fontan is sort of the culmination stage of palliation for single ventricle congenital heart disease, by no means is it a normal circulation, or a circulation that's well suited in most individuals to healthy long-term cardiac output. And so here is a diagram from a scientific statement put out with Jack Rychik as the first author a number of years ago, and it just sort of schematically looks at the pressures and of this sort of altered physiology. And so in normal physiology, the LV would pump the blood out. You have aortic pressure here. You pass through the systemic circulation, drops down to low pressure in the right ventricle, but then is propelled again. You have this pumping force that gets the blood into the PAs and then comes back to the LA and then repeats. With Fontan, it's a bit different, meaning this section in here now, as it falls back down, it has to make its way all the way through that pulmonary circulation. And so you see here that in the cable veins, you're running at a high central venous pressure just to be able to have enough driving force to get through that second resistance of the pulmonary circulation, and then falls to the LA pressure. The other thing that we can see that happens over time is if and when systemic ventricular dysfunction develops, and it may even be diastolic dysfunction as well, but this pressure here that it drops to is actually no longer this low sort of baseline pressure, but is actually elevated as well. And so this just pushes the central venous pressure, the cable pressure, up even higher. And so in a good Fontan, the best case CVP is probably 8 to 10 millimeters of mercury, whereas normal CVP is in the 0 to 5 millimeter to mercury range. And so I think that's just important to think about that, because you're saying that in the best case, you're operating probably about 2 times normal CVP. And this is the best Fontans. There are many Fontans walking around where the CVP is 12, 13, 14, 15, and they're okay. They go on about their lives and their business, and then we start to see Fontans where they get to progressive failure and they're running CVPs that are 15 or 20, and that's when we start to think about transplant. But it is important to recognize that this CVP is markedly higher than normal, and with that there come a number of other issues and morbidities. So it needs to be this way, as we've pointed out, and yet at the same time, this is not ideal. I think one other thing just to think about again is it's good to think about where's the resistance. And so in the normal sort of physiology, resistance is at the muscular arteries to some extent and at the arterioles. And these arterioles are lined with smooth muscle cells that allow them to constrict and relax and govern the diameter of those vessels, and somewhat with the muscular arteries as well. And these are normal features of our arteries, whether they be the systemic arteries or the pulmonary arteries. And in a Fontan, so this is the site of vascular resistance in circulation. And cardiac output in a Fontan is dependent on this passive flow through the pulmonary circulation. So there's this pulmonary vascular resistance that's normal that has to be overcome. Sometimes it's worse, and we're able to overcome some of that with medication therapy, so something like sildenafil. But there's also maybe anatomic resistance to flow, right? Depending on reconstruction of pulmonary arteries, depending on the underlying native anatomy. There may be other anatomic barriers to flow, and these are sort of magnified in importance when there's not that second pump. And then I think the other aspect that's probably not as well appreciated, and I speculate, though I don't have great data to back it up, is I do wonder about systemic venous capacitance. And as we talk about this high CVP, clearly the downstream resistance will impact what that CVP is. And yet in the venous capacitance vessels here, I almost wonder if there seem to be some individuals with a Fontan where they really just trap a lot of their circulation in the venous side, and you can't really mobilize it very well. And I suspect, though I've not seen any great data to say that, there may be issues with venous capacitance where those vessels, if they had a bit more tone, you'd not leave so much volume sitting in the venous side. That is difficult to mobilize. Nonetheless, so we've covered some of these issues with respect to the Fontan circulation. We've talked about how cardiac output is dependent on flow through the pulmonary circulation, despite the usual pump assistance of a right ventricle. And so this is important again, because you can have the best systemic ventricle in the world, but if you have either anatomic obstructions or high pulmonary vascular resistance, your cardiac output is going to be limited. We talk about left heart output, equals right heart output, and if you don't have that flow through the lung bed, you can't get that flow back to the left heart to augment cardiac output as needed. And so, these are important features as well. And preload, it also matters both in terms of where the volume might be trapped, as well as not being volume down. And I think I've hit on this as well, but minor anatomic issues may not be as well tolerated. So an mild arch abnormality that in somebody with a good normal two ventricle circulation, you wouldn't go after, you probably should be thinking about in a Fontan, in this idea of wanting to promote longevity of that circulation. You want to do all you can to minimize the afterload of this ventricle. As that afterload goes up, the ventricle may become less compliant. As the ventricle becomes less compliant, it just backs everything up in terms of the PA pressures going up as well. Systemic AV valve regurgitation. So if in this case, on a hypoplast with severe TR, that will raise your atrial pressure, which again gets transmitted back to your pulmonary pressures and increases then your CVP. And so all these things feed back in a negative way. So what could go wrong with the Fontan circulation? And, I don't know, Macaulay Culkin sort of characterized this or gave a good look to it in the movies. I would say, the second, third, fourth, and fifth movies probably went wrong here. But with respect to Fontan, there's lots of things that can go wrong, lots of problems after this circulation has been in place, and some sooner and some later. So, you see the top line here is cardiovascular issues, but really, if you look down this list here, there are issues or complications or morbidities of having a Fontan physiology that span the global spectrum of organ systems, from pulmonary to lymphatics to kidney issues to liver issues, of course. And so there, to growth issues. So there are many, many, many issues, and likely this is still only an incomplete list. So what can ECMO potentially help us with? And I would argue that issues in these domains are probably things that ECMO can help us with. So there's a lot of stuff here in an individual with a Fontan that ECMO is not going to make better. And in fact, complicates our ability to support people successfully on ECMO. If somebody has, as we'll see in a bit, renal dysfunction and liver dysfunction and a bleeding tendency, they're lymphopenic and more susceptible to infection. All of these things are going to add to the difficulty of having a successful ECMO run. So, as I envision it, at least, ECMO for a Fontan is really a rescue therapy for an acute reversible event, or I guess what I would call a transitional event, meaning I can't necessarily reverse it, but I have another therapy that I can employ and bridge them to. And essentially with that, I'm thinking about a VAD and moving to a transplant if that were to be appropriate. So for instance, some people come out of the OR early after their Fontan and have low cardiac output syndrome and may not be tolerating that scenario, in which case, ECMO either may buy some time for things to cool off a bit if there's not, to investigate, is there an anatomic issue? Is there something else? Or are they just not tolerating this physiology? The systolic pump failure that I mentioned before. So, I think that ECMO and mechanical support in an individual with a Fontan is probably most well geared to this, meaning we have pumps that can provide good cardiac output, albeit, right, this should be in the setting of not having other major issues. If there's significant pulmonary artery issues, if there's significant liver disease and renal disease, again, this may not be the best background upon which to bridge somebody from ECMO to VAD to transplant. And the reality is it takes some time to sort that out. We don't always know everything about these patients when they show up in crisis. And so it does give you some opportunity, though, to let the situation cool off and see what is going on. So another complication that I didn't allude to specifically is plastic bronchitis. And so this is the formation of these casts that sort of mimic plastic that many of you are probably familiar with. And so, we've had patients here and there and have certainly heard of this, where they develop a cast in their lung and it acutely affects their saturations, and they become very cyanotic and very unwell from that. And so whether that's the etiology or there's some other form of transient lung injury that could be overcome, that might be an indication for ECMO support as a temporary support. Somebody likewise were to develop a PE that would obstruct the Fontan circuit, or a Fontan conduit obstruction. I think one time as a fellow, there was even a patient with compression or bleeding somehow around their conduit, so it compressed it from the outside. And so, all of these things would impair that individual's ability to generate cardiac output, and ECMO would potentially allow you to support them until you sorted out what's going on. And then significant, potentially life-threatening or cardiac output compromising arrhythmia. So if somebody were to develop severe dysrhythmias that didn't allow them to perfuse, again, ECMO would be a reasonable option for support, with the idea that hopefully you can treat that arrhythmia and get them back off ECMO. I looked just to double check myself, because these were sort of the things that I came up with. And I found this publication, which is, I believe, open access, which you can all access, which just sort of mimics and discusses a lot of these same issues as indications for support. And so I thought it'd be worth just showing that. I'd like to move to talking a little bit about outcomes of ECMO support for individuals with a Fontan. And there's a nice paper, although it's now a little bit dated, from 2011, with a number of members of the group from Boston Children's looking at support in individuals with Fontan. And so this looked at ELSA registry data from 1987 to 2009 and found 230 post-Fontan patients in that cohort that were supported on ECMO. And they compared survivors to non-survivors. And I'm not going to go through this whole thing, but I'll point out some things that I thought were noteworthy and interesting. So there's a 35% survival is what was observed in this cohort to hospital discharge for individuals with a Fontan supported with ECMO. And this compared to a contemporaneous overall 47% survival in that same cohort. So suggests that survival is not as good as the all-comers to ECMO. Some factors that were associated with mortality in a multivariable model included bleeding, neurologic complications, renal failure. And interestingly, I thought the duration of support was sort of an interesting set of findings. And it seemed like individuals supported in a 3 to 5 day range had the best outcomes or the lowest odds of mortality. Certainly individuals supported past, it looks like 8 or so days at 211 hours, had an increased odds of mortality based compared to the reference group of under 3 days. So, whether this means that that individuals, again, need a time to sort things out, figure out what's going on, cool things off, fix an underlying issue. And yet, if you can't find that problem, you can't fix it, you're unable to separate from ECMO as more and more time goes on, then likely it's not going to happen. Some other information from this paper that I thought was worth sharing was just thinking a little bit about, this is broken down into survivors and non-survivors. I'm less interested in that and more just sort of wanted to point out the mode of ECMO and how ECMO was employed in individuals with a Fontan. So you can see that, essentially everybody is supported by VA ECMO in this cohort, and then cannulation sites. So there's right atrium and aorta. So this, I assume, would mimic the thoracic cannulation data. So somewhere between like 60% of these patients are being supported through central ECMO is how I interpreted that. And then you can see other locations that were cannulated for ECMO. Other considerations, and I think Dr. Villegas probably discussed many of these already, but these are individuals who have had lots of prior surgeries, lots of prior caths, lots of prior lines. And so you need to be thinking and anticipating that there may be access issues and vascular occlusions that would preclude your ability to cannulate, perhaps in the locations that you first try or manner that you want. As Dr. Villegas also mentioned, was that, that may need multiple venous cannulas for adequate flow and or decompression of the venous system. So in summary, the Fontan is the final surgical stage of single ventricle palliation. I have an asterisk here because clearly as a transplant doc, I've heard that, transplant is often considered the final surgical stage of single ventricle palliation. There are important differences from typical two ventricle circulation. Commonly individuals with Fontan will develop Fontan failure with a whole host of comorbidities. Some of these are cardiovascular, some of these are non-cardiovascular morbidities, but they're all very important and impact the outcomes and survival for this population. There may be unique considerations around cannulation strategy and location given the previous issues, previous surgeries, previous cannulations. ECMO support should be thought of, in my mind, as an acute intervention for a likely reversible or treatable cause. And you may not know this when you go on ECMO, and I think that's fine, but it's important to recognize that if you've done your due diligence and your thorough investigation and there is not a reversible cause, right, that's also not a bridge to anywhere, and we must pay heed to that unfortunate outcome. So for pump failure, I think as a bridge to VAD and eventual transplantation, that may be appropriate for early post-operative support, or if there's some type of occlusion of the Fontan circuit. For arrhythmias, whether that could be treated either effectively or again transition to VAD and transplant. And if there were to be acute pulmonary respiratory compromise, that again could be overcome. And Fontan patients requiring ECMO support do seem to have a high mortality. So I thank you for your time and attention, and appreciate the opportunity, and happy to take any questions.
So up next, we have our Director of Perfusion and ECMO Services here at Children's Hospital of Pittsburgh. This is David Palmer.
Thank you. Well, thanks, Dr. Villegas. Thanks, Merit Aspenleiter, for the invitation to talk at the meeting. It's each year this just gets better and better, so this is very nice. I'm going to talk a little bit about simulation and what we're going to do this afternoon, and we have a little tomorrow for the general surgeons, and then an event on Friday. So this is more specific to what will happen in a few hours. But the objectives I have are, we try to create simulation models that mimic the real thing, that mimic the cannulation, the initiation, and the hemodynamic stability once you put somebody on ECMO. It really supports a setting of developing and mastering your clinical skills. We try to make things very real. And our hypothesis is that simulation improves the cannulation times and controls blood loss. So with some of the models, when you make a skin incision until when the cannulas are in place, we can look at how much blood loss is leaked out of the system and the time frame it takes from start to finish, and the surgeons can increase their skill set and cannulate a little bit quicker. The whole idea of simulation is, if we use this kind of depiction, ability kind of lies in the center core of knowledge, which is your didactics, your skills, your psychomotor skills, and your attitude, your effective behavior. Those three things combined really make for someone that has the ability to do just about anything. When we put somebody into a clinical situation, we can hone in on what's in the brain, what's in your hands, and what's in your heart. Competency, I think, is something that's a mixture when you're out in the profession of whatever certification you hold, whether it's if you're a perfusionist and it's through the American Board, or if you're an ECMO specialist and it's through either ELSO or it's through AMSEC. They have 2 certification exams. That all leads you down a path of being qualified for doing that skill set. And licensure is another credential that folks can get for different professions. And I see in the future that ECMO is going to be licensed. And then ability is, the subset of the other 3 domains. When you put those all together, you can start to formulate and say that somebody's competent in what they're doing. And simulation brings all that stuff together because you're able to reenact what you're going to do and practice what you're going to do. You gain experience and competency for it. The other thing with simulation, just to get on the soapbox a little bit about education, is that if you ever want to give an in-service to a group of adults, this is probably a quick list of the things that if you try to address all these talking points, you'll probably leave with good reviews of how you presented the material. The big ones that I'll go over are a needs assessment. A needs assessment is just finding out what they need to know. If they already know some of the subject matter, you going over it again is just going to bore them, and they won't take anything from the lecture that you're providing. But if you tell them what they need to know, you're going to get really good reviews. Safety in what you're doing, and simulation falls into this too. You can create a simulated event that's unsafe, that you scare students, you scare practitioners, and they stop focusing on what they're doing, and they're more worried about how you've increased the complexity, the stress of the situation. But with a simulated event, you can make it completely unstressful, and then the learning just kind of falls into place. And later on, you can increase the weight that you want somebody to bench press. You can increase the stress level based on the simulated event. Praxis is action with reflection. So adults love this. They love to think about what they're doing, reflect on it, and use that for later on when they actually have a real life event. That's the same idea as ideas, feelings, and actions. All of these different characteristics make up adult learners, which we as adults learn differently than kids that go to school. But if you do some of these things, use this reference. It's a real easy book. It speaks to all these different talking points for learning in an adult situation, which I think is simulation. This is just a quick depiction of one of the most popular models we have. It's a cervical model. So with the help of Dr. Villegas and a few others, but primarily Dr. Villegas, we've tried to focus in on that circle, that carotid area where we cannulate. So we've had 3 different revisions of it. In this last revision, we started to put a sternocleidomastoid. So when the incision is made in the carotid and you pull that sternocleidomastoid over, it exposes a capsule. So again, that's another thing we try to do, is to create that capsule. So whenever they make the incision, they go in and they isolate out the vessels. It's as realistic as we think that we can make it. So you'll get to see that. How we make this model is, I'll kind of give you the recipe. It's not really hard, but we take a skin pad. We make the skin pad and we just tie it on to any kind of mannequin. And the key is, if you use a sim baby or a sim mannequin, you can increase the fidelity of what you're doing. So you could create, a pre-arrest situation that progresses into CPR, and then it progresses into eCPR, where you have to put the patient on ECMO while you're doing compressions and while you're doing everything to bring them around. We attach this either to a pump that we have next to it, or you can attach it to the calyphia. And the calyphia is really nice because once you cannulate this and you connect it to the ECMO circuit, when you start flowing, you flow from the surgical pad into the calyphia, and it creates all the hemodynamics. So again, you set this in a whole other direction of what you're able to do. So this skin pad, we have 3 generations of this. And our focus really hasn't been on that first layer, the skin layer, although the skin layer is just, it's pale skin, and we put a mesh inside of it so that when you put this retractor, it doesn't tear. And then the second layer is a subcutaneous layer, just a real small fat layer. And we make it with these different components. If you Google these things, they're muilage. You can make anything you want with this stuff, and they're all different durometers. So the durometer is the stiffness of it. So if you get something that's very flexible and it feels like real tissue, then it's very realistic. So again, with the help of the team here, we were able to figure out what the feel was best by trial and error and getting feedback from the physicians on how to make the skin model that really works. The sternocleidomastoid is the newest thing in this. So from 17 until now, we've gone through 3 different, versions of this thing. And the focus has been more on the capsule where the blood vessels are, and then putting in this sternocleidomastoid that you pull aside. And the feedback's been it's been okay. It's been good. So how we do it is you make this little box mold, like a little jewelry box. You pour in the bottom layer, and then you put mesh inside of the bottom layer, and then you pour the fat layer, and then you pour what we would call the skin layer, or the muscle layer, but really the area that's very vascular, and that's around the blood vessels. And then we make the blood vessels by putting like a cotton kern and mantle. We take the inner core out, leave the cotton fabric, put it on a dowel rod, and then we use dragon skin, which is another one of the smooth-on products, to make the blood vessels. And then the blood vessels lay inside of those different layers. Between the second and the third generation, one of the docs that we were working with, said, I wonder if you could just put something on these blood vessels so that stuff wouldn't stick and it wouldn't be as sticky like a redo. So we started putting a silicone lubricant on it, painted on the vessels, and then that red layer doesn't stick to it, and it makes it easier to dissect, because the feedback we got from the surgeons is it was too much work and it wasn't realistic trying to get that away from the blood vessel. The other thing we do is we put a thread in between the blood vessels to mimic the vagus nerve. Hardest part is balancing this mouse. The next thing we did is we started messing around with a fish pump. So we attach a fish pump to it so it creates pulsatile flow. And then we went over to Presbyterian and we started using 3D models to put underneath them. So when you insert the cannula, you can see where the cannula is placed inside of an atrium and an aorta that we modeled through their support. This is some quick, short clips of what the cervical model looks like when it's in action, which you'll get to see in the back. You can see you can move the sternocleidomastoid down, and then you could put the sutures around the blood vessels. And that capsule is nice and clean. It's real easy to get to. But one of the first steps is to isolate out both blood vessels with a heavy black tie above and below, distal and proximal. And then they use a blue tape to tie that down so that when you go to decannulate, you can just cut the knot on top of that blue bumper. But all these little steps are great, not only for the fellows and some of the surgeons to practice their skill set, but the surgical techs and the other folks that are assisting them learn how to hand what instruments, when to hand the instruments, and what things happen in the order in order to increase the cannulation times. So when the cannula goes in, you can see that the pump makes it pretty realistic as far as controlling the blood loss. So one thing you can do is when the incision is made, until the cannulas are in place, you time that. And then you look at the bag where it's an IV bag, how much blood loss has occurred in the time that you're cannulating the patient. This is just another pic of once that cannula is in place. And this was all the arterial cannula. And you can practice the depth. And if you have the 3D model below, you can lift up the drape and see where it's placed so that anybody that doesn't understand the placement, they can see it in the 3D model. So what we believe is that our cannulation times have improved over the years because we're practicing this more. And this is just kind of the direct where our attention has been on simulation, and that neck cannulation over the years is really our big go-to. For kids, that's probably the primary way we get on ECMO. The second way that we get on ECMO is chest cannulation, and we do very limited number of femoral peripheral cannulations. So if we were going to focus our practice and our attention, it would probably be on neck, chest, and then femoral. And if you were in an adult center, their primary target is peripheral or femoral cannulation, chest, and next to no neck. So you'll see today where we have an example of neck cannulation and an example of chest cannulation. And our initiation to ECMO times, we feel have gotten better over the years. So this is just some preliminary data from the last 4 years and how our page to incision, our incision to ECMO is better than what it once was. So it's going to level off, but what we want to do is sustain that momentum so that we don't really lose any time when we're trying to get kids on ECMO. The 3D models are really pretty cool. We started to focus on just the vena cava. So there is an aorta, the aortic valve, ascending, the arch, and the descending, but we overlay the vena cava behind it so that whenever we're putting in the single style venous cannula, we can teach where the placement is the best and then use it on the model, and it's really worked out well. So this is just a quick example of the aorta, and then if we turn that over, you can see the inferior and superior vena cava on I think this was like an 8 or a 9 kilo atrium. So the crescent cannulas, the crescent RA and the crescent, have 2 different locations of where they're positioned anatomically, and you can really screw them up. And using the 3D models really helped us teach the appropriate cannulation locations for them. This is the surgical SAM, which you'll see this afternoon. This is more focused on chest cannulation. And we used some grant dollars and we're able to get this. And it's really pretty slick. It's a clean model. You replace the atrium and the aorta and you can cannulate both. And if you connect it to the clyphea, you heighten the simulation experience because you cannulate, you go on, and you see all the hemodynamics change. And we have that all set up in the back, so you'll get to see that. But we used that for the first time a couple months ago, actually a month ago in August. So we'll set that up, and it has a beating mechanism in it. So it has a general beat to it. And the atrium and the aorta are pretty good for Dr. Villegas to cannulate. So she'll show you that in a little bit. The other one that's I'll call it a dirty model because it's more set up and it's not as clean. We've done this a couple times and we didn't do it this year, but we usually do it for every simulation. It's kind of mimics the Ramphal model where you go to the slaughterhouse and you can get heart-lung block, and then you connect that with connectors to the clyphea. And then we put a party balloon inside of the left ventricle, and we use this kind of a contraption that has an actuator that pumps a bag valve mask and inflates the balloon, and it makes the heart look like it's beating. So the benefit of this is that you have real tissue that you don't have to go through any approvals because the animal was euthanized for food. So the only thing we have to do in this environment is just keep it clean. But it's like you're practicing on a piece of meat because that's what it is. So this we think has some promise because you put a cannula or a connector in the inferior vena cava and in the superior vena cava and one on the descending aorta. You connect it to the clyphea, and when you cannulate this and pump into it, it goes into the clyphea. So I think, especially with our School of Perfusion, one of the nice things about this new lab is, we got a sink in the back, which will make it easier to clean, and we could actually have a clyphea that's a dirty clyphea where we could just use this on a regular basis. This is just another of one of the years when we had this going, and it looked pretty real. And if you're going to practice sewing, you're on real tissue, and the physicians can do their thing. Perfusion can run the pump. You can give cardioplegia. You can really do a lot. But this one takes a little more practice, and we're going down the pathway of trying to do that. This is just our take preliminarily on our peripheral cannulation models, where we would use a ballistic gel. It's 10%. And you put it in crock pots, you mix in the pale skin or coloring, and then you can reuse it over and over again. You melt it down, you pour it into a mold, and then you can ultrasound this stuff. So if you put a vessel underneath it, you ultrasound it, you have to practice the dexterity of cannulating it and passing all the cannulas that we normally use. So there's other versions of this where this ballistic gel is used in other ways. But we were pretty happy that we validated the tubing that we feel has the best feel and the ballistic gel that we feel feels like skin, and you can ultrasound it. So whatever we put this in the future is what we need to kind of develop. And then we're going to try to use this on Friday, but this is that same ballistic gel that we put on the sim mannequin. So it attaches around it, and then you can cannulate this. And this is probably the first year we didn't do an eCPR demo, but with the city of Pittsburgh, we worked with them and we practiced doing a patient that would go into cardiac arrest in the field, and you would put them on ECMO and then transport them into an emergency room to show that, it's very possible here in Pittsburgh. So this is about 3 minutes, and I'll end with this. But this is a demo of one of the eCPR videos that we did. I don't know if it was last year or the year before. I don't know if the sound will come over on. So we have sound in the background. So like the radio transmission for the paramedics is all you can hear it. It's pretty cool. And then we put a clock for when the patient went down in the park until everybody arrived and, you know, we got them on ECMO. So the city of Pittsburgh is pretty unique. We did it in real time, like how long it would take for the first ambulance to arrive. And then whenever they have a cardiac arrest, they call a doc. There's a doc in the box, they call it, that goes to all the cardiac arrests in the city. And there's a supervisor, it goes, and then the rescue truck shows up and they have the Lucas device. So they put the Lucas on, and that's Lenny. He's the doc that showed up. And we trained Lenny how to cannulate with the models. So they draped, they cannulated in, you know, on Flagstaff Hill. They used a ultrasound, got the vessel, and you'll see it bleeds back. And they cannulated, and we used the cardio help that Lenny would run. We trained him how to use it. And what we were trying to do is to use this to demo what the future holds for a lot of cities across the country and across the world, but how this could be very possible here in Pittsburgh, because we have all this stuff in place. You know, they have the Lucas, they have the doctor, the fellows and the physicians that go to the site, and the training mechanism is available. And, you know, peripheral cannulation is teachable. And then the cardio help is so portable, it's very easy to get somebody on. So each time we've done this, we did it in Shenley Park, we did it on Flagstaff Hill, we did it here in the auditorium 2 years in a row. And the city medics are really good. They enjoy doing it. But this was a shortened version that Devin did for us. The long version is, you know, 40 minutes long, but we take it as far as we can, where we load the patient up, put them in the ambulance, and the ambulance goes off. So it's pretty cool. Sorry, the sound wasn't working. So in conclusion, medical simulation offers a realistic opportunity to develop and master and maintain your skills in a real stable environment. You know, the learning is optimal and you can make it any way you want. And we're constantly trying to improve on this to really create a nice educational experience that, you know, we gain experience doing it. And, you know, we want to introduce this model to others. We want to share how to make them. And what we find is we could tell everyone how to make those molds, but very infrequently do I hear people call up and say, hey, we're making them. They try to make them, but I think it's easier for them to try to buy them. But we were earlier not selling them. We make them for here. Anyways, that's our idea of simulation. Thanks.
Thank you, David. So our next session that we have planned for today is called Does This Look Right? And it's cannula positioning on ECMO. So this session is going to be led by Dr. Laura Oliveri. She is the Director of Non-Invasive Cardiac Imaging here at UPMC Children's Hospital of Pittsburgh. Along with Dr. Oliveri is going to be Amanda Brennan, who is one of our pediatric sonographers. And David Palmer is also going to assist in this session also. They're going to kind of do a combined talk and demonstration while we talk about the positioning on cannula positioning on ECMO. David will show us the 3D models and where the cannulas would be in the heart. So I'm going to go ahead and turn it over to Dr. Oliveri and Amanda.
Great, thank you so much. Amanda and I are thrilled to be here presenting some of the imaging. So this is largely, what we're about to talk about is largely after the cannula have been placed, just assessing where they are and if we're all happy with how they ended up. We have no disclosures. So because this is an ECMO course, we won't spend too long talking about what ECMO is. We'll just briefly review, and then we'll go through some cases of VA ECMO cannula placement and VV ECMO cannula placement. And I should preface that our talk is going to be completely ultrasound, echocardiography to assess any arterial or venous cannulas. So first we'll start with VA ECMO cannula placement. I'm sure this group is aware we're kind of dealing with 3 different flavors of VA ECMO. When you think about from the perspective of cannula placement, panel A is the femoral cannulation option. Panel B is the kind of open chest cannula placement option. And then C is where we largely live, I guess, at least in the pediatric hospital, assessing cannulas that are coming in from the neck for VA ECMO. So a few points when we go to do an echocardiogram on a patient on VA ECMO, these are the things that are in our minds as we acquire images and then interpret them. So first, we kind of attempt to identify and assess the venous cannula. As we talked about, it tends to come from the right neck, from the right SVC, and ideally would terminate in the mid-right atrium. Finding the tip of the cannula is an art form, and we'll convince you of that today. The arterial cannulas also usually comes in from the right neck, the right carotid, and usually terminates in the mid-transverse arch. Finding the tip of this cannula is much easier than the venous cannula. And here we usually are noting by echo the flow direction. So the flow is coming out, and is it going down the DAO, down the ascending aorta? Is it splaying or is it flowing preferentially to one side or the other? We're also noting at that point if there's any associated aortic valve insufficiency. Although not specifically associated with the cannulas themselves, it is important for us to assess. There's really no other way for this to be assessed. So it's very important for us to assess the interatrial septum. A lot of times, particularly like in acute left heart failure or left heart dysfunction, that can be associated with significant left atrial hypertension, like really malignant left atrial hypertension. And patients, if they have a small atrial septal defect, it's important for us to understand what the gradient is across it. And if they don't have one, it may be important to identify this quickly so that one can be created if needed. We do our best to, like I said, identify any septal defect. If we find one, understand what the pressure difference is between the left atrium and right atrium, which is proportional to the velocity time integral, and I'll show you that. This becomes important because the venous cannula often rests right near a tiny like patent foramen ovale or atrial septal defect that's right there. So sometimes parsing out the cannula flow from the ASD flow is, like I said, kind of an art form, but it's something that is our job to do. And then there's kind of these general assessments of atrial and ventricular size, which really reflect both the disease process, but largely the loading conditions, how high the flows are, how much preload is being taken out of the right atrium. So therefore, assessments of size on ECMO aren't really necessary. I think they should always be interpreted with a grain of salt to understand what the flows are and what the disease process is that led to ECMO being applied. And then same goes with function. And actually, some of us are even hesitant to make any remarks about function when patients are on ECMO, or at least significant ECMO support. There's really it's hard to assess contractility if there's no preload. So that's kind of sometimes we won't even comment on function because it's irrelevant what we see. All right, I think this is probably best. The concepts we talked about are probably best illustrated with cases. So we'll first talk about an infant who presents a couple weeks of life, who has a known family history of dilated cardiomyopathy and presented with respiratory distress. This is the patient's echocardiogram on the left. This is prior to any application of any ECMO therapy. This is just the presenting echocardiogram, and I think we can see there's significant chamber dilation. This is right atrium, and left ventricle. The left ventricle is barely moving, whereas the right ventricle has a little bit more contractility. applying color Doppler to the inner atrial septum, we can see what I was talking about, which is a tiny patent foramen ovale. That red flame in the middle is the gradient, or is the velocity of flow between the left and right atrium. And this, I don't have it here for you, but the measurement was really high. It was 8 to 10 as an millimeters mercury for an atrial septal gradient. This is the same patient after cannulation onto VA ECMO via the neck. So here it's the same sweep, same patient, maybe a half hour later, half hour plus minus later. So I think we can see, whoa, sorry. I think we can see up here in particular significant changes that I was talking about, kind of reflecting what loading conditions can do to the appearance of chamber size on echo. So here's the right atrium and right ventricle. If you think about what they looked like on the last one, they look very different here. And this down here is kind of it's called the subcostal sagittal sweep, where we can see at the beginning here, this is the venous cannula coming down. And sorry, I'm fighting the slides. This is the color showing, this blue color flow is the venous flow in the venous cannula back to the circuit. Okay, and that cannula was actually a bit low and kind of tenting up inferior, the most inferior part of the heart, right, just above the tricuspid valve annulus. And so we actually did an echo-guided repositioning of that cannula. I think it's there's, when the chambers are huge and the left atrium and the right atrium are really big, there's a lot of forgiveness for where you put the cannulas, at least by echo. But once you get on and flowing, obviously the heart kind of shrinks down a bit, and that forgiveness that you had becomes a lot less. And so oftentimes on these echoes that we perform after cannulation, one of, I think, the most important ways we can weigh in is looking at the atrial septal gradient like I talked about, but also looking to see, is that cannula that had been probably in good position, is it maybe a little too high or a little too low using ultrasound? So that's one example of a VA ECMO case in a baby. This is another baby. This baby was known to have enteroviral myocarditis. This is the same kind of subcostal sweep. This baby's already been cannulated onto ECMO. And again, it's the approaches from the neck. So there's a venous cannula here, which you can see the superior vena cava that terminates very beautifully in the mid-right atrium. This is right where you want to see cannulas. Looks great. This is the same baby. It's a different view where we put the ultrasound probe up on the chest and tip back towards the tricuspid valve. And this is the superior vena cava ending in the right atrium here. Again, this is beautiful. It's like a textbook position, exactly where you want to see cannulas from an imaging standpoint. This baby, the interesting part about this baby was actually their arterial cannula. So this is the left ventricle. This is the aortic valve, which isn't opening because the left ventricle is not squeezing. And then this is the ascending aorta. And what you see here is flow swirling around from the aortic, from the arterial cannula. The flow is actually directed into the ascending aorta. This is a picture of the aortic arch here. This blue continuous flow is flow from the arterial cannula that's kind of sitting right at the kind of the junction of where the carotid and the transverse arch come together. And some of the flow is kind of, it's going both down the descending and ascending, but it's kind of preferentially coming down the ascending, which we can kind of see here and here. And then this is about a week later, the same baby on ECMO, unfortunately, from an apical four-chamber. Here's the left ventricle. This is the aortic valve, and this is the ascending aorta. And this red flow is a little bit of leak of the aortic valve, aortic insufficiency. So this is something that, again, echo is useful for. You wouldn't know this was going on unless you looked for it, and may drive some decision-making regarding the length of time on ECMO, or if any interventions are needed on the aortic valve. Okay, so those were the two neonates that I had. So maybe next I'll move into a toddler. I don't know, David, if you wanted to show any neonatal cannulas before we move to toddler. Okay.
The camera will figure it out so we can
Oh.
see where, so you could see what we see. This is the atrium. So this is the ascending aorta, the arch. The aortic valve would be right here. The superior vena cava into the atrium, and the inferior vena cava, and it has that right angle takeoff. So the crescent style cannulas are designed, the crescent RA cannula are designed to go into the superior vena cava and rest in the atrium and not go into the inferior vena cava. The crescent style cannulas that are larger are designed to go into the descending aorta. So if we use it on a larger model, right here, so the superior vena cava and the inferior vena cava, the crescent style cannulas that are larger are designed to go into the inferior vena cava. So guide wire would go in first, and then it would slide into place in the inferior vena cava, in the atrium, and in the superior vena cava. But the crescent RAs are really only designed to go into the atrium, not into the inferior vena cava. And we use the 3D models to debrief after we had a case or two where we were at risk for puncturing the right atrium, because if the cannula placement would be like the older style Avalon, the Avalon in the same style is designed to go into the inferior vena cava. And if the user was putting this in thinking it was an Avalon cannula, the crescent RA has a different position in the atrium.
Cool. Thanks. Was helpful. So I have a couple more cases of VA ECMO cannulation from the neck. This is a 3-year-old boy who had had an abdominal surgery and a cardiac decompensation, and ended up cannulated on ECMO. He had significant arrhythmias and some other medical history that led to his arresting cannulation. I included this to say sometimes we don't always we vastly prefer abdominal, what we call subcostal echo views or echo views from the belly to understand the cannulas. Even when the cannulas come in from the neck, we see them better from our subcostal imaging, where the transducer is actually on the belly. But we adapt to whatever situation we are, as we all do. So in this case, we had no abdominal windows, so had to kind of assess the cannulas from apical and from the chest. And so here we can see the right atrium, right ventricle, left atrium, left ventricle. And again, this blue flow is blue flow going away up the wrong way, up the SVC in the venous cannula. And we can see that the venous cannula rests right around the foramen ovale. So again, in a great position, right in the mid-right atrium. And this is the same child where we can see up in the arch, this is the kind of the ascending aorta, transverse and descending aorta, and the arterial cannula comes down from the carotid and is just shy of the transverse arch. Again, a beautiful position. You can see all of this continuous blue flow splaying both a fair amount going down the descending, some going down the ascending, but probably to a lesser degree, which is exactly what you want to see on echo. So those were kind of the neck cannulations. I'd like to now move on to open chest cannulation. So first, we'll just go through a couple of points. The venous cannula, from our perspective from imaging, it's typically coming in anteriorly through the right atrial appendage, but the tip ends in the right atrium, or that's what we're looking to confirm by echo. For the arterial cannula, this again comes in anteriorly, and the tip should be in the ascending aorta somewhere. And it's significantly proximal to the heart compared to where the neck cannulation, arterial cannula would be. The same kind of considerations apply to an open ECMO cannulation versus a neck ECMO cannulation in terms of assessment of the atrial septum, assessment of ventricular size and function. Those are all the same things. But the cannulas are in often significantly different positions. So I'll just show you a quick case. This patient actually, the patients I've shown you up till now have actually had structurally normal hearts for the most part. This patient was born with congenital heart disease, so essentially has no right ventricle, has pulmonary atresia with intact ventricular septum, mostly intact ventricular septum, significant hypoplasia of the RV inflow, outflow, and body. So what you see here is essentially a single left ventricle, big left atrium, and then there's a right atrium that's identifiable, but no really identifiable right ventricle. And this right here is actually the cannula, the venous cannula that's kind of tucked into the right atrium, coming anteriorly through the right atrial appendage. And again, you can see it here. This is the orthogonal view. And these two bright train tracking lines here are that cannula kind of coming into the right atrium. Again, not from the neck, not from the IVC, but just coming straight in to the heart right here. With color in the same projection, we can see, again, here's the right atrium, here's the left atrium. We see two flows. We see a red flow down and a blue flow out. So we'll kind of parse them out. So this blue flow out is actually it's flow away from the right atrium in that venous cannula. And then the red flow that we see at the beginning that was coming down here, this is a tiny atrial communication. This is the large left atrium and then the kind of smaller right atrium here. So that's the essentially the atrial communication. You can see flow is essentially evacuated from LA to RA and then out the cannula. This shows the same thing. And this baby, this shows actually kind of an expert, our sonographer really did a beautiful job, I think, of parsing out the red flow down and the blue flow out to understand the gradient between the LA and RA was too high. It was a mean gradient of 9 in this case, which led to an intervention for this child. And then for the arterial cannulas, you know, these are actually, I will admit, these are a little hard to see with cardiac ultrasound with echo because there's not a huge length of cannula that's actually inside the body, surrounded by blood pool and visible for us to see. But we can see the continuous flow that emanates from it very easily. So a lot of times that's our clue, is when we see the continuous flow pick up or start as we're scanning through the ascending aorta, that's when we know, oh, yep, there's the cannula and it's in position and we see it. And that's what this echo demonstrates. Here's the aorta, the aortic valve, and you can see this blue flow, which is the arterial cannula. So I don't know if you want to pause here, David. I don't know if you want to say any words or do any demonstrations about open ECMO or what you're feeling.
We really don't have anything with a 3D
Oh, okay.
model on that.
I'll keep
but
rolling.
We will when we do the simulation at the end.
Perfect. Okay, great. Well, then we'll keep rolling, and I'd like to introduce Amanda Brennan to take us through the rest of the cases.
Thank you. Okay, so we're going to now demonstrate VA ECMO with femoral cannulation, which is a little bit more rare in our pediatric population here, but we found some good cases to share with you today. This part will just be a little bit repetitive, but the venous cannula here, though, is going to be from the femoral cannulation coming up through the IVC. The arterial cannulation is going to be best visualized from the aorta in the belly and visualizing retrograde aortic flow. And these points are similar to our others, or what we're observing on echo. The atrial septum, the atrial and ventricular sizes, and questionable assessment of function. So our first case is a 15-year-old male with myocarditis. We included the chest x-ray so you can see here the IVC cannula coming up, as well as the SVC cannula coming down, and the arterial cannula. So this was a little bit of a different scenario. They don't always have 3, but in this case we did. So here I am demonstrating this is the liver and this is the IVC, and you can appreciate the bright line in there is the cannula coming towards the right atrium. And in this bottom clip here is a subcostal sagittal view. This is the IVC coming up here, and you can see the cannula entering the right atrium. Typically, this is the SVC, and you would sometimes be able to appreciate that other cannula coming down here. It's not optimal in this patient. These windows can be a little bit trickier in our adult-sized population, but that would be a spot to look for it. This bright spot here is the SVC cannula. It's kind of an untraditional view here of a right sternal, parasternal border window where they're tilted back so they can see the SVC entering the right atrium. And on this side, you can appreciate that arterial flow coming in. Not as beautiful as the baby's arch imaging, but this would be your ascending aorta here. That's the carotid coming down with the cannula flow into the transverse and descending aorta. A second case is a 25-year-old male. He is a heart transplant patient who presented after cardiac arrest. Again, you can appreciate the IVC going through the liver here with the cannula entering the right atrium. And this is another subcostal sagittal view where you can see the brightness of the cannula coming towards the right atrium. Now we are going to present a VV ECMO case. Well, David, did you want to show anything from femoral?
Over the crescent before.
Yeah, okay. We could share the VV first if you want. So with the VV is going to be a single venous cannula with 2 lumens, 1 inflow and 1 outflow. So we evaluate the side ports for the inflow from the distal IVC and the proximal SVC. We also evaluate the outflow port, which should be in the mid-RA directed towards the tricuspid valve. This case is a 16-year-old female with strep pneumonia and respiratory failure. So here we have the IVC, and you can appreciate this flow that's a little bit turbulent and multicolored here. That would be the inflow portion of the cannula. You can almost see the spacing in the black and white between the cannula there of the holes of the flow being directed in. On the top here, you'll appreciate a subcostal sweep where we are coming up to the heart, and you can see the cannula that's in the IVC here coursing all the way through. In the bottom, this is a zoomed up view of the right atrium. Here's the cannula coming IVC to SVC this way. And on the color on the right-hand side of the screen, you can see the red jet as it comes anterior right there. That is the flow from the cannula of the outflow cannula towards the tricuspid valve. This is another view from subcostals. This is the cannula here, and this red flow is the outflow portion of the cannula with the flow directed towards the tricuspid valve. This is a good view that you can appreciate the flow in the mid-RA, which is the correct placement for the outflow. This is a parasternal long axis down towards the tricuspid valve. So you have the cannula coursing across the right atrium here, and again can appreciate the red flow that's coming at the tricuspid valve for the outflow portion of the cannula. This is a 4-year-old with trisomy 21 and respiratory failure. And in the terms of our talk, does this look right? The answer for this is no. So we wanted to include some examples of when it is useful for when the sonographer is obtaining the echo for cannula placement, on when it would be a time to notify somebody that it may not be in the right location. So this is the cannula coming into from the SVC into the RA. This red flow here is the flow that I previously stated for the outflow should be positioned mid-RA, and you can see it is basically at the mouth of the SVC to RA here. So this would be an instance where they would want to reposition this cannula to get this flow down into the mid-RA to be better directed at the tricuspid valve. This is another example of when your cannula does not look right. So this flow that's kind of swirling around here, that is similar to the last clip of the outflow not being positioned in the mid-right atrium. So this is at the mouth of the IVC to the RA, and that flow is not going to be directed right at the tricuspid valve easily because it's too close to the IVC entrance.
Okay, thank you. That was great. So just to summarize, ECHO is a great tool to utilize to assess cannula tip position. It's easy, portable, it can be brought to the patient. You don't have to bring the patient anywhere to get these images. It's real time, it's imaging as a function of time. The data sets are all change over time. So if a cannula requires repositioning in the sterile environment, that can be performed with ultrasound guidance if needed. Repeat echocardiograms are not a big deal. Again, you don't have to take the patient anywhere to get this data. It can come to the patient. So it's actually a great modality to assess cannula tip position. It's critical for those of us that do this, that assess cannula tip position. It's like critical to understand what type of cannulation we're talking about, VA, VV. If it's VA, where are the cannulas coming into the body and where should we be expecting to find them? So those are just basics of what to understand about your patient before you perform an ultrasound on that patient. I think from just an imaging technique standpoint, hopefully you saw a lot of what we showed you today weren't just little clips that were 1 or 2 beats. It was like these long clips where we swept from one side of the IVC to the other, or from one side of the aorta to the other, to understand where the cannula comes in 3D space. You want to start when you don't see it, sweep all the way through it, and then end when you don't see it. That's the optimal technique for finding the cannula tips, because it can be tricky. And then just a reminder that ECMO loading conditions really complicate assessments of size and function. So if you're an ICU person or a surgeon or anyone who works in this clinical arena, echocardiogram assessments of size and function when you're on ECMO should be taken with a grain of salt. Echo should always be used in conjunction with X-rays, which are also easy to obtain, and you can bring that modality to the patient's bedside. But we'll also hear in a little bit about CT assessment of cannulas, CT assessment of patients on ECMO, including cannula assessment in more complicated cases. So I'm not sure if there are any other comments that you'd want to make, David, regarding like VV cannulas or anything of that nature. Okay.
We have 2 single cannulas. So if you cannulate the internal jugular to the superior vena cava, you can see how it comes down into the atrium. And then if you femorally cannulate and you come up, you can cannulate that, and you can see on the 3D model the appropriate positions for both. The cannulas for the drainage, or the inflow, if you're doing veno, this cannula can be used for femoral cannulation or jugular drainage. This one right here, you can see that has side holes on it. This is a biomedicus cannula. And then a standard femoral venous drainage cannula from biomedicus looks like this. And we can also, they come with side holes that are on the way up. And there was a talk earlier that spoke about the flow dynamics and the drainage ports on the cannula before you get to the distal end, that it's actually pretty high here. But this is all placed in the inferior vena cava, and it slides up into position into the atrium, and the dilator is removed. And the cannula can be positioned in the mid-atrium for drainage, or it can be further in the inferior vena cava.
I think that's great. I love watching, I mean, obviously I love imaging, but I love watching you like manage the cannula position within the 3D model, because I think about what the echo looks like as we do that. And especially and particularly as you unload the heart and you think you're in a certain spot and then you unload the heart and then you're in a different spot. So I think these are important elements to remember as we take care of these patients, and especially for us in imaging. All right, thank you. Thanks for your attention.
Thank you, that was really great. Thank you so much. Thank you, Laura, Amanda, and David. Next, in kind of keeping with our imaging for ECMO patients, we have Dr. Tariq Al-Saeed coming up. He's another one of our cardiologists here. And he's going to talk to us about the use of chest CT angiogram in pediatric ECMO patients.
Thanks, Merit, and thanks, everyone. It's my real pleasure to be here today to talk to you. So we'll start with a case presentation of a patient, Johnny, who just got cannulated to ECMO. However, the flows are not going well despite good cannula position. So the team is concerned about a clot on the cannula or a pulmonary embolism, and they decided to go ahead and get a CT angiogram. And in the next 10 minutes, we will talk about how we can get a successful CT angiogram in a patient who's on ECMO. So you can see here in the CT room, it can get really crowded when there is the ECMO circuit. So the objectives of this talk is to talk about the indications for CT angiogram. Then we'll talk about the challenges for doing a CT angiogram on ECMO. And finally, we'll talk about some steps to make it a successful CT angiogram and acquisition. Regarding the indications of CT angiogram on ECMO, CT angiogram in general provides excellent spatial resolution, which provides excellent identification of the cannula malposition. It can also identify any thrombus around the cannula or pulmonary embolism. It's also very useful to evaluate for preoperative VAD planning, identification of anatomical lesions, detailed evaluation of lung parenchyma, and aortopulmonary collaterals, including BTT shunts, and finally, evaluation of the sternum or the cannula for any infection. So this is how the images of the CT angiogram look, and this is a 3D reconstruction of a baby who's on ECMO. And you can see with this 3D reconstruction, you can see the venous cannula coming in here, and then you can also see the arterial cannula beautifully coming in here. However, also in this baby, you can see that there is a lesion here on the aortic arch. So this baby had coarctation of the aorta. And then when you look at the source imaging here, you can also see that there is coarctation of the aorta, and you can see the cannulas beautifully. This is another example of a CT angiogram from a patient with dilated cardiomyopathy. And you can see the cannula nicely coming into the right atrium. But then the reason that they got this CT angiogram is that we were considering doing a ventricular assist device. So you can see the heart position in the chest, and also our engineers will help us do like virtual fitting of the ventricular assist device in these patients. Now, although the CT have a significant role in patients with ECMO, we reserve it for only serious issues related to ECMO. And the reason for that is that you need to transport the patient to the CT scanner as opposed to the echo where it can come to the patient, or the X-ray where they can do it portable at the bedside. And also there is some exposure to radiation with CT scan. So just quickly to review, how does the CT work generally? So we inject the contrast, typically in a peripheral IV or a PICC line, and then we image when the contrast is in the structure of interest, and the table will have to move to cover the imaging field of view. The typical challenges with the CT scan is that it needs transportation of the patient to the CT scanner, which on ECMO will take about an hour or so to get the patient from the ICU to radiology and to position the patient. Also, sometimes we have altered anatomy in some of our patients. The contrast timing can be challenging on ECMO, as the contrast may get siphoned into the circuit, and thus we may not see the area of interest. And then the CT table motion may dislodge the cannula, and this is a very serious consideration. So in order to make the CT a success, we first, our step one is to call you back and ask, why are you ordering the CT? What's the question? Could that question be answered by other modalities like X-ray or echocardiogram? And is the information going to change the management of the patient? And also we will ask you where the cannulas are. So that's very important for us in CT, as it is important for us when we're imaging by echo as well. And then the second question we will ask you is that, can we turn the ECMO off for like 30 seconds to get the CT, or does the ECMO need absolutely to be on all the time? So could the ECMO be clamped, and what's the structure of interest? And the reason we ask about that is, like, this is a case example. So this is a cross-section of a CT scan in a patient on ECMO. This is the superior vena cava. You see how bright it is. This is the aorta. You see also how bright it is. And then you can see that the pulmonary artery did not turn out very bright. And the reason they got the CT is to rule out a pulmonary embolism. So the reason for that is that the contrast got siphoned or suctioned by the ECMO venous cannula and was, was returned back through the arterial cannula. So the aorta looks very bright, but then it bypassed the pulmonary artery, and that's why the pulmonary artery does not look bright at all. And for us who do imaging, it's impossible to tell if there is a pulmonary embolism or not. So if we don't clamp in this case, we will end up with a non-diagnostic test after all the work we have done to try to get the patient to the scanner. The solution for that is discussing with the ECMO team and see if we can just clamp that ECMO circuit for about 30 seconds. So this is what we did. We repeated it with clamping, and you can see that the contrast now is filling the pulmonary arteries very nicely. And now we can tell that there is no significant pulmonary embolism in this patient. Now, for the aorta, if the question is the aorta, you can actually inject through the arterial cannula without clamping, and this also works for BTT shunt. So this is an example where we injected in the arterial cannula, and you can see that we filled the aorta with contrast beautifully. So we didn't have to clamp the ECMO for this indication. So to summarize this point too, about if the ECMO is on or off, so if the ECMO has to stay on, the contrast will get suctioned or siphoned off in the ECMO circuit. And the solution for that is to try to inject through the arterial cannula, especially if the question is about a problem in the aorta. If the ECMO can be off or slowed, then we can just get a routine CT or CTA, and we inject usually through a standard line, either a PICC line or a peripheral IV. So the step 3 is, how are we going to time the scan in order to get the contrast into the structure of interest? So that depends on the location of the contrast injection. Are we injecting in an IV, a peripheral IV, or are we injecting in the ECMO cannula? And then the time required of the contrast agent to travel to the vessel of interest. So in order to get a diagnostic imaging, we do like a special type of triggering called manual triggering of the image. And what that means is that we get just one slice of that CT and we watch it over time as the contrast is coming in. So you can see we take a picture every second here until we are happy that there is a lot of contrast in the structure of interest. And at that time, we go ahead and tell the tech to get the entire CT at that time. And this is how we get a successful CT scan in a patient on ECMO. We have like standard numbers, so we don't have to do it in patients without ECMO because we know when the contrast will be in the structures of interest. But on a patient with on ECMO, we need to do like this manual triggering in order to opacify the structures with contrast. And finally, we need, like, now that we got the patient to the CT, we need to position the patient and we need to communicate that the table will move quickly. So we try to communicate to the ECMO team and the perfusionist that the table will move very quickly so everyone is prepared. And we try to perform the scan when many techs are available to help. And in this case, we need to think negative. So that, that ECMO cannula can dislodge in the CT scanner. So I know we're all positive people. This is a situation where we really need to think that bad things can happen, and we need to act positively and proactively to prevent that from happening. So this is our checklist for CT on ECMO. Over the last 10 minutes, we covered that we need to understand the locations and the flow of the ECMO. We need coordination with the clinical team and the perfusionists. And we need to ask the question, can the ECMO be clamped for typically 30 seconds? The systemic circulation can be seen with injection through the arterial cannula, while the pulmonary circulation is best seen with a pause or slowing of the ECMO. And we really need to ensure that there is no dislodgement of ECMO cannulas during the CT table movement, which is vital. And with that, I would like to thank all of you, and I would like to thank our wonderful ECMO team and our wonderful Echo Lab, and thank you.
Thank you so much. Thank you, Tarek. We're going to take a quick 5 to 10 minute break so we can have a quick turnaround and set up for our simulations. So up next, we'll have our cervical simulation, and then we'll do the open chest cannulation. So just give us 5 or 10 quick minutes to get the rest of that stuff set up, and then we'll be back. Okay, we're ready to get started with our first simulation this afternoon. Our first simulation is going to be with our cervical pad simulation model. Dr. Villegas is going to cannulate a neonatal sized baby. We have Emily McCrae, who's one of our senior CVOR surgical technicians here to help her cannulate. So we're going to go ahead and get started. Dr. Villegas, we're ready for you whenever you're ready.
Okay, so it's hard to tell, at least by the camera. For the students that are here, it's covered. I just want to show you how we set up our models. So we've draped this out sterilely like this is a real baby. But our little cannulation pad is up here next to the neck. And because we like to make things as real as possible, we've even done it in the NICU bed. Using the exact same thing that we use to... She does this in OR for me too. Using the exact same things that we would normally use for a real cannulation. Okay. So once we're prepped up, I don't know what. Once we're prepped and draped. Sorry. Clip it to her mask. Maybe clip it to her mask.
Dr. Villegas doesn't typically operate with a hot mic, so we're just trying to get things adjusted for her.
Is that better? Yes. All right, sorry. So everything is prepped and draped like we normally would.
We're just working to get our mic back up.
All right, so we usually have suction in the bovie here. Hopefully this kid will bleed a little bit, but not as much as normal. So when we make our incision, we make a transverse incision. You can pretend like the clavicle is here, and I usually go about 1.5 finger breadths above. Do you have a wheat light? Next, we spread the skin. The next layer that you're gonna get to is the
take the lines
platysma.
whenever you're ready.
I have a pickup. Pick up and I'll take the knife again. And this is another layer of fat that we're cutting through. The next layer that we reach is the sternocleidomastoid. David talked about it earlier, how he has really tried to make this as lifelike as possible, which is excellent for teaching. Here we go. So obviously our plan is to find the carotid sheath that lies right behind the sternocleidomastoid. So here you can see I've already encountered one of the vessels. So this looks like, because it's pulsatile, the carotid artery. Over more laterally is the vein. You want to dissect enough of both of these vessels out so you can easily have proximal and distal control of them. You never want to be in a situation where you're working in a tiny hole, and if there's any vessel injury, you can't get control of either side, because that can be a disaster in a patient that is already struggling. So here I'm taking the right angle, and I'm going to get around the internal jugular vein. Emily's going to hand me a silk. Okay. So I'll put one proximally and one distally. Next, same thing for the carotid artery. Same thing, you want to dissect this out. You also don't want to end up cannulating these vessels too close to the thoracic inlet. That can lead to a disaster because you can quickly lose control that way. as well, especially when these vessels want to retract. All right, you have a vessel.
Yeah. Can I get the camera? Oh, okay.
You have the vessel loop?
Yeah, sorry.
So we tie off these vessels distally. We usually put a vessel loop spacer in between. That way, when it comes time for decannulation, we're not destroying the vessels. Same with the vein. Can you guys see well what I'm doing? My hand's getting in the way. Good. Pick up. All right. So I usually start, you can start with whichever vessel you want, whatever is easier. Just try to do whichever one you do first, make sure it's not getting in the way. Canula. So this is the vessel. I usually have my assistant hold up on the vessel so that it doesn't bleed. Make an incision. As you can see, it's bleeding. It's harder to do this, obviously, because what the vessels here are made of is harder than an actual vessel. So if you hold up on a vessel like this, it will definitely close off. You have the vessel loop. We also, if this is a controlled situation and we're able to, we also put a vessel loop down here as well. That way we aren't losing any vessel in the process. Tie around the vessel or tie around the cannula to make sure that it does not come out. Scissors. This kid is robust, so it's bleeding back at us. So wear the cannula. Let it sit. Right. Now we'll do the vein. Need another pickup. So again, I'm just trying to make sure that I have enough vessel in between, and then I'm going to have enough vessel to repair, and then also something to grab onto if I somehow lose control. Okay, I'm going to have Emily relax the silk. This is very crystalloid blood. Can you hold that? Glittery, extra special kind of blood. You have more vessel loop or no?
You want it?
That's okay. Normally I'd put a vessel loop there. We're bleeding pink, purple Kool-Aid, so we'll just tie it down. And same thing, we'll de-air the cannula. Oops. And then circuit has already been clamped and divided for me. And then we'll connect up the circuit. Same with the arterial side. And then we'll unclamp and go on. Okay. Scissors. Once we're done, we get rid of all of these silks. It's usually pretty hemostatic, but obviously the goal is to make sure that we have hemostasis because you don't want to be coming back in the middle of the night for any bleeding. And you want to make sure that all the ties and everything that you put around the vessel are adequate. Adequate, even enough for a patient to be moved to a CT scanner or wherever else this patient may end up. So that's it. And then we usually just close the incision with some interrupted nylon sutures and secure both of these cannulas at the level of the skin on the neck with some 2O silks. That's it. Okay. Let me have the clamps because I think
I think I was muted. Oh yeah, sorry. So everybody here was listening to me talk, but nobody on the other end of the Zoom could hear me. So we're gonna go ahead and move a couple things around. We're not gonna go to a break. I'm just gonna kind of talk about some of the behind the scenes stuff that happens when we're doing these cannula simulations. We like to really focus in on the process of cannulation. So what we lose when we're doing that is an opportunity for everybody to see what everybody else is doing to get things ready for the simulation. So we have our ECMO team in the background. We have a pump that is an exact replica of what we would use on this size baby. So we use this also as an opportunity for people to train, do their competencies. They can prime the pump. They can use our bag of fake blood and blood prime the pump, hand up the lines. Those are all the things that kind of get missed when we're doing the simulations sometimes. There's also all the effort that it takes for Emily to set up her table. You know, and she does it so quickly and beautifully with such ease that it kind of is a lost art that we don't actually get to see, but she really does a good job of getting everything set up and knowing exactly what Dr. Villegas needs before she even asks for it. So those are some of the things that we miss when we're doing these simulations. Some of the other things that we miss when we're doing something like this, particularly when we're live streaming, is all of the effort that goes into organizing the equipment, not only the simulation equipment, but the cameras, the audio, the lighting, all of that stuff, nobody gets to see other than the people that are here in the auditorium. So we're very fortunate to have on our team one of our casual ECMO specialists, Devin Corboy. Devin actually has his own video production company. So we're really lucky because we have him here with us and he helps he organizes all of that stuff. So what you guys can't see right now is he's over there resetting his camera, resetting the lighting. We're getting our ECMO pump all packaged back up so we can go on with this other simulation model. Emily's moving her stuff around so that she can get set up to cannulate this baby open chested. David's over there helping to get the suction set up, get the baby positioned, all so that we can provide this simulation opportunity, not only for our team here, but so that you guys can see it on the other end of the Zoom, wherever it is that you are. So those are the kind of the things that get a little bit lost when we do these simulations. And even at that, they do it so quickly. I think I've been up here maybe 3 minutes and we're almost set. Whenever Devin gives me a thumbs up, I'm hoping maybe in a minute or two because I'm not real good at just chatting, which I know most people find that hard to believe. However, it is a little bit difficult to do. We do have some new team members, like I mentioned earlier when I was talking, that this is a great opportunity for them to kind of go through the process without feeling terribly pressured. They can go through the steps of priming, go through the steps of blood priming, handing up the lines, making sure they don't contaminate anything, even though it's not a true sterile setup. Practicing those steps, particularly in a low stress environment, just helps to build comfortability, increase confidence, and that's another way that we like to really work to build confidence, competence, and build a strong team so that we're ready when whenever anybody needs to go on ECMO. I unfortunately don't have my iPad up here, so I'm not sure if there have been any questions that have come in the chat. However, all questions that do come in the chat, I am writing those down, and I will get answers for those. Even if they don't come through on the chat, I will make sure that I email you. I'll email you, thank you, Kurt, an answer to any of your questions. Some of the questions that are on here, I don't have the answer to, I would need to consult a physician. So that's why I haven't answered some of those yet, but I do have them all logged, and I will get answers to everybody who asked questions. A couple other things just to address is I'm getting a lot of emails about, are there going to be recordings available after the conference? And the answer to that is yes. We've partnered with the Congenital Heart Academy for this conference. So all of the talks, simulations, everything will be available via their YouTube channel. I will send the links out a little bit closer to the end of the conference, and I'll also review with everybody how to claim their credits for the conference. One of the things I always do point out, I'll point it out now and then again at the end, is anybody that's a perfusionist, please email me privately that you're a perfusionist and you need the certificate for the ABCP points. Our CEUs are calculated a little bit differently than everybody else's. So we do a separate certificate for anybody that's a CCP. Unfortunately, the CCEHS office doesn't have a spot for you to select perfusionist in your occupation. So that's why I need everybody to just shoot me out an email saying, hey, I'm a perfusionist. And then I'll know to get you your ABCP certification for the credits for the meeting. We did get approved for 20.8 Category 1 CEUs, if anybody is curious. And Ron Snyder, if you're listening, I know you want the breakdown by days and I don't have it yet. So as soon as I get that, I promise I'll get it out to you because I know you like to fill out your Category 1 CEUs as soon as you get them. So I think we're just about set over here. I'm gonna have Megan, if she can, flip the camera back to the wide angle so people can kind of see what is happening over there behind the scenes.
Too much?
So there's some of the stuff that's going on right now, as you see Devin setting the camera so that we get a great view of that open chest cannulation by Dr. Villegas. We have perfusion students from the University of Pittsburgh Shadyside School of Cardiovascular Perfusion that are here watching the cannulations and watching the conference with us live, which is always a nice opportunity for them to be able to come here and participate in the conference with us. And I think we're almost ready. I think Devin's just making some last minute adjustments, and we're gonna go ahead and switch on over there in just a couple of minutes. So I do see one of the questions that did come in regarding simulation. Do we have a budget for our simulation program? And do we have a designated FTE for people working on the simulation team? So the big answer to that is no. We are lucky enough to have a great foundation that offers support for simulation equipment that we need. We had a very generous foundation donor that gave us money to be able to go towards the surgical SAM simulator, which we are tremendously thankful for. We do have a small fund that we use specifically for simulation equipment, but we don't really have anything dedicated for that. We don't have a dedicated FTE for simulation, although that would be nice. So if any of our leaders are listening, that would be really great. I think we're ready to go back over to Dr. Villegas and Emily to go ahead and cannulate that surgical SAM model.
All right, so most of the time, if we're ever doing central ECMO, it's usually in a kid that is not that far from being post-op. However, there have been instances in which, we could get kids that are prior, small bowel transplants that have lost access everywhere, that arrest, and they really have no other access. Or if there's something that happens with one of the two vessels and there's difficulty, there have been times where we have converted from neck midway through to chest. So we're really excited to have this model. It's very lifelike. Here we've draped everything out. This is the sternum. I know it's really hard to tell. End of the rib cage here and the abdomen is here. So I'm just going to make an incision. And this does actually kind of feel like skin. And you drop back in. No, you don't have to use a saw. So the sternum is already apart. But yes, in real life, a saw. Is our sternal retractor. And here you can already see the heart beating here. It's very much real, looks like real life. You have the right ventricle here, the pulmonary artery here. Here you have the aorta and the aortic arch. If you guys want to come around on the front, you can also see if you want. And then over to the side here, can I get a DeBakey? You'll be able to see the right atrium and the right atrial appendage. So it's very cool, very lifelike. You can see head vessels coming off and everything. So usually once you're in the chest, half the time, honestly, when you're doing this, someone is doing some type of internal cardiac massage. But you want to cannulate the aorta. In our immediate postoperative patients, we often, that we leave the chest open on, we actually leave these purse strings behind in case this happens, because we suspect that they'll be mildly unstable, and this just decreases the time necessary, especially in an arrest situation. So I put a purse string in the aorta. Emily's actually doing two jobs. She's doing her own job plus the job of an assistant, so she is pretty impressive. The next purse string goes into the right atrium. So here you can see the right atrium. This is the right atrial appendage. I'll place a purse string here as well. And it is pretty lifelike, especially with what David has us hooked up to, because as you can see, even my needle holes are bleeding like they would in a normal patient. All right. Next. Mid shooting. We cannulate the aorta. That definitely feels very similar to what the aorta feels like. Emily, I need you. This patient's blood pressure is like 130. David, can you turn down the pressure?
That's another nice feature of the simulator. We can adjust the pressure on the fly
Thank you.
to accommodate our CT surgeons.
Thank God. Unfortunately, that does not come on patients. Anyway, next we'll make a small hole in the right atrium. Use
This really is a nice testament to Emily's abilities. Dr. Villegas has verbalized not much to Emily, yet she has everything ready for her when she needs it. It's very important to have a scrub tech that's in sync with your surgeon.
All right.
No, can I get a quarter connector?
So now we have the aorta cannulated, the right atrium cannulated. We're just missing a quarter connector, which is coming. All right, then we're going to release all of our clamps and connect the arterial. Jesus Christ. All right, you can go on pump. Okay, so now we're flowing. I'll let David speak to all the manipulations he can make with the calyphia. David, that's you. Okay. Here, David, I want you to talk about all the manipulations that you can make using the calyphia. Yeah.
The calyphia is really nice because when you go on, it automatically will, when the flow increases on the ECMO circuit, it will change the hemodynamics in sync with the flow as it increases. So in the calyphia, you can put the size of the patient, height and weight, and then it automatically calibrates, and it has a ventilator on it. It has a lung that you can make very sick, real-time blood gases. We just changed the FiO2 and the sweep gas when we went on ECMO, and then the blood gases will change in sync. You can put any kind of monitors you want up if you want to put the Invos, or we have cerebral venous sats. So we have the saturation now on the venous drainage is 79, the arterial saturation is 100%, and our flow right now is half a liter. So you could see all this stuff change in real time.
And then once we're done with cannulation, the way that we close, we use which I'm not going to show you here, but where we affix all the cannulas to the chest, just like that. You can see that sometimes there can be, especially in smaller babies, positional issues with these cannulas, whether it's hitting the back wall or the direction in which it's going. So all of those things will make a difference. So you have to keep that in mind. And then same thing with the venous. Sometimes the venous can twist a little bit. You just want to be cautious and try to make it as best as you can when you leave. But then once we're done, we sew a small silastic patch to the front, make sure everything's secured, and leave behind a couple chest tubes. And that's it. Any questions?
Thank you, Dr. Villegas. So that concludes our program for today. We hope you guys all enjoyed it. We'll be starting again tomorrow around 10:30 in the morning. There may be a slight delay. We do apologize for that. There's the room that we're currently in has another meeting in here before us. So we'll get in here and get set up and get started as close to 10:30 as we possibly can. Thank you all for tuning in, and we'll see you tomorrow.
Oh, man.